Okay, but come 9-5 start here.
Good morning, all. Welcome to yet another session of CSIK. We'll start in a couple of minutes. We are starting our first session. It's elementary. I invite the chairpersons, Dr. Annu Jose, Dr. Deepak Davidson, Dr. Girish PV, Dr. Vinod Thomas. Dr. Girish PV and Vinod Thomas will come to the dais and occupy the chairs. Sorry, Dr. Annu Jose also will join us on the dais, and Deepak Davidson will join us on online. Moving to the first presentation, Challenges of HOFA Primary PCI, The Night Manager by Dr. Sivaprasad K.
Respected chairpersons and my dear colleagues, we all thanks to Dr. Sulfi sir and his wonderful team for this opportunity. We all know that establishing early reflow is the essence of management of STEMI, which will reduce the mortality and morbidity of STEMI. Maintaining a STEMI network with high standard of care is a major public health challenge in any healthcare system in the world. Prior data on off-time PCI. Off-time PCI means, off-hour PCI means the PCI done beyond 6 p.m. to 8 a.m. and on holidays. Prior data shows that there was higher mortality in off-hour PCI, and these results are considered conflicting because the studies often compared heterogeneous healthcare systems. But what are the potential challenges which led to the higher mortality in off-hour PCI? One, the lower likelihood of receiving evidence-based treatment, longer presentation time, lower successfulness of PCI, unbalanced portion of sickest patients coming in the odd hours, unsuitably skilled or insufficient coronary staff, lower availability of cardiologists as per the local systems, and limited Cath Lab facilities. All are challenges which can attribute to a bad outcome. What is important in PCI is the time. Symptom onset to first medical contact to the sheath insertion to angioplasty. All these things can get delayed at various sections. But first is the most important factor, the patient-related time, and others are related to transfer and the PCI time. We understand that each 30-minute delay in door-to-reperfusion time is associated with 30% increase in the in-hospital mortality. One of the earliest trials which looked into the difference in the outcome between the presentations between 8 and 6 p.m. and 6 p.m. to 8 a.m. found that there is increase in the failed angioplasty rate nearly 2 times, and also the mortality nearly 2 times in the presentation in the order of hours. And another trial which looked into the poor prognosis of patients in off-hour PCI group found that there is increased occurrence of younger age group, males, smokers, and higher cardiogenic shock, more multivessel disease, less use of IVUS and mechanical thrombectomy devices, lower TIMI3 flow achievement after PCI, and higher TIMI0 flow after PCI, and high incidence of dissection. All were contributed to an increased occurrence of adverse factors. But the authors also concluded that biological factors also may play a role in this adverse outcome. And one of the trials which later came, that is Horizon MA sub-study, which looked into this controversy and found out that even after prolonged door-to-balloon time or symptom onset to balloon time, there is no difference in the short-term and long-term survival as far as on-hour or off-hour PCI is concerned. Another large trial which analyzed the 39 studies and produced a meta-analysis found that there is no difference in the time intervals, but the outcome, short-term, mid-term, and long-term, even 3 to 4 years, the outcomes are not entirely different from what we get in regular PCA hours. Recently, last 5 years, I have taken certain trials which occurred, which were published in the last 5 years, found that 2017, 2019, all the trials have shown that there is no difference in the hospital mortality, irrespective of whether there is time delay or not. Most of the trials trials in Swedish registry, Tehran, and then the France study all showed that there is no difference in the outcome. Again, another recent trial, 2019, 2,167 patients also did not show any difference in the mortality. Whereas the 3 trials which was published in 2020 and 2021 in the COVID era found that there is a marginal increase in the mortality. That is in the latest 2021 Chinese trial, which shows the mortality odds ratio 1.14 versus 1.16, producing 14% and 16% increase in the in-hospital and 7-day mortality. Whereas the MAN study in Portuguese did not show any difference, whereas Tokarev study from Poland showed a marginal difference in the increase in the mortality in the off-over group. So the debate is not yet settled. But what we can conclude is that a well-organized primary PCI program in a PCI expert center providing 24-hour into 7-hour expertise can provide results which are similar in mortality and outcome as per a regular hour PCI. So where remains challenges which are to be addressed are setting up a well-organized primary PCI program, then reducing the time intervals by increasing the public awareness and improving the transport, and providing an advanced care mobile intensive care ambulance, and also a PCI center with appropriate, timely, and adequate capability to perform an emergency PCI, that is improving the expertise of the team. Thank you very much for the patient listening.
Thank you, sir. We'll have the discussion at the end of the session. So moving on to the next presentation, Echocardiography in TAPVC, a roadmap for diagnosis. It is a live presentation by Dr. Kumar KH.
A warm good morning to all of you. So the topic today given to me is echo in TAPVC. As you know, it's one of the commonest critical heart disease in newborn, and a diagnosis would definitely save a life. So I have tried to make the talk simple and without much complications, and mainly aiming at the cardiology residents and the budding cardiologists who should identify how to diagnose the condition. So let us just go through the basic anatomy and the pathophysiology of TAPVC. As you know, there are 4 types. You have a supracardiac TAPVC where your vertical vein drains into the SVC. You have a cardiac type where the drainage from the common chamber comes to the right atrium directly, or it enters the coronary sinus. So in the cardiac TAPVC, the interesting thing is that you don't have a separate vertical vein for the drainage of the pulmonary veins. And you have the infracardiac type where the vertical vein joins the portal system or the hepatic veins or the IVC. So there is definitely an RARV dilatation. In effect, physiologically, if you see, it acts like a large ASD. The entire cardiac output from the pulmonary veins has to come to the right atrium, and then only it can go to the left atrium. So definitely there is an RARV dilatation. In appearance, the LV and the LA are underfilled, and they appear relatively small when compared to the dilated RA and RV. You have pulmonary hypertension of varying degree, which is secondary to the pulmonary venous hypertension. So that depends upon your site of obstruction. The commonest site of obstruction is at the restrictive PFO or a small ASD, where the entire cardiac output has to go to the left atrium. So that's the commonest site where you have an obstruction. You can also have an obstruction in the vertical vein at the drainage site or in the individual pulmonary veins. Interestingly, the infracardiac TAPVC by itself, just by virtue of its nature of drainage, has got obstruction, because it has to either go through the entire levan parenchyma when it drains into the portal system, or into one of the smaller hepatic veins or an IVZ, where naturally it is an obstructive physiology. So intracardiac TAPVC almost always have a obstructive component, and that's why the babies with infracardiac TAPVC often present very sick. We also have an obligatory right to left shunt across the ASD or the PFO, because the entire cardiac output coming to the right atrium, there is no other way. You have to go through the PFO or the ASD to enter into the LA. So there is an obligatory right left shunt. But the commonest misdiagnosis in this situation is a PPHN. You have an RARV dilatation, severe pulmonary hypertension, and right left shunting across the ASD in a newborn. The commonest mislabeled diagnosis for a TAPVC is PPHN. Second thing, very rarely we have seen babies being referred as HLHS. That's because of the relatively small size of the LALV and the dilated RARV and the pulmonary hypertension, which tend to make such a labeling. An important thing which we note here is, in an HLHS, when you have LA hypertension, the shunting across the ASD will be almost always left-right. It cannot be right-left. But in a TAPVC, it has to be right-left. That's one clue where you can identify that it's not an HLHS, there is something else going on. So once you suspect TAPVC, the next aim is to identify where is the common chamber. And one view which can do that is the apical 4-chamber view. When you tilt slightly anteriorly, opening up the aorta, not the typical 5-chamber view, you can see a common chamber behind the left atrium. It might mimic a pericardial effusion, but once you put in the color, you can see the pulmonary veins draining into it. So that's the first clue that you might be dealing with a common chamber. This is the subcostal short axis view. All adult cardiac residents should learn the subcostal views. This is one of the best views where we can demonstrate the vertical vein and the anomalies of the TAPVC in a newborn. The probe has to be held vertical with the pointer facing down. So this panel shows a normal baby's echo, where you can see a right atrium, you can see the left atrium, which is reasonably big, you see the SVC flows, and you see the RPA. So there are two chambers by the side of the RA, the LA and the RPA. In a baby with TAPVC, interestingly, you can see a very much dilated right atrium when compared to the normal size right atrium. The LA is squished and it is reduced in size. You can see the RPA here, and there you can see one more chamber in between the RPA and the LA, which is the common chamber. And you can see an ASD, which is the where I have placed the arrow, is completely shunting right to left. So this sort of a configuration where you see an additional chamber in the subcostal short axis view in between the RPA and the left atrium, one should suspect TAPVC. The classical view to show the common chamber and the pulmonary veins is the parasternal short axis view or the suprasternal view, which is the classical view to demonstrate the left atrium. So the same view can be used to demonstrate the common chamber and the draining pulmonary veins. This is the best view to identify that, and we can see beautifully the pulmonary veins draining into the common chamber. You have seen the pulmonary artery here, the SVC here, and the aorta in between the SVC and PA. So this is the classical suprasternal or the parasternal short axis view, which we usually use to demonstrate the left atrium. The same view can be used to demonstrate the common chamber and the pulmonary veins. So the next aim, we should identify where it is draining. So in case of supracardiac TAPVC, the best view is the suprasternal view. In suprasternal view, you can see a vertical vein which drains from the common chamber into the innominate vein. This is an angiographic correlate of the same, where you can see after the PA injection, you can see the vertical vein draining into the innominate and lighting up the SVC. So the same picture is depicted here. We do not do angiograms to diagnose TAPVC, which can be easily diagnosed by echo. This was done for some other purpose, but I thought it would be a good image to show. It can be easily correlated with the echo image. And this is another example of a supracardiac TAPVC, where you see the common chamber draining via the vertical vein directly into the SVC. It doesn't go to the innominate vein. So the drainage of the vertical vein in a supracardiac TAPVC can be into the innominate vein via the vertical vein. The vertical vein also can join the SVC at various levels. So here you can see the common chamber draining directly into the dilated SVC. what are the other clues in supracardiac TAPVC? In the subcostal view, the other clue is a brisk flows in the SVC. The SVC will be dilated and shows very brisk venous return. So that's one clue that there is something draining into the SVC wherever it is, either to the innominate vein or high, mid or low SVC. In infracardiac TAPVC, you demonstrate the vertical vein by the subcostal short axis. You see a large channel that comes in between the aorta and the right atrium. So one thing we should remember is that you should do the imaging at a very low velocity scales. You have to bring down the scale to 20 or 30 so that you can bring up this imaging. Otherwise, we can entirely miss the channel. And for coronary sinus TAPVC, the best view is the four-chamber view, where you dip posteriorly to open up the coronary sinus. You can see the large venous drainage which is coming into the coronary sinus, which is very dilated. And same view in the subcostal long axis view, you can see the dilated coronary sinus receiving the right-sided and the left-sided pulmonary veins, the right atrium dilated, and there is a right-left shunting across the ASD. So mixed TAPVC, you may have a different sites of drainage. That is, you can have one vein, both the upper veins draining into the SVC, and at the same time the other veins draining down into the IVC. So different sites of drainage is also possible, especially in a mixed TAPVC. So once you have a setting of TAPVC, like RIR dilatation, a PFO standing right to left, and pulmonary hypertension, I would advise next to look at the coronary sinus. That's the easiest ones to diagnose. The apical four-chamber view with a posterior tilt, you might get the beautiful draining of the vertical vein. Try to identify the other sites for vertical vein. Just one site of vertical vein should not be enough. You should always see the suprasternal and subcostal view to make sure that there is no other additional drainage. In addition, try to look for the common chamber and the pulmonary venous drainage. You can also look at the SVC flows which are brisk, or also you can dig into the liver and see any dilated portal venous system or a hepatic vein which can be traced upwards into a vertical vein if you are not able to diagnose the vertical vein of an infracardiac TAPVC. Thank you so much for your patient listening. And I must thank
you, sir.
Surfi sir and the team for giving me this opportunity to talk. Thank you.
So next presentation is the graft angiogram. Analyze this by Dr. Jimmy George. It's a live presentation.
Yeah, good morning everyone. So after a pediatric topic, I'll go to another topic. This is a graft angiogram analysis. So this is considered as one of the most challenging angiogram for any adult cardiology because we are well versed with the routine native angiogram in cannulating the left and the right coronary. But cannulating the grafts, especially when you don't know what the reports are or where the grafts are, is really difficult and time consuming. It would take a long time sometimes to selectively cannulate each and every graft and get a diagnosis. Another important thing is to get the right catheter, the right view, and cannulate it gently so that you avoid any complications during these routine angiogram procedures. The most important part is to get a post-surgery graft notes. If that is not available, you will be in a doom. This is a nice cardiac surgeon's discharge summary where you can definitely see he has written the Lima LAD LRI graft and beautifully drawn a diagram so that it will be easy for future for us when you do an angiogram to just cannulate the left right Lima artery which gives all the grafts. All angiogram details of the native vessels are also important, and we are smart cardiologists, we usually write notes, and maybe the CDs also would be available for long duration to get a pre-CABG angiogram also. But what happens is when you have no records, that is something when we find ourselves in a soup, we cannot go further out. But if you can see that what grafts are taken from the patient side, like the femoral, the saphenous graft or the left radial artery graft, especially when the left radial artery graft is taken, most probably we should have an intuition this could be a Lima LRY graft. Now the graft positions are quite important now. These are the usual graft positions which are done in majority of the patient. You have a long Lima which is attached to the LAD. At the same time, you can have both the venous grafts attached to the right coronary artery and the circumflex or the OM. When you have a total arterial revascularization, it's most probably the Lima which is getting attached to the LAD and a Y graft, either a radial artery, mostly the left. Complex and the PDA. You can also have another total arterial revascularization like the Lima attaching to the LAD and the Lima attaching to the circumflex, and maybe a radial artery attached separately towards the PDA. Earlier, even the gastroepiploic artery could have been connected to the PDA instead of the radial artery. These are the different scenarios which grafts can be made out. Now, native coronary angiogram is the first thing to be done before going for a graft, followed by doing the graft angio. The advantages is you can see for the lesions, and you can see where the lesions were not there also before surgery, not significant lesions. Here on the right side, you can see the jump grafts which have been attached, which has already been obviously visible in the native angiogram, clearly indicating the graft is occluded. And even the Lima also is flowing up from the native angiogram, so clearly indicating there may not have been significant disease in the LAD. On the left side, on the lower one, you can see the SVG graft which was attached to the OMA is having thrombotic occlusion. So it's a recent occlusion. So you don't need to separately cannulate this SVG graft to take a shoot, because that is quite obvious in your native angiogram. Now what approach can be taken up? Always, we are all now becoming radialist, so we take all right radial approach, but preferably right radial approach may not be a good option when you go for a bypass graft cannulation. Ideally, a left is better, but left radial artery may be taken in some of the cases, so that also would be difficult out. The advantages of left radial artery is almost like the femoral approach. You can easily exchange your catheters well. You can go with your JL catheters, JR catheters, and multiple other catheters. And preferably hooking the Lima artery would be quite simple. The problem with the right radial approach is like this, you see over here, you may have to enter the subclavian artery with a wire, then try cannulating the Lima, and that sometimes depends upon the tortuosity and time consuming, and more than that, for prevention of stroke and embolization all could be there. So femoral is always reliable, but left radial artery could be a good choice. Earlier, there were a lot of graft markers kept by the surgeons. These are anastomotic sites in the proximal part. They used to keep rings, they used to keep different markers so that easy for the cardiologist to cannulate these. But unfortunately, long duration, they have stopped doing this. The advantages could have been this, but the disadvantages is longer duration of bypass surgery, and maybe the proximal anastomotic sites have getting chances of injury or restenosis. The catheters are the key. Radial, the TIG catheter or the Tiger catheter is always friendly to cannulate most of the grafts. And when you take a left radial approach, even the Tiger catheter would be better out. When you take a left radial or the femoral, the Judkin catheters, multipurpose, and sometimes high origin ambulance catheters are there. Lima catheters may be sometimes useful for a better shoots. On the right side, you can see when the approach is from the right radial, most of the right grafts are basically by Judkins or the multipurpose. And the anterior approaching most of the left side grafts are mainly by Tiger catheters or ambulance catheter. The similar scenario when you approach from the left radial also, or the femoral approach also comes like this. Now this is a case of just showing a Lima cannulation. Once you finish the native JR or native grafts, if you want to go to the Lima, it's better to cross the aortic arch with a JR catheter. And if you're not getting a good shoot with that, it's better to exchange it with a Lima catheter. The second one is a Lima catheter, so that you can get a better shoots of the LRA followed by a Y graft over there. Now this was a case where there was a RIMA to LAD and a LIMA to OM, and your right radial approach, even the RIMA to the LAD is quite faintly visible. And the LIMA to OM, you cannot cross from the right radial, so again you have to go with the left radial. So these cases always preferably go for the femoral route so that you can get a better visualization. This is different types of LIMA to Y graft. The second one is showing a LIMA LRI Y graft. You can see the Y graft attached to the OM and to the PDA. And the last one, you can see a larger one, that is a RIMA graft as a Y graft attached to the OM and PDA. Don't forget, sometimes you can have a venous graft to the LAD. This was a 20 years old SVG graft. You may be expecting it to be closed within another 2 years or 3 years or 5 years time, but 20 years hanging on an SVG to LAD. So that also we need to be kept in mind. Graft to RCA and PDA, LAO projection, just like the RCA catheterization is important. The same thing, JR catheter can be used or take in the radial approach, just push up and turn up like that, and you can get the right coronary, right graft from the right graft to the right coronary. Sometimes downgoing, you may need a bypass graft or a horizontal or a vertical one, you may need an ambulance or an AR catheter one. Circumflex and OM mostly are attached in the anterior aortic wall. RAO projections are mostly taken up. Here you can see a SVG occluded to the diagonal and SVG flowing to the OM. So the different positions, like these are the different positions, the RIMA, SVGs on the right side becomes for the PDA, and from the center and the anterior side comes for the OM and diagonal. Basically, circumflex and OM are higher up and diagonal below, LAD again below, and on the right side you can get the PDA one. Sequential graftings also need to be done because SVGs can also be sequentially attached. So that also needs just a one cannulation. I just finished off fast. This is basically a case where in a LIMA LAD seems to be flowing well, but if you don't take a lateral view, you miss the distal anastomotic stenosis. So that is always a must when you take a LIMA. So you have to see in multiple views to see where the stenosis is. What trouble comes up? Mostly sometimes when you have a different angulation, watch for the spasm. There seems to be a spasm occlusion of the SVG graft. So an osteostenosis, so that needs to be carefully uncoiled so that the catheter does not injure the graft. This is a scenario where there is some slow flow in the LAD. After the LIMA graft, the LIMA seems to be flowing slowly. And the second shot, you can see some hastiness in the middle also. There is a thrombus or a spasm, but you can see from the second shot, the LAD starts flowing up. The first one, the LAD is not flowing. So definitely the patient had come with an ACS, seems to have a thrombotic occlusion or could have been a spasm too. This scenario, when cannulating the LIMA, always be careful. If you can better use a French lower, that is always better. Otherwise, you can have an ostial injury. And finally, LIMAs are very notorious for spasms. So you need to be very careful out. That is standing of the ostial LIMA followed by the final report. Now this is a case where all three grafts were occluded. Patient was asked for a re-CABG, not willing. And this is a situation where sometimes your CT angiogram comes to rescue out. The grafts were missed in this thing, and you can see that you can have a, almost after a CT, if you recannulate it, you can see that there was a graft which was missed, and that was causing scenario which could have been easily tackled with angioplasty. This is the last slide, I'll just go up. What options other than to cannulate it? Always an aortic chute or a pigtail is always better. But one important thing is always recannulate these things after taking aortic chute to get a better visualization. On conclusion, I would say that pre-bypass angiogram and at the same time post-surgical notes are very much important. Access and catheters makes the key. Aortic chute and CT angiogram, especially the 3-dimension CT angiogram on reconstruction by radiologists, are quite helpful and handy for us now. That helps in minimizing the fluoroscopy, and judicial use of these approach, especially catheters, really matters. Thank you.
Thank you, sir. So now I request chairpersons to have 10 minutes discussion on all the presentations. We'll start with Dr. Deepak Davidson is joining us online.
Yeah. Good morning to all of you. It was wonderful listening to all the speakers. Thank you so much for the wonderful, very informative session. First of all, let me start off with asking Sivaprasad sir. Sir, primarily we know time memorial. Every time we have a patient coming late in the night with a myocardial infarction, the outcomes are going to be bad. That's what the data also says. Now, primarily, I felt that it's always because the Cath Lab number of staff and the doctors, the anesthetists, the number of anesthetists, it's all going to be less. So when you have a patient in hypertension or cardiogenic shock, the outcomes are going to be bad. So in our Cath Lab, what we do, we try to alert the anesthetist prior to taking up a sick patient, or we try to alert the CCU staff that in case of trouble, two of you need to run to the Cath Lab. So we tend to alert them. And that is one thing that we do when we come across a sick patient late in the night. In your center, what all precautions would you take? Or would you think about a pharmaco-invasive option? Because we know from Dr. Adit's data that in Indian subset, pharmaco-invasive is a good option. So if the patient comes early, even if she is in hypertension, would you go ahead and thrombolize and take him up as the first stage in the morning? So what all changes would you have in your Cath Lab for all these late night sick patients who get admitted?
Thank you, Davidson, for the very important question. But I think that the distribution of staff and the facilities are heterogeneous between the various PC institutions. If you take a residency program running hospital, like one of ours, where 8 postgraduates are there, along with 8 into 3 means 24, and there are senior residents who are bonded residents. So we have actually no dearth of staff members apart from the interventions by the COVID, where most of them are now doing COVID duties than cardiology duties. But of course, the manpower is going to be a major handicap in institutions where there are limited number of cardiologists available. One. Second thing, if you do an angioplasty for a sick patient is the best thing which we can offer to the patient. Of course, the logistics are going to matter, but we have to give mechanical. If you have good mechanical support, good anesthetic support, I think rather than pharmacoinvasive, I will go for straight primary angioplasty rather than a pharmacoinvasive. Now, the question of pharmacoinvasive is also important. It has to be judiciously selected. In some patients, if you suppose you are having a patient who have a mainstem disease and hypertension, unless you are able to open up the vessel, I think pharmacoinvasive may not do good to the patient. So what we do in our place is, even in the late night hours, even the sick patient with hypertension, with adequate explanations given to the patient, we take them for primary angioplasty. The question of anesthetist exists with us, but question of manpower regarding the postgraduates who are going to rush into the Cath Lab for taking care of the ventilation, taking care of the hypertension, taking care of all other resuscitative matters if it happens, is better in a medical college setup rather than in a private institution where limited facilities are available. But you are lucky in that you will have good anesthetic help. But we may not get that much real help because anesthesia is also downstaffed.
In the night also, like if you have a complicated case like a left main or bifurcation, you can always get the help of your colleague, or in a private setup also. Like two persons can involve and probably tackle that, like rather than residents also like.
A lot of stress from the operator.
Yeah,
takes a lot of stress.
Yeah, unless it's a single man setup, probably like taking a challenging case in the night may be a little bit problem. But otherwise, if you have a colleague who can help you, probably you can get over the case in a good manner.
One comment I would like to make in this regard, what we lose is actually the time. Most of the time, these persons come beyond 3 hours, 4 hours of MI. And then the thrombus burden is going to be high. The insult to the myocardium is also going to be high. The nature of recovery which you are going to make is also going to be lower. This may determine the outcome very, very badly. So I think our aim should be to educate through media about to the public to reach the hospital where a facility for PC is available at the earliest. whatever be the hour. I think Kerala is lucky in that we have Cath Labs available, at least in majority cities. Cath Lab is available within reach. In rural areas, it is going to be a little tough because you have to be a single cardiologist. A 24 running program is also difficult.
Thank you, sir, for that discussion on primary PCI. I think we are all versed with the idea that primary PCI has to be a round-the-clock program, probably with the better results that we have. And it's the system that has to rise up to the occasion rather than trying to go for a pharmaco-invasive. And duty anesthesia always helps. I think we should move to the next topic. Thank you for your discussion. I put a question to Dr. Shine, Kumar, for your comments on what would be your single most quick view for picking up in a routine case when you are consulted for a neonate for a TAPVC, suspected TAPVC. What's your single most suggestion for a resident for the first view or the one view for you to not miss out at all?
Okay, so thank you for the question, sir. The best view I would say to diagnose a suspected TAPVC would be a subcostal view. But most of the time, the adult residents may not be fine-tuned to that. Even a 4-chamber view would be good enough. The classical view would be a suprasternal or a parasternal short axis. But subcostal view, the advantage is that 3-chamber identification by the side of the RA, you see a very brisk flow in the SVC, which is very much suggestive of supracardiac TAPVC. At the same time, you can identify the vertical vein in a infracardiac TAPVC, which is coming down and draining into the liver. So that would be the one best view which I would describe.
All three forms can be definitely
easily tackled.
And looking at the flow across the ASD for most of the cases
definitely
would be the first pointer, definitely in a cyanotic patient.
Yes.
Anything else that you would want to add on before we move on to the next topic for discussion?
As Sir said, subcostal view, and of course, very importantly, the right to left shunt across the ASD and the dilated RARV should be your first cue towards thinking about TAPVC. He's done a very systematic and step-by-step roadmap to diagnosing TAPVC and using echocardiography. Nothing more to add.
How do you identify an obstruction in a supracardiac TAPVC?
Mainly the immediate physiological effect of an obstruction is the severe pulmonary hypertension, secondary to the PVH. So if we have a baby with severe pulmonary hypertension, we have to assume that it is obstructed. And as I said, the commonest site of obstruction is at the PFO or a restrictive ASD, which is the commonest site of obstruction causing a severe PAH. In a supracardiac TAPVC, the other sites of obstruction are the vertical vein which is draining into the innominate vein. You can have something called a hemodynamic vice, where the vertical vein gets compressed between the left bronchus and the pulmonary artery. So that's the commonest site of obstruction for a supracardiac TAPVC. But as I said, the commonest cause is a restrictive PF for a small ASD.
Can you identify some gradient over there? Like is
definitely, you can. There's not such of a cutoff, but when you go for a low scale, you can definitely see a turbulent flows there. And there is nothing like we can measure by a gradient per se, like to say that above this value we should identify like an obstruction. Mainly we go for the color flows, and basically the severity of the pH is one clue that it is obstructed somewhere.
Any more queries?
Deepak?
Yeah. The summary of whatever Dr. Stein has mentioned, what I could take it from that is when you see RARV dilated in a small baby, then you think about severe pulmonary hypertension rather than just telling, oh, it's severe pulmonary hypertension. Always go back and look for TAPVC. That is the most important point that I could gather.
I absolutely agree, sir, because once you label it as PPHN, then the neonatologists would go in the exact opposite direction. They will give pulmonary vasodilators, they will give oxygen, which will again make the situation worse, because that would again add up onto the sickness burden of the baby. So it's always better that to have a second look to make sure that we are not missing anything urgent.
Any comments about graft angiogram?
Thank you.
If no, we'll move on to the next session.
Jimmy, do you want to say that you would go for CT angiogram upfront if you have no records in a non-ACS setting as a standard before you hunt for the grafts if there are no records as a standard of practice? Now that CT angiogram is getting better and better. in a late screening of a routine post-CABG, 15 years so.
No, exactly. I would advocate for a CT angiogram because especially like last month only we had a patient who had done bypass surgery in US 30 years back and he had come in a shock in IABP. So in these scenarios, like we don't know where the grafts are, where all these things are, we'll be hunting it out anyway at all. But these cases you may really need to take him to a Cath Lab and find it out. But when you have an elective patient, with the advent of CT angio and the three-dimensional approach they give the anastomotic sites, both in the proximal and distal, I think it is quite helpful for us so that if at all any doubt after that, we can specifically cannulate these areas. So I think I'm not advocating a CTA, but some scenarios where you don't have any reports, it is better to go with the CT than trying cannulating it selectively after that.
Yeah, I think if there is no surgical records, probably first of all a CT angiogram would be better.
Correct, yeah.
Otherwise, I think we can go for a graft angio.
Yeah.
And many of the time, like most of the CABG patients will have some amount of renal dysfunction. Like they might go like 10 years, 15 years. They will have a borderline renal status, and also I think subjecting them for 2 angiograms is generally not indicated. Unless you have some misleading reports or you have no records, probably you can go for a CT
always it's
first.
better to tell your technician also to keep a pigtail and also the injector ready for an aortic angio if you are struggling with getting the grafts, so that you don't waste much time.
Thank you presenters, thank you chairpersons. We are moving to the next section. Next session is the management issues in cardiology. I invite the chairpersons, Dr. Ajit Tachal, Nigel Cletus, Dr. Ramdas Nayak and Dr. Vijay George. Dr. Nigel Cletus and Ramdas Nayak will join us on the dais, and Ajit Tachal and Vijay George will be online. Dr. Vijay George is joining us on dais. So the first presentation is by Cibu Mathew. How do I treat prosthetic valve thrombosis?
Respected chairpersons, dear delegates, good morning. First of all, I would like to thank Sulfika sir and the organizers of this meeting for this opportunity given to me. How to treat prosthetic valve thrombosis. Okay, a 52-year-old male presented with 2 weeks of class 3 dyspnea. He had mitral valve replacement done 1 year prior. It was a mechanical bileaflet valve. He was on oral anticoagulation and the INR value was inadequate. INR at admission was 1.5. 2 weeks back it was 3.5, 1 month back it is 1.8. So obviously we are considering a prosthetic valve thrombosis, obstructive prosthetic valve thrombosis. So in the early evaluation, PT-INR is a must. We have to get the history of what is the PT-INR in the recent past. Echo must be done, transthoracic echo and transesophageal echo if possible. A cine fluoro we most often do. MDCT is always helpful. In the echo, we look at the gradient. If there is an increase in the mean gradient of more than 50%, must. We have to get the history of what is the PTI. Or if there is an increase of 10 millimeters of mercury in the aortic valve gradient, or if there is an impaired valve mobility, we can consider that it is an obstructive valve. And you can look at the size of the thrombus. If it is more than 10 millimeter, it is a large thrombus. So our patient had a obstructed mitral valve processes, and the gradients were also high. So what are the management options? The management options are in the immediate intensification of anticoagulation, especially the patient had suboptimal anticoagulation, thrombolysis, surgery. These are the immediate options. The long-term option, definitely, the oral anticoagulation therapy, optimization and intensification. What are the points to consider in a prosthetic valve? Is it a left-sided or right-sided valve? In a left side, there is always a risk of systemic embolization, especially when you give thrombolytic therapy or a big thrombus. Is there inadequate anticoagulation? If so, there is always a role for adequate anticoagulation and wait if the patient is not very sick. Is the patient critically ill? Then you have to go aggressively. Is it obstructive or non-obstructive? Obstructive, you have to be more aggressive. Non-obstructive, you can anticoagulate. What is the size and mobility of the thrombus? The thrombus more than 10 millimeter, more than 0.8 centimeter square in another study was shown to have increased embolic events. What is the surgical risk? What is the bleeding risk? Is the patient compromised? Is there pregnancy or old age where there can be problems? Evidence of thromboembolism already embolized to the brain. If you thrombolize, there can be a problem. By a prosthetic valve, often you can anticoagulate. And always, patient preference is the management. These are the things you consider when you treat. So our patient who came with inadequate anticoagulation, he was treated with heparin infusion for 2 days. We tried heparin, but the patient was still symptomatic. Echo was remaining the same. Then we thrombolized with streptokinase. It was some years back, 2.5 lakh over 30 minutes, followed by 75,000 units over 30 hours. And it was followed by heparin optimization of warfarin dose. And this is the result. The valve opened up very well and the gradient came down very well. So what do the recommendations say? There are few recommendations which we follow, like ACC, AHA guidelines and ESC guidelines. The ACC, AHA guidelines advise urgent, slow infusion fibrinolytic therapy. We'll come to slow infusion fibrinolytic therapy or emergency surgery. Both are class 1 indications. For bioprosthetic valve, intensification of anticoagulation. Whereas ESC guidelines, they suggest surgery. If surgery is feasible, they prefer surgery. Okay. If the patient is having a recent history of inadequate anticoagulation, you can go for optimization of anticoagulation, and if the patient is not responding, then you can go for the surgery. So ESC prefers surgery, whereas ACC-AHA prefer fibrinolytic therapy or surgery. But there are other guidelines which prefers thrombolytic therapy first. So which should be given first? So you can compare. This is from ACC-AHA, which favors surgery, like readily available surgery, low surgical risk, contraindication to fibrinolysis, recurrent valve thrombosis. Recurrent valve thrombosis surgery is better. NVHA class 4, big thrombus, LA thrombus, all these favor a surgical approach, whereas no surgical expertise available. This is very often the situation in most of the centers. Immediate surgical expertise may not be available. High surgical risk, no contraindication to fibrinolysis. First time valve thrombosis will do very well with fibrinolysis. NVHA class 1, 2 or 3, a small clot and no LA thrombus. These are the things which favors for the fibrinolysis. I could find two review and systematic review and meta-analysis. The bigger one, which was published in 2014, actually lysis was better. Surgery had 3 times mortality compared to lysis in this meta-analysis, 18 versus 6. Whereas in the second meta-analysis, where Joe Joseph is also a co-author, and it found that the outcome was similar with fibrinolysis and surgery, but bleeding and thrombotic events and recurrent thrombosis were more. So thrombolytic therapy, which are the agents which we can consider, streptokinase, urokinase, RTPA, tenecteplase, all have been studied. In TPA, the high dose given fast is recommended in ESC guidelines, whereas ACC-AHA recommend slow infusion of lytics. What is the slow infusion of lytics? There are 2 studies which have evaluated the slow infusion of lytics. One is the Troy trial and another is the Prometee trial. In the Troy trial, 5 thrombolytic regimens were evaluated. TPA was given 25 milligram over 6 hours, and this low dose slow infusion was equally effective but less adverse events. Another trial, which was Prometee trial, ultra slow infusion of low dose, 25 milligram IV of tenecteplase given, alteplase given over 25 hours, and if needed it can be repeated 8 times up to maximum of 200 milligram. Success rate was 90% with very low incidence of embolism and bleeding, less than 2%. So slow and low dose of TPA can be useful in pregnant patients, higher risk of bleeding, older patients, and already embolized but surgery is at high risk. Okay, such patients can be used. What about non-obstructed prosthetic valve thrombosis? We diagnose that on routine evaluation or when they come for embolic event. But because it is non-obstructed, it is not a benign entity. You have to treat it and follow up aggressively. The size of thrombus is very important. So the size of thrombus, if the size is less than 10 millimeter, and size is more than 10 millimeter. If the size is less than 10 millimeter, you can optimize the anticoagulation, and if the thrombus resolves, it's okay. If the thrombus is persisting, go for lysis or surgery. If the size is big, if it is more than 10 millimeter, you can consider lysis or surgery straight away. In a pregnant patient, valve surgery has got a high risk. Maternal and fetal mortality is significantly high. Morbidity is also high. So we can consider low dose ultra-slow infusion of TPA. Bioprosthetic valve, anticoagulation with vitamin K, intensification of anticoagulation is needed often, and indefinite anticoagulation to be considered balanced against increased risk of bleeding. And once you have tackled the present problem, you have to step up the antithrombotic therapy. If the patient was on inadequate anticoagulation, you have to be more strict and vigilant on follow-up. And if it was on adequate anticoagulation for left side aortic processes, the INR target should be 3, mitral processes around 4, and bioprosthetic valve, you start anticoagulation. So to sum up, in the treatment of prosthetic valve thrombosis, if it is obstructive, whether it is right side or left side, I will prefer thrombolysis first, and probably a low dose slow infusion lytic therapy. And if that fails, I go for surgery. If it is a non-obstructed prosthetic valve thrombosis, if it is a big thrombus, go for intensified thrombolysis, and if it is a small thrombus, initially anticoagulation, and if they do not respond, go for fibrinolysis. Thank you for your kind attention.
Thank you, sir. We are moving on to the next presentation. How do I treat small vessel CAT in the Cath Lab? By Dr. Madhu Sreedharan. Is joining us online.
Morning. Let me thank the organizers and Dr. Sulfi for giving me the opportunity. So we'll be talking about how to manage small vessels in the Cath Lab. We'll start with the case. It's a 60-year-old man who presented with anterior wall MI, pain for 8 hours, diabetic, not on treatment. There's other risk factors being dyslipidemia and obesity. This is after thrombus You can see a long diffuse disease in distal LAD. This is after pre-dilatation with a 3 to 12 acute balloon, followed by a 2 to 20 Maverick along the length of the LAD. And you can see there's a type B dissection in distal LAD, but there's a diffuse disease in a small vessel, reasonably good result with COBA, and he's well on follow-up at 3 months. The second case, he had inferior wall MI with moderate LV dysfunction and complete heart block with a diabetic HbA1c of 13. His angiogram done elsewhere showed a proximal RCA 100%, LAD proximal 100%, T1 70%, and advised CABG. He came here for possible angioplasty. He had an angioplasty with the RCA with a 3.538 expiration, and this is following COBA to LAD and T1. You can see again the diffuse disease in LAD distally. He had hypertension and angina during that balloon dilatation with the proximal LAD suggestive viable myocardium. So he had a 2.2523 thin strut cruise stent deployed in the proximal LAD. Fortunately, he had a safe landing zone. This post-dilated with a 2.5 balloon at high pressure with good result. So what have we seen so far? We've seen 2 cases, both involving the LAD, small vessel involvement with distal disease. One was treated with angioplasty alone, another with DES. We got reasonably good short-term results, but what happens long-term, we are not certain. So why the topic? Small vessel coronary artery disease poses unique challenges with high restenosis, higher late lumen loss, high incidence of vessel thrombosis, and subsequent need for repeat revascularization. The treatment options we have are COBA, DES, and drug-coated balloon, which is that new kid in the block. What are the various definitions for small coronary artery disease? Less than 2.5 is the most widely accepted. The problems are there's no difference in COBA and BMS amongst 404 patients in the ISR SMART trial in vessels less than 2.8 for angiographic or clinical restenosis. DES reduces restenosis, however, neoatherosclerosis and stent thrombosis are concerns. Late lumen loss in small vessels would result in higher late lumen loss with the higher instant restenosis and clinical events. The drug-coated balloon, which leaves nothing behind without the thrombotic risk of scaffolds, is attractive. So what are drug-coated balloons? We have paclitaxel, which is the most common one, which have an excipient, which causes a dose-dependent release of drug. There were problems with limus drug, but with a newer technology, with crystalline sirolimus coating with butyrated hydroxytoluene and sequence-based sirolimus coated balloon, and with encapsulation in phospholipid and nanotechnology and magic touch, these have become commercially available. The potential advantages are it overcomes a negative remodeling with POVA, the immediate encumbrance following trauma to the vessel and a subsequent neo-intimal hyperplasia after death will be reduced, and the perpetual yearly risk of 2% of MACE with the current death is absent with a drug-coated balloon with no process of death. The commercially available drug-coated balloons are predominantly paclitaxel, though you do have a sirolimus eluting ones coming up now. When you have a drug-coated balloon-only strategy, optimal lesion preparation is very important. You should have a pre-dilatation with a standard semi-compliant or a specialty balloon like scoring, cutting, a non-compliant balloon. You also have the option of rotablator or lithotripsy, but you should have an acceptable angiographic result, which is defined as no flow-limiting dissection and residual stenosis less than 30%. If you're using an FFR, it should be more than 0.8. If you have this, then you can have a drug-coated balloon. If you don't have, then it has to be a drug-eluting stent. Any type A or B dissections can be left safely, but C or above needs a stent. When you have a drug-coated balloon alone policy, pre-dilatation should be mandatory, stenosis to be less than 30%. It should be kept in the site as per the manufacturer, at least for 30 seconds, and 60 seconds is better. Post-dilatation is contraindicated after the drug-coated balloon because that will cause dispersion of the drug. And if there's any dissection more than type C or a residual stenosis more than 30% after a drug-coated balloon, you need to put a stent, probably a bare metal stent, for rescue. What do we have? The evidence. You have 4 major trials of drug-coated balloon in small vessels. The first one is the Picoleto trial in 2020, which was a diode balloon versus Taxus Liberté. It was a negative trial with a high rate of MACE and TLR with a drug-coated balloon, and it was thought that drug-coated balloons are not going to be for native coronary artery disease. But with the newer technology, the newer drug-coated balloons like the Bello trial with the NPAC Falcon, where the Restore PCB was a resolute integrity in the Restore small vessel disease, China, and the largest one is the Basket Small trial. You all find that the MACE and TLR are equivalent with a drug-coated balloon even for de novo vessels in small coronary artery disease. Then came the Picoleto 2 trial, which is the last one in TCT 2019, which was comparing the Elutax Emperor DCB, which used dextran as a carrier for the drug in vessels with 2 to 2.75. So this is a new drug-coated balloon, and it is compared with the best-in-class Zyme stent. And at 6 months, you find for the first time that the late human loss is probably better than the Zyme stent, and the clinical outcomes were comparable. At 12 months, you had a numerically higher MACE, MI, and vessel thrombosis in the DES arm as compared to the drug-coated balloon. So in conclusion, the new generation paclitaxel eluting drug-coated balloon outperformed everolimus eluting Zymes in terms of late human loss and was comparable in terms of binary restenosis and percentage diameter stenosis. Short-term clinical outcome was comparable, and the angiographic supremacy and equivalence regarding MLD and diameter stenosis was seen for the first time with a drug-coated balloon. And it again shows there's no class effect among drug-coated balloon, each being different. What does a real world show? This is a SCAR report which came in 2020, the percutaneous treatment of small coronary vessels. This was a study design, and in a nutshell, it involved all patients with PCI in less than 2.5 millimeter vessels in Sweden from April 2009 to July 2017. The primary outcome was restenosis and target vessel thrombosis at 3 years. The secondary outcome was all-cause death in MI. 14,000 patients, more than 1,000 with DCB, 13,000 with DES, and you find with a higher risk of restenosis with drug-coated balloon, there's no difference in target lesion thrombosis or death in MI. So smaller vessels, you have a greater risk of restenosis. DCB is a promising option when stenting is not desirable or effective as in small vessels. However, DCBs are not equally effective as a new generation test. In this registry, DCB had twice the rate of restenosis, though dead MI and lesion thrombosis were comparable. So DCB should be restricted to selected cases where stenting is not a viable option. This is the real world study. So in conclusion, treatment of small vessel disease is challenging. You have poor long-term outcome with higher restenosis, target lesion thrombosis, and target vessel failure. Tests are often not suitable due to long segment disease in small vessels, making ISR and stent thrombosis difficult or catastrophic. The new generation drug-coated balloon offer an attractive therapeutic option, though availability is an issue. Medical therapy in non-ACS setting should be considered and cannot be overemphasized in this set of patients, especially in light of the new ischemia and orbital trials. Thank you for your attention.
Thank you, sir. Moving on to next presentation. How do I treat childhood hypertension? It is a live presentation by Dr. Edwin Francis.
Good morning, everyone. Thank Dr. Sulfika, Dr. Anil and Joe for this wonderful meeting. Just quickly go through the next few minutes about childhood hypertension. Basically go through what's the problem, when do you suspect, and how and when to treat it. The incidence actually in it and the prevalence varies depending on the definition you're using many a times, but on an average, it is estimated to have around 2 to 4% of the pediatric population may be hypertensive, but depends on the definition many a times. And in the case of obese patients and overweight, it is around 10 to 20%. So the question is, like, why should we treat pediatric hypertension? As we all know, these pediatric patients, they grow on to become adults and invariably are likely to have higher incidence of adulthood hypertension. Definitely the studies have proven that, but the concern is, again, there are studies which shown there are structural and functional changes in the cardiovascular system, but then whether it relates to or amounts to an increased incidence of cardiovascular events in the older adults is not proven, which will cause long studies, which is not yet available. But as of now, is logically seemingly it is better to treat them. Again, definitions keep on changing. According to the earlier 2004 pediatric definition was a bit different, except that it changes a bit the names depending upon the whims and fancies of each American Cardiology or American Pediatric Association, whether it is a normal less than 90th percentile, and it is increased blood pressure or pre-hypertension between 90th and 95th percentile, and stage 1 between 95th plus 12 millimeters of mercury and above that. What are the main goals of an evaluation of a patient who was identified to have hypertension? The primary thing, especially in one and most important thing in pediatric hypertension, is to identify a secondary hypertension. Whether exclude secondary hypertension, make sure it is not a primary essential hypertension. And if that's the case, identify the secondary cause. And if it is more likely to be an essential hypertension, obviously to look into the comorbid conditions and then to identify those who need of drug therapy. Ideally, the recommendation by the Pediatric Association is to have yearly BP evaluation at least once beyond 3 years, if not earlier, or more frequently if there is concern about obesity, renal disease, diabetes, or obviously coagulation. In less than 3 years, the major concern is when they have an umbilical artery catheterization, which would have resulted in renal thrombosis, renal vein problems, or recurrent urinary tract infections, or any urological malformations, malignancy, or tuberous sclerosis. Again, I think we all know this because you need basic thing is to have the height of the cuff to be up to 80 to 100% of the arm circumference, and the width should be at least 40% of the arm circumference. But on practically, we may not have the actual different sizes of cuffs available, so it's going to be a practical problem. So when do you actually suspect a hypertension? Obviously, any pediatric patient, obviously first thing, if it is not obese, if there is no family history of hypertension, obviously you should almost always rule out secondary hypertension. More common when the patient is less than 6 years old. If it's more near to adolescence, we assume there's a family history that is essential. Acute rise in blood pressure, specific ambulatory patterns, which is nocturnal or a persistent elevated diastolic hypertension, a past history of renal disease, of history of drug intakes. Fixed examination, obviously almost always make sure you do a full limb evaluation. That's only major thing from the cardiology point of view, is to rule out a coarctation. It's still missed quite often. And on systemic examination, again, it is more an area of the pediatrician, probably to identify the neurocutaneous markers like a neurofibromatosis or is evidence of a web neck of Turner syndrome. It just immediately gives you a clue to a cause of a secondary hypertension. And obvious other, beyond that, lab investigations include a renal function test, electrolytes, USG, and an echocardiogram. Obviously have removed an ECG because that's not sensitive in adult in identifying LVH or any other disease. Specific evaluation you can find out in any other routine. You know that as a chronic renal failure, the routine evaluations already mentioned, but specifically renal Dopplers, MRI, according to the specific scenarios, you can proceed with the specific investigations. And the concern is the treatment when you go in. So whenever you have an elevated pressures or a stage 1 hypertension, obviously you need either pharmacological or non-pharmacological mechanisms. The goal is to bring it to the below the 10th, 90th percentile or below 120/80 for anybody in the adolescent age group. And first obviously comes the non-pharmacological methods like dietary modifications. Even the stage 1, you can even first, there is no evidence of end organ damage, first non-pharmacological therapy should be always considered. And only if there is a symptomatic or a severe systemic hypertension, you consider for a pharmacological therapy. Or when there is failure of non-pharmacological therapy with persistent hypertension. And secondary hypertension, obviously you treat the secondary cause and then continue to treat the systemic hypertension. Non-pharmacological therapy, as you all know, the weight reduction, regular exercise, and diet modification is quite easy to say, but then practically it becomes difficult. And reasons for drug therapy are symptomatic hypertension, secondary hypertension is the persistent with non-pharmacological measures, and in the presence of end organ damage, obviously, and in the presence of diabetes. Drugs, I don't think I need to speak to the adult cardiologist about the drugs, which is, I think usually again it is nothing specific for the pediatric age group, almost always AC inhibitors or AC receptor blockers are preferred most of the time, again the rest of the things. So to conclude, we need to be aware and then to pick up these hypertension in the pediatric age group, which may prevent adult comorbidities. And then we should have to identify the secondary cause. The most important is not to miss a secondary cause which could be easily treatable, and then appropriate therapy prevents long-term adverse outcomes. Thank you.
Thank you. Thank you, sir. So next presentation is How Do I Treat Neurocardiogenic Syncope? It is a live presentation by Dr. Bhim Sankar.
Morning, everybody. At the outset, I'll thank the organizers for this opportunity. To answer this question posed, I thought I'll quickly recap the modalities available, the limited evidence that we have, briefly on the guidelines and the differences how the Americans and Europeans approach it, and finish off with a slide on my algorithm. Fortunately, vast majority of the vasovagal syncope patients have a solitary event, but occasionally clusters of event over the few years, and then they have remission. And all they need is a little bit of reassurance, education about the entity, the benign nature of the entity, and then teach them the circumstances to avoid the circumstance that could trigger it. And then finally, most patients have the prodrome, which is characteristic, and it's to each patient. And if they learn to identify the prodrome, they can kind of mitigate the event by kind of lying down or sitting down and raising the legs. This happens to the vast majority of patients. Physical counterpressure methods have a good role in these patients, and this has been studied in several small studies. Eventually, it was systematically studied in this RCT called the PC trial that randomized 100 odd patients towards training patients to physical counterpressure methods versus conventional therapy, and found that there was significant difference in terms of outcome. There was syncope-free survival probability was much higher with patients who received training for physical counterpressure methods, either hand grip or leg crossing and muscle tensing. So you can abort an event. Pharmacological evidence for pharmacological methods is at best weak. Of all the drugs that is available, Midodrome has some evidence, and this hypothesis was tested early on by the Milwaukee group on 11 patients, and then on there have been conflicting reports, both for and against. The last of the abstract that was presented in the ACC was a RCT that showed that there was no difference in using Midodrome or placebo. Nevertheless, in practice, when patients have recurrent syncope, the only option is Midodrome. It seems to show some benefit in addition to the assurance and physical counterpressure methods. The other drugs, beta blockers, SSR and fluorocortisone, have even weak evidence, and I just put up this slide to show that beta blockers, if at all we are using it, we should be using it in patients who are older than 40. The post study, which all of us may be aware, that showed that beta blockers have not much use in vasovagal syncope, but in this study showed that when they estimated age specific hazard ratio, it was shown that at least in patients above 40, for patients with recurrent syncope, we can attempt using beta blockers. So that's about non-pharmacological and pharmacological modalities that we have. About pacing, the enthusiasm that was there in the initial RCTs actually waned off after these two trials, the VPS2 and SynPace. The truly double-blinded RCT showed that all that enthusiasm was mostly placebo effect of pacing. But proponents of pacing actually found that the inclusion criteria was the issue with VPS2 and SynPace. They included all comers, all patients who had syncope. But then issue 3 actually enrolled patients specifically who had cardioinhibitory type 2 response, who also had long pauses on ILR. They had ILR implanted, and then they subsequently received pacing, and they showed benefit in terms of patients who had received, in terms of recurrence of syncope in patients who received pacing. However, if you look at all these trials, they all use the rate drop response algorithm of the Medtronic device. The concept is slowly changing that if you can circumvent, if you start pacing earlier on, before the second phase of vasovagal syncope, probably pacing could be more beneficial. The so-called closed loop system that is available in Biotronic devices actually starts pacing even before there is onset of bradycardia. It actually uses the rise in impedance when the increase in contractility happens during the early sympathetic surge, and therefore you can probably circumvent the event. So the Spain study actually looked into this aspect, and this was a randomized study that showed that on patients with cardioinhibitory type 2 response had actually benefits on pacing. There's an ongoing larger trial called the BioSync phase, so we'll have more information on this, on use of this algorithm for patients with vasovagal syncope. What's emerging is cardioneuroablation. In the second phase of vasovagal syncope, the ganglionic plexi, both in the atrium and the ventricles, probably are the trigger for the parasympathetic surge. If you can ablate this ganglionic plexi, probably you can mitigate syncope. So this was first studied at Sao Paulo, Brazil, but then there are several studies coming up both in South America and China. There's no quality evidence. Nevertheless, this seems to be interesting. So some centers actually use spectral mapping to locate the sites of ganglionic plexi. Other centers just use anatomic mapping, and these ganglia is supposed to be around the pulmonary veins, around the SVC RA junction and the coronary sinus. So you're ablating this probably will. So this is emerging data. We're not yet having quality evidence to use this in practice. So this is first came up from the Brazil Sao Paulo unit. So despite constraints in time, I couldn't resist putting up this paper. This paper is from India, published this year from Jayadeva Institute, that showed that structured training yoga for a month or so actually has benefits in vasovagal syncope. They showed that over 12-month follow-up, one month structured yoga training does help. There are other centers trying this, even in Hyderabad Cath Center, they are doing a paper, it's yet to be peer reviewed. Asana that's similar to tilt training seems to be working. So what are the guidelines saying? At the moment, education is the only class 1 indication, education about the entity, and the physical counterpressure measures class 2 indication, both the European and American guidelines. If you look at pharmacological management, midodrine receives class 2A indication in the American guidelines. The Europeans don't think it's a good drug. Beta blockers are to be avoided in the European guidelines do not advocate beta blockers, but based on that one trial, post hoc analysis, it can probably be used in patients above 42 years. It's a class 2B indication. Regarding pacing, it's a class 2A indication in the European guidelines and a class 2B indication in American guidelines. There are qualifiers in ESA guidelines. You need to actually document symptomatic 3-second pause or asymptomatic 6-second pause. And again, in both the guidelines, it's to be advocated only for refractive VVS in patients above 40 years. So how do I treat my patient? To answer the question, once NCS neurocardiogenic diagnosis is established, again, the primary stay is education, counter pressure measures, salt fluids, and then reassurance. This is the vast majority. In the very few minuscule of patients who would come back with recurrent events, if they are less, I'll just take a minute more. If it is less than 40 years, probably I would consider midodrine at the dose of 2.5 TAD. Most ladies and teenagers do have some amount of anxiety and functional overlay. Collaborate with the psychiatrist and use SSRIs. If they are above 40, it's a trial and error method, beta blocker versus midodrine. And in the very selective subset of patients who have typical type 2 response to TIL test and have no prodrome, probably I would consider pacing, and maybe I will consider CLS over RDR these days. And I'm contemplating on sending patients to yoga instructors, and then we need to wait for more information on cardio-neuroablation. Thank you for your opportunity.
Thank you, sir. So now I request all the chairpersons on the dais to start the discussion for 10 minutes. Dr. Ajit Kachal will join us on discussion online.
Cibu, so is there any particular thrombolytic therapy you will choose for particular valve on the right side or the left side, or how exactly you are going to give, or your final slide showed that RTPA is the choice?
No. The RTPA, there are studies on RTPA low dose, 25 milligram given over a slow infusion over a long period. So that is a very good scientific data where we can give a low dose or a prolonged period where the risk of embolism as well as the complications bleeding is less than 2%. So that is a very good choice. Whether it is right side or left side, whether it is aortic or mitral valve, we can consider this slow infusion. If RTPA is not available, may not be available, it may be streptokinase also can be given as a slow dose, low dose as slow infusion. There are studies where, which reports where streptokinase was given over several hours, like 72 hours also, with good response. But the ACCHA recommend a slow infusion of thrombolytic therapy.
Regarding the use of tenecteplase, what is the experience with?
I have no experience, but I have found a report from India itself where tenecteplase infusion over a period of 24 hours was a very good option compared to streptokinase, and it is a very good option, can be given. That I found a report.
Dosage, what is the dosage which we use most of the time?
The dose was their dose was, it is 0.5 per kilogram over 24 hours, something like that.
Infusion rate.
So it is the same dose what we usually give as a myocardial infarction. The usual dose, it is given over a period of 24 hours, a slow infusion.
So any case reports of bolus dosage for thrombosis, because most of these patients will be sick, massive heart failure if it is a mitral valve thrombosis. So this slow infusion takes this much hours. So any case report showing bolus?
If the patient is extremely sick, very sick, then the recommendation says that ideal therapy is surgery, because when the patient is very sick and very critically ill, their surgery also has got a high risk, more around 50% class 4 symptoms. But once you thrombolize and if the patient is not going to respond, then surgery cannot be done within 2 or 3 hours, because already thrombolize, how can you do surgery? The surgery is the first option, but very often it may not be available, And surgery may not be feasible also. Even the first surgery the patient did with very difficulty, second surgery may not be also feasible. So we had to thrombolyze. So their thrombolytic therapy, the ESC says that you give just like 10 milligram 10 hectoplace bolus followed by 90 milligram or 90 minutes, or our streptokinase, regular streptokinase over 60 minutes. That is fast infusion. That is what ESC suggests. Whereas if the patient is not very sick, we can give slow infusion. Slow infusion has got the advantage of less bleeding, less embolism, because you lyse the thrombus slowly. If you give a fast infusion, always there is a chance of a thrombus fragmentation and embolism. So that is a risk. If the patient is very sick, you cannot wait and you give faster infusion, higher doses and faster infusion.
So after one round of infusion, how to follow up these cases clinically and echocardiographically?
So you can follow up always after one round of infusion. You can the clinical assessment and echo assessment, whether the gradient has come down, we can follow up. If the gradient has not come down significantly, you can repeat the lytic therapy again. But when you are giving low dose of 10 hectoplace, there is something known as antibodies, ATA antibodies. So if this is present, patient may not respond very well. So you may have to give a higher dose. So low dose may have a problem in altiplace or TPA if there is antibodies present. So higher dose may be needed. So once you give thrombolytic therapy, you have to do a repeat echo, assess the gradient, assess clinically, and if the patient is not responding well, you can repeat the infusion of thrombolytic agent again. And if still not responding, go for surgery.
So it's only gradient or the thrombus size. I heard it is less than 75% of the thrombus size compared to the initial echo.
So if the gradient,
you have to repeat the infusion.
Yes. If the gradient has come down significantly and the obstruction has been relieved, then there is always an option to continue heparinization, anticoagulation, aggressive anticoagulation, and wait for the thrombus to disappear slowly. So we need not repeat the thrombolytic agent very aggressively. But if the thrombus is still persisting, the valve is not moving well, the obstruction, the valve opening is not very good, then definitely you have to repeat the thrombolytic therapy.
Dr. Cibu, I think, we had the experience, I think, when I was doing my DM in 91, there was the first reports of using streptokinase we used in very sick patient. That was one of the first few cases reported in the Indian literature also. So ever since that, this has been a lot of articles came in, it's become an accepted therapy. I think the dosage which is given for streptokinase, the question which was asked, initially you always give a bolus of 2.5 lakhs for this to act immediately and keep this 1 lakh continuing for 1 lakh units per hour. It's not a low dose for streptokinase, which need to be continued. But unfortunately, one of the major problems that we see time and again, even in our practices, if you have a large thrombus, like very, very huge, that's where when you use it, invariably there is a risk of systemic embolization and the strokes there. And we have had occasions also, once sliced, doing very well, the patient again getting a recurrence. At that time, in fact, we wonder whether the streptokinase itself will do the job again. We've used 10 hectoplace in the second sitting with good results sometimes. But the major problem is in terms of embolic occlusion of the cerebral circulation. So that's a cause of concern. Otherwise, I think it's a very, very accepted modality for prosthetic valve thrombus.
Sir, as streptokinase, the different guidelines give different methods. Like ESC gives 15 lakh units over 60 minutes. That is their recommendation. So streptokinase, just like that. Or we can give age-old 2.5 lakhs bolus followed by 1 lakh per hour infusion, or even 50,000 if the patient is having a higher risk of bleeding. Slow infusion over a period of 72 hours have been recommended in some guidelines.
Cibu, one practical point. The gradients are not usually helpful in patients with atrial fibrillation and slow ventricular rate. You have to go by the symptoms as well as fluoroscopy. Especially with the St. valve, it is very, very important that we had patients who had severe dyspnea, PND, everything, but the valve gradients were always less than 10. So you always tend to miss a valve thrombus. I think fluoroscopy is more important for looking at the valve motion. Even the echo may not really help you. So I think it's a very important practical point. AF with slow ventricular rate, please do not depend on the gradients.
Yes, very good, sir. Sir, but certain valves like Chitra valve, you cannot see on fluoro. You cannot see anything on fluoro. So you have to look at the gradients also, and you have to have a previous gradient and the present gradient. So you have to document what was there after the surgery. If there is any increase by 50% in the mean gradient, that is significant.
We had one patient who had this recurrent PND, and Dr. Rajesh is not there, and it's a St. Jude valve.
Okay,
it's
sir.
a re-surgery. Twice she underwent mitral valve replacement. The only thing which helped us again was the symptoms. She was having PND.
Yes, sir. Yes,
and
sir.
then gradients always were less than 10. So you could not.
Yes, sir.
That's a very important practical point.
Yes, sir. Yes, sir.
Okay, thank you, thank you, sir. Shall we move to the next queries about presentation as we're exiting the time?
Madhu?
Next topic, we'll discuss these queries about the next topic.
Madhu?
We have only 5 minutes more for the discussion.
Madhu?
Yes.
Yeah, Madhu, as usual, clear and crisp presentation. So, my question is, can you extrapolate all these things with the bifurcation also? If you have a small vessel bifurcation, 2 millimeter vessel, and you have a type 1 dissection, type 2 dissection, and you have little slow flow, can you go with the depth there and then think of leaving without extra metal inside the bifurcation?
In fact, that is one of the most common indications for using the drug-coated balloon in the scar registry. But they have found that the restenosis is still very high. Bifurcation is always a difficult thing to treat. Restenosis is high, so the scar registry. They say drug-coated balloon should not be the thing that you use drug-coated balloon for everything. We don't have data.
So my question to Edwin, sir. Sir, shall we advise all children less than 6 years or less than 12 years for yearly BP measurement, even if there is no symptoms or there is no risk factors?
The recommendation says that more than 3 years. Probably, if you get an opportunity, probably it's better to always document a normal BP. That is, because many a times it is missed many a times. So if you have a patient walks into your OPD, it's always better to document one blood pressure. Anybody is more than 3 or 5 years old, so that it will be useful in the future.
Is there any last question, last queries about?
Bhim, can I have a question, please? This is to Bhim.
I'm there.
Bhim, can you quickly comment on the dose of midodrine, please?
Oh, I start.
The dose and timing of midodrine.
I know people recommendation is 5 milligram TID, but in practice I tend to start with 2.5 TID and then go up gradually.
Right. And do you really need to think that night dose of midodrine is required? And can you comment on the dose timing? Because I usually tell people to take the first dose as soon as they get up, because otherwise people tend to take the first dose at breakfast, and by the time the dose acts, it's almost 1 hour after taking the dose.
Well, I didn't think that was critical. It's I didn't take generally advice along with breakfast, so I didn't think it was important to initiate it as soon as you get up. Do you find that
the worry is nocturnal hypertension with in elderly people who get midodrine? There is a worry about nocturnal hypertension. So do you really think that night dose is required? There are pros and cons. They might get up at night to pass urine and might have a syncope. I don't know, I just want to know your view on that.
So I haven't had any issues like that. So the very few patients who are on actually are taking it in the night too, but none of them have had an issue until now. So I'm not sure. I'm not sure which way to go.
Thank you, sir. Thank you, presenters. Thank you, chairpersons. So moving on to the next session, ACS management in Kerala, yesterday, today, and tomorrow. I invite our honorable chief guest, Dr. Mohanan PP, National President, CSI. A good applause for him, please. I invite the chairpersons, Ashokan Nambiar C, Dr. Chacko KA, and Dr. Govindan Unni to the dais.
याद रखें कि जिंदगी में कभी भी दूसरा मौका नहीं मिलता। Take care. Good luck.
Colleagues and friends, we are on to a very important and interesting oration. The topic itself is fascinating. And Dr. P.P. Mohanan, I will do this greatly, and I am waiting for his exposition of the cardiology in Kerala, especially the ACS. It is very difficult to introduce Dr. Mohan. It is a gracious pursuit to this crowd, because he has been a presence throughout the activities of Kerala Chapter and leader in many of his activities. He has extended his field nationally, and he is currently the president of the National CSI. Just one point I want to make about his multifaceted personality and contributions, and that is, I firmly believe that his lasting contribution to Kerala Chapter is the important role he played in taking Kerala cardiology to national and international level, mainly through the elegant epidemiological studies. The studies included American National Institute supported and funded program of coronary artery syndrome quality improvement in Kerala. Another investigation is prevalence of coronary artery disease and coronary risk factors in Kerala, South India. He is a principal investigator of the WHO and Government of India supported acute coronary syndrome quality improvement pilot program. Interim results of these ongoing studies appeared in well-regarded peer-reviewed journals, and I have no doubt that the legacy of these original studies and report will last a long time. Dr. Mohan.
Ashokan Nambiar.
Dr. Ashokan Nambiar is it?
Hello, Mohan.
Sir,
Mohan,
we can't see you.
I am online. You can see me, my image you can see. I think you can recognize me even by voice or even my thought. You are always in our thoughts. I am very pleased to note that you are giving this talk on ACS yesterday, today and tomorrow. You are the most apt person to it. I was taken back to the 1960s when we were impressed by the trilogy, yesterday, today and tomorrow, with Sofia Taylor and Marcelo Mastroianni and all. Probably you were too young to watch those movies at that time. But this phrase caught up with the imagination of everyone. And I'm very pleased to know that you are going to talk on this evolution of ACS management. And you have observed from close quarters. I'm waiting for you to do this operation. Mohan.
Thank you, sir. Thank you, Csi Kerala, for all what you have done. For it's only because of that what I am today in the organization. I have also the privilege of my session being chaired by my guru, Nambiar sir, my boss. Chacko sir was my boss when I did the national conference, and my dear friend Unni. I don't get the credit of, I should admit, that this title is Sulfi, and maybe because I gave him another, but then he made this way, and I have a disclosure saying that I just compiled whatever is happened in Kerala, whatever the publications. But as you are aware, the unsung melodies are much sweeter. So there could be many that I have missed, and my apologies will be for that. We are, the escalating epidemic of coronary artery disease is something which was there, and every one of us understand that. And we had the initial data from the Calicut Medical College, which showed there's a quantum jump from 1970s to 90s. Now you have something like a 20-fold increase in admissions, of course. Now these are all preliminary data, and this was from Professor Girija. As you could see that 50% before the age of 50 years, possibly not, we are not very sure about these data, but then
our interest in heart attack has been going on for years. This was possibly the first of the prevalent studies that from Professor Ramangutti, who showed that the average prevalence in the rural area is about definite coronary artery disease is 1.4%, which was in fact rather comparable to the other parts of India. But look at this, we did it about after a gap of 19 years. I'm just giving you some glimpses of the epidemiological data before I come to the real management part. But then gap of 20 years shows you that the prevalence has jumped from 1.4% in 1993 to 3.5% definite CAD. I'm talking about definite CAD, and the probable CAD in the Kerala CRP, our study, was 14.5%. So we were possibly east or west. Kerala is the best, even though for the wrong reason. This was again Professor Soman's data, which showed that phenomenal increase in the prevalence of coronary artery disease. And unfortunately, this is CAD is killing younger persons. 60% in women, men, and 40% in women occurs before the age of 65 years, and that's precisely young, I will say. So, well, and over the years, we also knew the epidemiological transition possibly is fastest happening in our state. See, that's why you have Kerala, Tamil Nadu is very inching closer to us, but we are still on top. And of course, Punjab, and we three are the triumvirates who sort of established their role in having the highest incident prevalence of coronary artery disease. Again, I was talking about the epidemiological transition level of some of the. We are there, right there. Even though we are at the bottom side, we are. In transition, we have nobody to conquer. We are there. Okay, right. And this is not very important slide, but just for the information, look at the contribution of our interventional data to the National Interventional Council. We contribute a mammoth just behind Maharashtra. So our cardiologists have been doing a lot of, that is not primary alone, that was total intervention. I'm just giving you an idea that our contribution, and of course, that pari passu goes with the coronary artery disease. This was our first, entry into, Unni is there. We tried to sort of, the CREATE was going at this time. CREATE study, many of you were part of the CREATE study. And we learned huge lessons from CREATE. And this was one of the things that we tried to involve, educate physicians. We didn't have the guts to get the cardiologist at that time, but we got about 35 physicians in and around Thrissur, Palakkad and Malappuram, and tried to sort of identify what are the gaps in the management part and how better. As we could see here, we could do something. This was a very short data, very short-term data, and we were not looking at the hard end points at all. But then we could improve the door to needle time lysis was the only thing happening at those days, and we could just improve the medications, at least the discharge medications. That was something which we tried to. Of course, CREATE gave us a huge data. That was the first Indian data which told us what are, and we had a huge representation from Kerala, mind you. Now we have a lot of Kerala centers involved in these 22,000 patient data of CREATE, which showed us that CAD mortality is very high, and apparently, even there, it is linked to your socio-economic status, it is linked to your educational status. I will not go into that. But then we came out with the the Kerala SES registry. We were bent on beating the number 22,000 of create, and we could achieve that thanks to every member. We had 125 hospitals in Kerala SES registry, and we could somehow do that. And with the help from, of course, we waited for almost 2 years. We slept over the data, but because we were naive, we have no idea of how to do a biostatistical analysis. And we waited, and finally somebody came in the form of Mark Hoffman and helped us, and that is that. And look at that, look at the data. No? Lysis was in about 41%. Our PCI, right, here again, those were the days where we have, Koshi sir will know, those were the days where now we have very few centers in the, I think there were about some 31 Cath Labs at that time, and even there, we would not have been involved. We tried to involve all the medical colleges, but we could get only 3 medical colleges at that time. But look at the percentage of the percutaneous coronary intervention, dismal 12% in my God. And we learned again quite a lot of lessons. Anybody with acute coronary syndrome who has to be on a dual antiplatelet drug, heparin, statin, only less than 50% receive these vital guideline-directed medical treatment. We were aware of that, and that could explain this very much variability. Now, our in-hospital mortality of STEMI was 8.4%, which was, when compared to the other ACS registries in the outside world, it was really high, even though it was at that time. So that was basically because of the process of care in every hospital differs, and that was the real attributable thing. Of course, we had multiple papers from, this was one of the papers Harikrishnan did, and we were just wanting to compare the physician's approach and the cardiologist approach of management. Roni presented a urban versus rural management kind of thing in ACS care. We had a AHA presentation, I think in 2009. We in fact was trying to identify, what were the real problems in the ACS management at that time in Kerala, and you have a lot of barriers for a proper. We have even at that time our trauma care was pretty good, but our ACS care was totally non-organized. We in fact made a policy document and requested the policy makers. I personally met the health minister, the health secretary, not the chief minister at that time, and gave him a document, bunch of this. Possibly everybody slept over it. But then this was the first nationwide document that we prepared, and we were trying to impress upon these policy makers that we have a problem of ACS management, and unless we do something, we could be in real trouble. This is from Rajiv Gupta and Dennis Xavier, who thought that they were analyzing all the ACS registries, and when in comparison, you could see that when we compare our registry data with the Grays or the Euroheart, of course we had a high mortality, and they wrote that maybe the low quality cardiovascular care, which I refuse to believe. I think our quality of care is much better than when we compare, at least over the years. This was the Kim Eagle's editorial on our study, our Kerala ACS registry. And he suggested a couple of things. And of course, he suggested that, now you did a good job, but then you better do better jobs because you have a problem in ACS management in your state, maybe in India. because we didn't have that, apart from CREATE, we didn't have any large database. All these HP Northeast registry was about 2,000, 3,000 patients. The number matters, that everybody knows. And he suggested that a quality improvement program is the best thing that possibly you can try to improve. But then a long time has elapsed. We did our registry in 2005. And 10 years, it took us 10 years to get the funding. See, that is the problem. See, to do a large data, unlike Kerala ACS, which we did on pittance, but doing a quality improvement data costed money, and fortunately, again, our association associates managed to get the NIS grant, and we could do that. The ACS basically, that was again, it continues to be the largest randomized trial. Of course, the randomization was not for the patient, it was for the hospital. We had about 63 hospitals, and we did a sort of a wedge design, little complicated design, but we showed that we could. The hard outcomes may not be there. Look at that. Look at the primary PCI rate by the time we started doing ACS-Q. Over 10 years, from 12%, we have gone to 46% or 52%. So the years made the changes, and even our lytic rate, our discharge medications, quality improvement program made a lot of differences. Of course, Kerala by the time, I think we have learned a lot of lessons, and everybody were adept in clinical managing ACS. We couldn't make any hard differences in the hard endpoints, basically because our baseline treatment was excellent. That is why we couldn't possibly, but even then, look at the mortality rate, the 30-day mortality, 3.9% and 5.1% and 3.9% the intervention. See, it has tremendously come down. The in-hospital mortality, our Kerala ACS in-hospital was 8.4 and 30-day. We did not publish it, but then because it was a little mazed up, that's why. But then we know that the 30-day mortality was something like 16%. And this is, look at that, we have brought it down to 6% only because of the excellence in our adeptness in our improvement. And I mean, in every subset, the quality improvement program improved the quality of the health. Well, this was another. We did a lot of sub-studies with that, and we also know that the quality improvement program helped to improve the quality of life, which is one of the very good indicators now. Over the years, you would have seen. Look at even ischemia trial. See, the hard endpoints are not different, but the quality of life, that is where they hanged on. I mean, I remember with that. So this was again one of the, yesterday Rachel was presenting about the women's affairs, how they get not the optimal treatment. The ACS-Q also showed that. This was recently published from another group who was interested in our data, and that showed we are still MCPs, I will say. I think we have to improve the women's care. This was again from Anub's, Jabir and your data. This was again very recently published, October 2021, which also showed. No, the women's care in our state is, something which definitely need to be improved, and we should be looking very, very special, importance to that. We also showed, this is something which has been there. We know about 15 years ago we had a data from, a small data from Sri Chitra Tirunal. I forgot her. I think that was the lady who published that initial data showing that about 80% of Keralites developing a acute MI or a stroke have distress financing. So no, it is not distance financing. Every time I say that, people confuse it with distress financing and distance. Kerala lives on distance financing, we know that. But this is distress financing, meaning they have to sell, pledge their property to get over the ACS fiasco. So that also is, of course, that was an editorial written by the famed Rom Kera, who was who is a very interesting guy. Maybe I will tell the story later. But then, who again stressed on the importance of financial toxicity of somebody developing a cardiovascular disease in Kerala, that they have to, because most of our insurance rates are much lower. Of course, we have also lot of other studies, this from Kottayam Medical College, Mishriya, Suday and George, and of course Kader, GP. So we have, these are sample sizes were not very high, but then this was again interesting. 56% had STEMI, 36% occurred between 12 p.m. and 6 p.m. That was interesting. That was, which caught my attention. I don't know why, but then maybe somebody can tell, Kader maybe can tell, but then this was another very important study from our state, very important study, which told us that the way to go, in Kerala at least, is not pharmacoinvasive. Look at that. The population access to reperfusion, I am talking about primary percutaneous reperfusion, catheter-based reperfusion, not lysis, is substantial. 70% of our patients have access. So I think there is no, need for us to get obsessed with this World Heart Federation white paper, which was trying to copy the STEMI program of pharmacoinvasive therapy. COVID is different, I do agree, but our state is now have the population access for a catheter-based reperfusion is excellent, and I think that should be the way forward. We have again some of the data from published data. They're all again smaller data, very small data. This is from the northern Kerala, and that again very small data. They didn't see much of the so-called malignant CAD in youngsters. Now there was a notion which Inas proposed earlier, years ago, said that our Kerala youngsters has malignant CAD, but then possibly the angiogram did not convey that much. Of course, we have the government, Kerala government has come out with many of you were Venu, George Koshi, Sivaprasad, Sajeev. A lot of people were involved in Cibu was the convener, and they came out with some SOPs, standard operating, treatment guidelines, which has happened in every disease. And I will just again tell you some story on this is the latest data from our state. Of course, this was again a all India study, 192 hospitals all across India, 41,000 patients. And look at Kerala. While the entire nation had a dip of about 30% in the STEMI rate, we didn't have that dip. We had hardly about 5%, 6%. So I don't know for what reason, but maybe our people are much better. And look at even during COVID time, this is COVID time, 2020, this is 2019, before COVID, during COVID. Look at that. Now our PCI rates, primary PCI rates were pretty good. And of course, one thing we understood from, this is an unpublished data, and I should say that this is being processed, so please don't quote. But then this is, before I conclude, I just want to show you this data also. So look at that. See, our reduction is only less than 10%. And the STEMI reduction was much lesser. Look at that again. See, 71% primary PCI in Kerala. This is something which again we have to understand. In hospital mortalities down to 3%, 3.5%, which is in parallel with the best centers in the world. So we are much better. Look at the comparison between our data and the all India data. We are definitely better than any other state. And 4.7 mortality India, 3.6% in Kerala. Don't ask me the p-value right now, because we did it yesterday night. So because this was unanalyzed data, we just tried to analyze it only in the last week. And I just want to have you look at this particular data, which came out a couple of months ago from one of the premier institutions in Uttar Pradesh. And look at that, 18%. We had 75%. So that is my, so what should be the way forward? I think we are doing reasonably well in our ACS care in Kerala. I think the data has maybe, and the guideline directed treatment over the years has been excellent. Our cardiology group, old and new, are doing an excellent job and there is still a place for. See, there is still, the most important thing that we have to do is we now learn a lot of things. I don't think we should go to translational research. Of course, I know Johnny is going to talk about that. I'm not saying anything against that, but then we have enough data to convince us we can bring down the mortality to 3.5%. Only problem what is remaining is implementing these. Implementation is something where we failed. And that's what we have seen when, look at that, this is a Korean guy whom we could attract. This is again from Northwest, one of those students who did a world management survey. There is a survey which tells us how is the best management policy for each hospital. And he went around about, I think many of you, he would have approached our Sang Kyun. You would have remembered him. You would, at least few of you will remember him. And he was trying to analyze what again is the implementation program. We have seen that in the quality improvement program. I have troubled you, many of you, reached you out and talked with you. So we were trying to analyze what is the problem, and look at that. Our management system in the private hospital, government hospital, maybe has to be better for a better mortality reduction. That is the only thing. So that we can go from 3.5, maybe we can go up to even 2.5%. So this is my last slide, don't worry. East or West? This is Kerala is best. See, despite all our preponderance of risk factors, our increasing burden, our management of ACS looks pristine, good, and I think the future definitely, can you get this slide, the last slide? Good. There was some discussion yesterday about heated discussion, I suppose, exercise. This is nothing to do with my talk, but then we are coming out with that. We will have a national discussion on that. Thank you very much for your kind attention.
Thank you, Mohan. As usual, it is always a pleasure to listen to Mohan. Whether he is the national president or not, even before that, it was a pleasure to listen to Mohan. And of course, what he has said during the last half an hour has given us a sense of superiority, I suppose, because he said Kerala is the best. But as he rightly said, the other way also, on the wrong side also, we are the best. If you look at the number of ACS patients per 1,000 population, I don't have the statistics, but I'm sure we will be somewhere in the top as far as compared to other states. Or if we look at the risk factors, number of hypertensives per 1,000 population, or number of diabetes, obesity, sedentary, whichever 9 risk factors Salim Yusuf has talked in that Interheart study, I think we will be on top once again for the wrong reasons also. So maybe we should not be too much complacent with the treatment of ACS, which is definitely very good. But I think we should look at other aspects of this point also. Thank you very much, Mohan. A very nice talk.
Thank you very much. It was a wonderful talk.
Nambiar sir?
One small comment.
Nambiar sir, you are muted possibly.
Maybe it shows.
Now you are muted, sir. Now you are not audible.
Please unmute, sir.
Yeah, now you are audible.
Now you can hear. So as usual, Mohan has given a very clear picture of the ACS in Kerala and the world. And as Unni said, rightly said, there is no place for complacency. You have given a very rosy picture, but let us have some introspection. My only piece of, I don't call it an advice, the recommendation is keep data always. Document everything. When you see some hospital records I'm very sad to note that many of the data are very incomplete and insufficient. So I would endorse everyone to keep, now that we have EHR in all hospitals, most of the hospitals, keep all the data and keep it up to date, and let everyone add up to the data and contribute and inform Dr. Mohan what's going on in each place, so that after another 10 years he can give some more data and more up-to-date picture of what is happening in Kerala when compared to the rest of the world. That's all. Mohan, fantastic talk. Congratulations.
Thank you, sir.
So I think we'll conclude this session, and thanks Mohan once again for that very good talk. Thank you.
Thank you, sir. Thank you, Chairpersons. Thank you, Dr. Mohanan, sir. Now we are going for the inaugural ceremony, the most awaited moment of CSIK. So please wait a couple of minutes for the inaugural ceremony. So we are moving on to the inaugural ceremony of CSIK. I request Dr. Johnny Joseph, Dr. Mohanan sir, and Dr. Karuna Das, Dr. Zulfikar Ahmed, Dr. Joe Joseph, and Dr. Anil Kumar sir to come to the dais. I would like to invite Dr. Anil Kumar, Organizing Chairman CSIK, for the welcome address.
Good morning. Good morning, everyone. It's a warm Sunday, and it's my privilege to welcome you to the inauguration of the annual conference of the Cardiological Society of India, Kerala Chapter, 2021. The COVID pandemic has been raging all over, and we all have forgotten our old normals. It's the new normal that we are all faced with, and it required a human, beyond human effort to organize a conference during this COVID pandemic. I'm sure we are seeing the lower end of the COVID pandemic, but still it required a superhuman effort from Dr. Joe and his team, and especially Mr. Anish also, to organize a conference. And I can see the success of this in the filling up of the hall on a Sunday morning. Thank you all. It's my privilege to welcome the national president. We, as Csi Kerala Chapter, has been lucky to have quite a few presidents, and we have the current president, Dr. P.P. Mohan, as a chief guest. Welcome, Dr. P.P. Mohan. One of the most eminent pediatric cardiologists and professor of Amrita Institute, Dr. Krishna Kumar, has been identified as one of the greatest scientists of the era. We are happy to have him as guest of honor today with us. Welcome, Dr. Krishna Kumar. We have a message from the Honorable Speaker of Kerala, Sri M.B. Rajesh. We are happy to have a look at his message soon into the inaugural function. Thank you, Honorable Speaker M.B. Rajesh. I especially welcome all the senior cardiologists, all the teachers who are present here and who are otherwise giving their valuable advice and comments live during this conference. A special welcome to all the seniors here. As senior a person as Dr. Vijay Raghavan was giving his valuable comments yesterday, and we have seen all the seniors contributing actively and making sure that the younger generation learns from them. I welcome all of them. I welcome the students and teachers who had participated in the World Heart Day program, and we are happy to give over the prizes to them. A special welcome to all the delegates who are here in person and making sure that this hybrid biosecure conference of Dr. Joe Joseph is a success. A special welcome to all of you. And welcome to all in the industry who have contributed to the success of this meeting and made this happen even at such a difficult juncture in the COVID pandemic phase. Thank you one and all. I hope you all had a very fruitful conference. Thank you.
Thank you, sir. We are moving to the inaugural ceremony, the lamp lighting ceremony function. So I request all delegates to please come forward and light the lamp.
All the people on the dais.
I request all of them on the dais to jointly light the lamp. A good applause. And on this blissful moment, I wish CSIK all the success in the future. You all. I would like to welcome Dr. Johnny Joseph, President, CSIK, for the presidential address.
Friends, it gives me immense pleasure to stand in this podium at this juncture after enjoying all the wonderful deliberations in the conference, which was conducted in a very enjoyable manner, seamless manner by the trio of Joe, Anil and Sulfi sir, with its content, the biosecure nature of the conference, and their immense energy to assemble at least almost 70% of the hall being filled, so that this is a really hybrid conference. Maybe first time after the COVID, we have all the opportunity to meet each other, see the family members of us, many of you, and enjoy the conference. So this is an icing in the cake of a bunch of activities we have done in the last 1 year, despite the COVID scenario, starting with the research initiative, research training, certification program, Chi's upgrading of the journal to a higher level, and also the other 2 or 3 conferences we have elegantly done, and also the fitness initiative, is the energy, the World Heart Day activities, a lot of things, World Heart Day activities, and finally this conference. And again, a lot of participation by the family members of our in the fitness as well as other programs of the entire year of this CSA activities. Only if one thing, and we had the wonderful president, the energetic president to guide us, and all the seniors to help us. And one thing I wish we had was the CSA building completed in this period. But unfortunately, it is not a reality in a good form right now. But I think it is in near future it will come. I must especially mention the Chacko sir's, Chacko sir's great energy, even in this age, running around here and there and organizing, stimulating all the people to finish at the earliest. And I think that will be the next great step for the CSA Kerala to come. And I remember the hard work of the many seniors, Giva sir, Venu sir, Mohan sir, everybody behind for the fundraising, also just the planning, and even the organization of the event. So that is one thing which we cannot do, and maybe our membership drive was we initially planned could not go into the full swing. Otherwise, whatever we have planned, it has been well executed. So that execution was by the Dr. Karinadas, the silent, efficient secretary, which I had the fortune, and also a vibrant number of executive committee members, Anil, Stiji, Joe, Shajan. So I am not mentioning all of us, everybody were contributed. So I think CSI has a great future, Kerala, stimulating a lot of scientific activities, research, and even social organizations. So with these few words, I declare that the conference is officially inaugurated. Thank you.
Thank you, sir, for that wonderful speech. Now I welcome our Honorable Chief Guest, Dr. P.P. Mohanan, National President CSI, for the inaugural address.
Look at the crowd. Now, we are in pre-COVID time, I think. Now, when Corona was a brand of beer, we all enjoyed, and physical distancing was your own idiosyncrasy. I think that augurs very well for us. I think in the months to come, we will have much more of these meetings, and CSI Kerala has been doing, I don't need to tell you about that. Even this last month when we had the last executive committee meeting, that was the occasion where the best branch award always was being selected. Kerala was right on top, but then as I even suggested that, the argument was, which was the state, which one? I think one of the northern state which never read, Jharkhand, or there. So everybody wanted to give a. Then I suggested, why don't you give something like a promising actor award? Why don't you select us? Because we have been doing wonderfully well every year, time and again, and thanks to Johnny, Karinadas, Manikanthan, of course, Joe, Anil, this has been a wonderful time for us, and I am sure every one of you would have enjoyed the deliberation and the hospitality. So, thank you very much from my heart, and I join you in felicitating this excellent meeting. Thank you.
Thank you so much, sir. Now we'll move on to speaker's message. Speaker's message will be played now.
പ്രിയപ്പെട്ടവരെ, കേരളത്തിലെ ഏറ്റവും പ്രധാനപ്പെട്ട മെഡിക്കൽ അക്കാഡമിക് സംഘടനകളിലൊന്നാണ് കാർഡിയോളജിക്കൽ സൊസൈറ്റി ഓഫ് ഇന്ത്യയുടെ കേരള ചാപ്റ്റർ. മാത്രമല്ല, കാർഡിയോളജിക്കൽ സൊസൈറ്റി ഓഫ് ഇന്ത്യയുടെ ഏറ്റവും സജീവമായ, ഏറ്റവും മികച്ച ചാപ്റ്ററുകളിലൊന്നാണ് കേരളത്തിലേത് എന്നും ഞാൻ മനസ്സിലാക്കുന്നു. 400ഓളം അംഗങ്ങളുള്ള വളരെ സജീവമായി അക്കാദമികമായ പ്രതിബദ്ധതയോടെ, പ്രൊഫഷണൽ പ്രതിബദ്ധതയോടെ പ്രവർത്തിക്കുകയും ഒപ്പം സാമൂഹിക പ്രതിബദ്ധത ഉയർത്തിപ്പിടിക്കുകയും ചെയ്യുന്ന ഒരു സംഘടനയാണ് CSIയുടെ കേരള ചാപ്റ്റർ എന്ന് ഞാൻ നിങ്ങളുടെ പ്രവർത്തനങ്ങളിലൂടെ മനസ്സിലാക്കിയിട്ടുണ്ട്. പ്രളയകാലത്ത്, അതിനുശേഷം കോവിഡ് മഹാമാരിയുടെ കാലത്ത് എല്ലാം മുഖ്യമന്ത്രിയുടെ ദുരിതാശ്വാസ ഫണ്ടിലേക്ക് സംഭാവന ചെയ്യുന്നതടക്കമുള്ള സാമൂഹിക പ്രതിബദ്ധതയുള്ള പ്രവർത്തനങ്ങളിൽ മുന്നിൽ നിന്ന ഒരു സംഘടന കൂടിയാണ് നിങ്ങളുടേത് എന്നതിൽ പ്രത്യേകമായ സന്തോഷവും അഭിമാനവുമുണ്ട്. ഡോക്ടർമാരുടെ ഒരു സംഘടന എന്ന നിലയിൽ സമൂഹത്തോട് പുലർത്തുന്ന ഈ ഉത്തരവാദിത്വം അഭിനന്ദനീയമാണ്. CSIയുടെ കേരള ചാപ്റ്ററിൻ്റെ വാർഷിക സമ്മേളനം നവംബർ 6-7 തീയതികളിൽ കൊച്ചിയിൽ നടക്കുകയാണ് എന്നും അറിഞ്ഞു. ഈ സമ്മേളനം നടക്കുന്നത് വളരെ സവിശേഷമായിട്ടുള്ള ഒരു സാഹചര്യത്തിലാണ്. കോവിഡിൻ്റെ പിടിയിൽ നിന്ന് പതുക്കെ കേരളം വിമുക്തമായിക്കൊണ്ടിരിക്കുകയാണ്. അത് ആശ്വാസകരമാണ്. എന്നാൽ അപ്പോഴും ജാഗ്രത നമുക്ക് കൈവിടാറായിട്ടില്ല. കോവിഡ് മഹാമാരി ആരോഗ്യരംഗത്ത് സൃഷ്ടിച്ച പ്രത്യാഘാതങ്ങളെക്കുറിച്ച് പൊതുവിലും പ്രത്യേകിച്ച് കോവിഡാനന്തര ഹൃദയ സംബന്ധമായ രോഗങ്ങളെക്കുറിച്ച് ഈ സമ്മേളനത്തിൽ വിദഗ്ധരായിട്ടുള്ള നിങ്ങൾ ചർച്ച ചെയ്യും എന്നാണ് ഞാൻ പ്രതീക്ഷിക്കുന്നത്. ധാരാളം ആശങ്കകൾ ജനങ്ങൾക്കിടയിൽ ഉയർന്നു വന്നിട്ടുണ്ട്. കോവിഡാനന്തര പ്രത്യാഘാതങ്ങൾ എന്ന നിലയിൽ അത് ഹൃദയത്തെ ബാധിക്കുന്നതിനെക്കുറിച്ച് ഒക്കെ ധാരാളം ആശങ്കകളുണ്ട്. കോവിഡിനെ തുടർന്ന് ഹൃദയ സംബന്ധമായ രോഗങ്ങളുടെ ഫലമായിട്ട് മരിക്കുന്നവരുടെ എണ്ണത്തിൽ വർധനവുണ്ടായതായിട്ട് പറഞ്ഞു കേൾക്കുന്നുണ്ട്. അത് എത്രത്തോളം ആധികാരികമാണ് തുടങ്ങിയ കാര്യങ്ങളെല്ലാം നിങ്ങളെപ്പോലുള്ള വിദഗ്ധർക്കേ പറയാനാവും. എങ്ങനെയാണ് കോവിഡും അതിനെ തുടർന്നുള്ള ആരോഗ്യ പ്രശ്നങ്ങളും ഹൃദയത്തെ ബാധിക്കുന്നത്, എങ്ങനെ പോസ്റ്റ് കോവിഡ് പ്രശ്നങ്ങളിൽ നിന്ന് ഹൃദയ ആരോഗ്യം നമുക്ക് സംരക്ഷിക്കാൻ കഴിയും, അത് ഉറപ്പുവരുത്താൻ കഴിയും, അത്തരം കാര്യങ്ങളിലെല്ലാം സമൂഹത്തിന് ഉൾക്കാഴ്ചയുള്ള മാർഗദർശനം നൽകാൻ നിങ്ങളുടെ സമ്മേളനത്തിന് കഴിയും എന്ന് ഞാൻ പ്രതീക്ഷിക്കുകയാണ്. കഴിയട്ടെ എന്ന് ആശംസിക്കുകയാണ്. ഹൃദ്രോഗ ചികിത്സാ രംഗത്ത് കേരളത്തിൻ്റെ മികവ് വളരെ ശ്രദ്ധേയമാണ്. ഇന്ത്യയിലെ തന്നെ ഏറ്റവും മികച്ച ഹൃദ്രോഗ ചികിത്സാ സൗകര്യങ്ങൾ, രോഗനിർണയ സംവിധാനങ്ങൾ എല്ലാം കേരളത്തിനുണ്ട്. ചികിത്സയിൽ മാത്രമല്ല, ഹൃദ്രോഗ പ്രതിരോധത്തിൻ്റെ കാര്യത്തിലും കേരളത്തിൻ്റെ സംവിധാനങ്ങൾ കാര്യക്ഷമമാണ്. ഹൃദ്രോഗ ചികിത്സയിലെ കേരളത്തിൻ്റെ മികവ് ഇന്ത്യയിൽ ഏറ്റവും മികച്ചതാണ് എന്ന് മാത്രമല്ല, പല വികസിത രാജ്യങ്ങൾക്കും ഒപ്പം നിൽക്കുന്നതുമാണ്. കേരളത്തിൻ്റെ പൊതുജനാരോഗ്യ രംഗത്ത് ഉണ്ടായിട്ടുള്ള കുതിപ്പിനൊപ്പം ഹൃദ്രോഗ ചികിത്സാ രംഗത്തും മുന്നേറാൻ കഴിഞ്ഞിട്ടുണ്ട് എന്നുള്ളതും വളരെ വളരെ അഭിമാനകരമാണ്. ധാരാളം വിദഗ്ധർ കേരളത്തിൽ തന്നെ ഈ രംഗത്ത് പ്രവർത്തിക്കുന്നുണ്ട്. അതിലൂടെ, ഈ മികവിലൂടെ, ഈ പ്രൊഫഷണൽ മികവിലൂടെ, കാര്യക്ഷമതയിലൂടെ ആയിരക്കണക്കിന് ജീവനുകളെയാണ് നമുക്ക് ഒരു വർഷം രക്ഷിക്കാൻ കഴിയുന്നത്. എന്നാൽ അതേസമയം കേരളത്തിൽ ഹൃദ്രോഗം ഉൾപ്പെടെയുള്ള ജീവിതശൈലി രോഗങ്ങളുടെ എണ്ണം ആശങ്കയുളവാക്കുന്ന വിധത്തിൽ വർദ്ധിക്കുന്നുണ്ട് എന്നത് നമ്മൾ കാണേണ്ടതാണ്. ഞാൻ ലോക ഹൃദയ ദിനത്തോടനുബന്ധിച്ചൊരു പരിപാടിയിൽ പങ്കെടുത്തപ്പോൾ അതിലുണ്ടായിരുന്ന ഒരു ഹൃദ്രോഗ വിദഗ്ധൻ പറഞ്ഞൊരു കാര്യം വളരെ ചിന്തോദ്ദീപകമായിട്ട് എനിക്ക് തോന്നി. അദ്ദേഹം പറഞ്ഞു, ആയുർദൈർഘ്യത്തിലുണ്ടാവുന്ന വർധനവ് ക്രമാനുഗതമായിട്ട് കൂടിക്കൊണ്ടിരിക്കുകയാണ്. ഇപ്പോൾ 20-ാം നൂറ്റാണ്ടിൻ്റെ തുടക്കത്തിൽ ഉണ്ടായിരുന്ന ആയുർദൈർഘ്യമല്ല 20-ാം നൂറ്റാണ്ടിൻ്റെ അവസാനമായപ്പോഴേക്കും 21-ാം നൂറ്റാണ്ടിൻ്റെ തുടക്കമായപ്പോഴേക്കുമൊക്കെ ഉണ്ടായിട്ടുള്ളത്. പൊതുവിൽ നമ്മുടെ പൊതുജനാരോഗ്യ സംവിധാനത്തിൻ്റെ, അതുപോലെ വികസിത ചികിത്സാ രംഗത്ത് ഒക്കെ ഉണ്ടായിട്ടുള്ള നേട്ടങ്ങളുടെ ഫലമായിട്ടാണ് ആയുർദൈർഘ്യം കൂടിയിട്ടുള്ളത്. ഈ 20-ാം നൂറ്റാണ്ടിൻ്റെ പകുതിയും അതിൻ്റെ അവസാനം 21-ാം നൂറ്റാണ്ടിൻ്റെ പകുതിയും ഒക്കെ ആകുമ്പോഴേക്കും ഇനിയും ആയുർദൈർഘ്യം കൂടും. അദ്ദേഹം പറഞ്ഞൊരു കാര്യം, ഇപ്പോഴത്തെ ചെറുപ്പക്കാർ പലരും 100-110 വയസ്സ് വരെ ജീവിച്ചിരിക്കേണ്ടവരാണ്. അത്രയും വലിയ ഒരു ജീവിതം അവരുടെ മുന്നിൽ കിടക്കുകയാണ്. അപ്പോൾ ഹൃദയ ആരോഗ്യ പ്രശ്നങ്ങളെ വേണ്ടതുപോലെ കണക്കിലെടുക്കാതെയോ ഹൃദയത്തെ അവഗണിച്ചോ ഒക്കെ അകാലത്തിൽ മൃത്യുവിനിരയായിത്തീരുന്നത് എത്ര വലിയ നഷ്ടമായിരിക്കും എന്ന് അദ്ദേഹം അവിടെ ചൂണ്ടിക്കാണിക്കുകയുണ്ടായി. അത് വളരെ ചിന്തോദ്ദീപകമായിട്ട് എനിക്ക് തോന്നി. അപ്പം അതുകൊണ്ട് തന്നെ കേരളത്തിൽ ഈ ഹൃദ്രോഗം ഉൾപ്പെടെയുള്ള ജീവിതശൈലി രോഗങ്ങൾ വർദ്ധിച്ച് വരുന്നതിനെ എങ്ങനെ തടയാം, അതിനെക്കുറിച്ച് വലിയ തോതിലുള്ള അവബോധം ഇപ്പോൾ ഉണ്ടാക്കാൻ കഴിഞ്ഞിട്ടുണ്ട്. അത് കുറേ കൂടി എങ്ങനെ നമുക്ക് ശക്തിപ്പെടുത്താൻ കഴിയും, ആ അവബോധ നിർമ്മിതി എത്രത്തോളം ശക്തിപ്പെടുത്താൻ കഴിയും, അത്തരം കാര്യങ്ങളും നിങ്ങളുടെ സമ്മേളനത്തിൻ്റെ ചർച്ചകൾക്ക് വിഷയമായി തീരും എന്ന് ഞാൻ വിചാരിക്കുകയാണ്. അതോടൊപ്പം ഇപ്പോൾ ഉയർന്നു വന്നിട്ടുള്ള മറ്റൊരു ആശങ്ക, വ്യായാമം, അമിതമായ വ്യായാമം ഹൃദയാരോഗ്യത്തെ ബാധിക്കുന്നതിനെക്കുറിച്ചും അപ്രതീക്ഷിതമായ ഞെട്ടിക്കുന്ന അകാലത്തിലുള്ള മരണങ്ങൾക്കിടയാക്കുന്നതിനെക്കുറിച്ചുള്ള ആശങ്ക വന്നിട്ടുണ്ട്. പ്രത്യേകിച്ച് കന്നഡയിലെ സിനിമാ താരത്തിൻ്റെ അകാല മൃത്യുവുമായിട്ട് ബന്ധപ്പെട്ട് വന്നിട്ടുള്ള വാർത്തകളുടെ ചർച്ചകളുടെയൊക്കെ പശ്ചാത്തലത്തിൽ അപ്പം അതിനെക്കുറിച്ചും ഒരു ശരിയായ അവബോധം, എങ്ങനെയാണ് വ്യായാമം ആരോഗ്യകരമായിട്ട് നടത്തുക, ഹൃദയ ആരോഗ്യത്തെ പരിഗണിച്ചുകൊണ്ടുള്ള വ്യായാമം, ഓരോരുത്തരുടെയും ശരീരത്തിന് ഒക്കെ ഇണങ്ങുന്ന തരത്തിലുള്ള വ്യായാമമുണ്ട്. ഇത്തരം കാര്യങ്ങളിലേക്കെല്ലാം വെളിച്ചം വീശാനും ഒരു ബഹുജന വിദ്യാഭ്യാസത്തിനും ഉതകുന്ന ഒരു സമീപനം അല്ലെങ്കിൽ അതിനുതകുന്ന മെറ്റീരിയൽസ് നിങ്ങളുടെ സമ്മേളനത്തിൽ നിന്ന് ഉയർന്നു വരും എന്ന് ഞാൻ പ്രതീക്ഷിക്കുന്നു. ഈ സമ്മേളനത്തിന് എല്ലാ ആശംസകളും ഞാൻ അറിയിക്കുന്നു.
Thank you, sir. So I invite Dr. Karunada CP, Secretary, CSIK, for the felicitation.
Respected seniors and dear friends, when we planned this meeting, we were skeptical whether it will come out successful. But 93 people have registered, and yesterday there were 167 people online attending this meeting. So I think the meeting is a success. I thank each and every one of you for attending this meeting. Thank you.
Thank you, sir. Now I invite Dr. Zulfikar Ahmed, Chairman, Scientific Committee, for introducing our guest of honor, Dr. Krishna Kumar.
Good morning. I think Dr. R. Krishna Kumar, the head of pediatric cardiology, AIMS Kochi, has been billed as one of the 2% top scientists in the world by Scopus. I would describe Krishna Kumar as a pan-Indian. He had roots in Kerala which run very deep. His great-grandfather was Diwan Peshkar of Maharaja of Travancore. KK had his schooling all over India, especially the eastern India, I suppose. And his medical schooling was in Delhi, in the northern part of India, MBBS from AMAMS and MD and DM from All India Institute. He had his fellowship in pediatric cardiology from the Boston, and he established a holistic pediatric cardiology services, which we all know, at Amrita in 1998. Now basically he has returned to Kerala and has been here for more than a couple of decades. So it's almost like a return of the native. And he has outstanding success as an academician. He had edited Anderson's textbook of pediatrics, which happens to be one of the two major textbooks on pediatric cardiology. Tandon's textbook of cardiology you must be aware of. And recently for pediatric cardiology, IAP textbook of pediatric cardiology also. And I was privileged to be his co-editor in that endeavor. He is also an accomplished researcher, including RFRHD, which is very dear to many of us, and an amazing interventional pediatric cardiologist, would be characterized as I'd always consider him as a philosopher among cardiologists and a mentor of many young men and women who would definitely vouch for his that capability. And unarguably a multifaceted individual, And most importantly, I want to describe him as a very sound, innovative and safe interventionist. And Shakespeare, when he was very young, he wrote Hamlet, and he said, readiness is all. When he became older, he wrote King Lear, which is equally good, who wrote ripeness is all. I think these 2 points, these apparently contradictory, but actually complementary attributes best describe KK as a cardiologist, as a pediatric cardiologist. So my friends, colleagues and my teachers, I hereby introduce to you Dr. R. Krishna Kumar, who by rank is Head of Pediatric Cardiology Services at Amrita, by service a great interpreter of and healer of cardiac maladies in children, and by quality an extraordinary gentleman who belongs to an elite league. And I would invite him to come to the dais, and I would request our beloved PP Mohan, I think, to honor him suitably. Thank you. I would like to talk. I'll request KK to reply to us. What?
I've got exactly 2 minutes to give a reply as per your speculation. Well, anyway, thank you so much. I just want to read that WhatsApp message that I typed when there was some discussion in this group. To be honest, this award means very little to me. What matters more is the respect, the kinship, the friendship that I have, and the camaraderie that I have with the fraternity in Kerala. And that's far more important, and I think that's much more valuable than these recognitions by people who don't exactly know your work. So I just want to say what I've written out here. I have to say I've been very lucky to work with some exceptionally talented colleagues at Amrita, and who have enabled, actually what's been unique about our research is that we integrated all our clinical work, which we tried to do with highest quality, and integrated with research, and that's how the research output happened. So this mask that I'm wearing right now has been designed by my colleague Mahesh, who has a 3D printing lab and who's actually much more of an innovator than I am. So I've been very lucky. It's just that I've stayed long enough, so I accumulated the credit. I've been part of many multi-authored papers, including the paper on Hridayam that we've written for the state of Kerala, which I shared in the group. So I just think it's only because of all this that I've got this credit, but the honor really should be shared by everybody who's been working with me. And I think I could not have achieved this anywhere else other than the state of Kerala, not because we're saying good things about Kerala today, but the fact is that there isn't another part of the country where you can actually do this quality of work and be appreciated and liked by all your colleagues for doing that. That's unusual. So with that, thank you again.
Thank you so much, sir. So now I would like to invite Dr. Sajjan Ahmed to announce the names of the members who actively conducted the World Heart Day activities.
Good morning, dear teachers and friends. My pleasant task to announce the names of our members who have actively conducted the World Heart Day events, especially the cycling and kayaking, as envisaged by our President, Dr. Johnny Joseph, sir. May I invite each person to come on stage and accept the honor from our President. Dr. Sujay Ranga from Kollam, please. Thank you. Dr. Rachel Daniel again from Kollam. Dr. Abhilash TG from Kollam. I think fitness was the motto of our president this year, so thank you. Dr. Tradeep Sagar from Thrissur. Thank you. Dr. Srijit V from Talasheri. Our organizing secretary himself, Dr. Joe Joseph from Kochi.
Let's give a big applause for all of them.
Dr. Jimmy George from Kochi. Dr. Jayesh Bhaskaran from Kozhikode. Dr. Sajir Keti from Kozhikode and Dr. Joby K. Thomas from Kottayam. I think Dr. Srijit V from Talasheri is here. Okay. Thank you so much.
Thank you, Dr. Sajid Ahmed, and congratulations to all the winners.
Just a comment for Dr. Srijit for appreciation for the innovative way incorporating the children of the patients who had ACS for the World Heart Day activities. Just a minute.
Thank you, sir. So now I invite Dr. Anil Balachandran to announce the winners of online heart competition for kids.
Yeah, respected dignitaries on the dais and dear friends, former American President John F. Kennedy once told, children are living messages that we send to a time which we may not even witness. That was the whole concept behind organizing an online painting competition for the younger minds. And in one of our earlier meetings, we thought at least if we get around 50 entries, it would be a big success. But we were taken to surprise by around 500 entries for the painting competition. And our own Superman, Anish, had a tough time in organizing the whole stuff. And we had a elegant panel of judges, which involved a professional doctor, a plastic surgeon by profession, who is a artist by passion. So that was the whole idea behind Dil Se, as the tagline says, there is art in every heart, and I think most of us agree to that after the heartwarming talk by Dr. Tiny Nair sir. And I am happy to announce the winners. In the junior session, I invite Dr. Mohan sir to give away the prizes.
I request Dr. Mohan sir to please distribute the prize to the winners.
Yeah, in the junior session, first is Sain Hamdan. He's a first standard student from Vidyodaya School, Cochin. You can just witness their artworks in the screen.
Let's all give them a big applause to him.
Thank you, Sain, and congrats. And second prize, unfortunately, it's an overseas entry from Doha, Diya Vinod. She's a fifth standard student. Third prize in this category goes to Aradhya Suhesh from Vidyodaya School, Cochin. You can witness the creativity of the young minds at work. In the senior session, we have Gada Gopakumar of Vidyadaya School, Cochin. The second prize goes to Jane Mariam Jacob of Essentra School, Kollam. Third prize goes to Paul Basil of Vidyadaya School, Cochin. I'm just taking one more minute of yours. After the judging panel we had done a very meticulous judging, in the sense that we masked the name and school of every painting sent to the judging panel. But after the judgment, they told a special mention to one particular school, that is Vidyodaya School, Cochin. They had sent a mammoth 40 entries, and according to the judging panel, each one were better than the other. And you could see in the total price list, they have occupied a big share. But that is because of their quality. So as they say, it is the teacher and not the classroom who makes the difference. So we we unanimously decided to honor the mentor of the students, Mrs. Sina Margaret. Madam, can you please come to the stage? Thank you so much.
Thank you, sir, and congratulations to all the young minds, and thank you, ma'am, for being a part of CSI. So now I would like to invite Dr. Joe Joseph for the vote of thanks.
Best Paper Award. Best Paper Award by Dr. Sulfikar.
Yeah, before that, there is a Best Paper Award session, awards. I invite Dr. Sulfikar to announce the results.
Thank you, Joe. I think we had actually wonderful response to this. 22 papers had come from Kerala. I think it's very difficult to screen them and make it into 4, so we made it 6. And I would just like to announce the winners. First is influence of age at surgery on LV strain in Al-Kappa patients. Csi Kiran from ACT IMST, Trivandrum. That is first place. Second is a Trivandrum heart failure survey study by Himanshu Rana, Government Medical College, Trivandrum. And we have the third place. It's a comparative study of RFR with FFR to determine the physiological significance of intermediate coronary stenosis by Vinod Thomas, Lisi Hospital, Kochi. And Vivek is right now here, so I would request Dr. Johnny to award him the certificate and the cash prize.
Dr. Vinod Thomas, please come to the dais. Congratulations. Thank you, sir.
അല്പം വ്യത്യസ്തമായിട്ട് മലയാളത്തിൽ തന്നെ സംസാരിക്കാമെന്ന് തോന്നുന്നു. കാരണം മലയാളം എൻ്റെ ഹൃദയഭാഷയാണ്. ഹൃദയത്തിൽ വരുന്ന എന്തെങ്കിലും സംസാരിക്കണമെങ്കിൽ മലയാളം മാത്രമേ പറ്റൂ. അതുകൊണ്ട് മാത്രമാണ്. എല്ലാവർക്കും വളരെ നന്ദിയുണ്ട്. കാരണം വെച്ചാൽ ഇങ്ങനെയൊരു കോൺഫറൻസ് ഓർഗനൈസ് ചെയ്യുക ഈ ബുദ്ധിമുട്ടേറിയ സമയത്ത് ഒരു മാസം മുമ്പ് CSIയുടെ എക്സിക്യൂട്ടീവ് കമ്മിറ്റി ഏൽപ്പിച്ചപ്പോഴത്തേക്ക് യാതൊരു സംശയവും എനിക്കില്ലായിരുന്നു. കാരണം എന്താണെന്ന് വെച്ചാൽ വളരെ വൈബ്രൻ്റ് ആയിട്ടൊരു പ്രസിഡൻറ്റും അതോടൊപ്പം തന്നെ നിൽക്കുന്ന ഒരു സെക്രട്ടറിയും എക്സിക്യൂട്ടീവ് മെമ്പേഴ്സും എല്ലാം ഉള്ളപ്പോഴത്തേക്ക് ഒരു കോൺഫറൻസ് ഓർഗനൈസ് ചെയ്യുക വളരെ ചെറിയൊരു ടാസ്ക് മാത്രമായിരുന്നു. പക്ഷേ നിങ്ങളുടെ എല്ലാവരുടെയും സഹകരണമാണ് ഈ കോൺഫറൻസിനെ ഏറ്റവും വലിയ മികച്ചതാക്കി മാറ്റിയെന്ന് എനിക്ക് ഉറപ്പുണ്ട്. കാരണം ഞാൻ പ്രതീക്ഷിക്കുന്നതിനേക്കാട്ടും കൂടുതൽ ആളുകൾ എത്തി. ഒരു 70, 65, 70. അനീഷോട് പറഞ്ഞപ്പോൾ അനീഷ് അത്രയൊന്നും വരത്തില്ല സാറേ, 30 പേരെ കൂട്ടിയാൽ മതി എന്ന് പറഞ്ഞു. ഞാൻ പറഞ്ഞില്ല അനീഷ്, ഒരു 75 പേരെ വരും ഞാൻ പറഞ്ഞിട്ടുണ്ടായിരുന്നു. പക്ഷേ 93, 95, 100ഓളം ആളുകൾ ഈ കോൺഫറൻസിൽ ഇന്നിവിടെ രജിസ്റ്റർ ചെയ്തിട്ടുണ്ട്. അതുതന്നെ നമ്മളെല്ലാവരും എത്രമാത്രം ഈ കോൺഫറൻസ് ഒന്നാകാനും നമ്മൾ പരസ്പരം സഹകരിക്കാനും പരസ്പരം കാണാനുമായിട്ട് ആഗ്രഹിച്ചതിന് തെളിവാണ്. അതുകൊണ്ട് തന്നെ ഈ കോൺഫറൻസ് ഏറ്റവും മികച്ചതാക്കിയ നിങ്ങളെല്ലാവർക്കും ഹൃദയത്തിൻ്റെ ഭാഷയിൽ ഞാൻ നന്ദി പറയുന്നു. അതോടൊപ്പം തന്നെയാണ് ഏതൊരു കോൺഫറൻസിൻ്റെയും സഹായിക്കാനായിട്ട് അനേകരുണ്ട്. എല്ലാ ഇൻഡസ്ട്രിയോടും വളരെയധികം നന്ദി. വളരെ കുറച്ച് പേരെ മാത്രമേ നമുക്ക് ഇൻവോൾവ് ചെയ്യേണ്ട ആവശ്യം വന്നിട്ടുള്ളൂ. പക്ഷേ പറഞ്ഞതനുസരിച്ച് എല്ലാ കാര്യങ്ങളിലും അവർ ആദ്യം മുതൽ എൻ്റെ കൂടെ നിന്നു. അതുകൊണ്ട് എല്ലാ ഇൻഡസ്ട്രിയൽ റെപ്രസെൻറ്റേറ്റീവ്സിനോടും എൻ്റെ ഹൃദയത്തിൻ്റെ ഭാഷയിൽ നന്ദി പറയുന്നു. അതുപോലെ തന്നെ എല്ലാ വെണ്ടേഴ്സും എല്ലാവരെയും പ്രത്യേകിച്ച് ഒരു കൃതജ്ഞത പറയുന്നു. പ്രത്യേകിച്ച് 1-2 പേരുടെ പേരെടുത്ത് പറയാതിരിക്കുക എന്താന്ന് തോന്നുന്നു. ഒന്ന് അനീഷാണ് നമ്മുടെ എല്ലാത്തിൻ്റെയും സഹായിക്കുന്നത്. അനീഷിന് പ്രത്യേകം നന്ദി പറയുന്നു. മോസസിൻ്റെ ടീമും അതുപോലെ തന്നെ നീലിമ, എല്ലാവരുടെയും ഹൃദയത്തിൻ്റെ ഭാഷയിൽ നന്ദി പറയുന്നു. നമുക്ക് ഇനിയും ഇങ്ങനത്തുള്ള കോൺഫറൻസുകൾ ഓർഗനൈസ് ചെയ്യാൻ പറ്റുകയും ഇനിയും കുറച്ചുകൂടി മുമ്പോട്ട് പോകാൻ പറ്റട്ടെ എന്ന് ആശംസിക്കുന്നു. പ്രത്യേകിച്ച് നമ്മുടെ CSI വളരെ ആക്റ്റീവ് ആയിക്കൊണ്ടിരിക്കുകയാണ്, എനർജറ്റിക് ആയിക്കൊണ്ടിരിക്കുകയാണ്. ഇന്ത്യയിലെ തന്നെ ഏറ്റവും മികച്ച CSIകളൊന്നായി മാറിക്കൊണ്ടിരിക്കുകയാണ്. അതുകൊണ്ട് തന്നെ ഈ ഒരു അവസരം CSI എനിക്ക് തന്നതിനും അതുപോലെ തന്നെ ഈ കോൺഫറൻസ് ഇത്രയും സക്സസ്ഫുൾ ആയിട്ട് നടത്താൻ സഹായിച്ച നിങ്ങൾക്ക് ഓരോരുത്തരും ഹൃദയത്തിൻ്റെ ഭാഷയിൽ നന്ദി പറഞ്ഞുകൊണ്ട് ഞാൻ നിർത്തുന്നു. അവസാനം ഞാൻ ആരെയെങ്കിലും മിസ്സായിട്ടുണ്ടെങ്കിൽ എന്നോട് ക്ഷമിക്കുക, അത് സമയത്തിൻ്റെ പരിമിതി മാത്രമാണെന്ന് കരുതുക. താങ്ക് യു സോ മച്ച്.
Thank you, sir. Thank you so much for your wonderful speech.
We'll move.
And we are concluding the inaugural ceremony. We are going back to the formal sessions of the CSIK. Thank you all. We have come to another very important session of the conference, Presidential Oration by Dr. Johnny Joseph. I invite the chairpersons, Dr. Koshi Epen, Dr. Krishna Kumar R and Dr. Sajeev CG to the dais.
laser pointer
Our dear colleagues, me and Dr. Krishna Kumar welcome you all to this yet another prestigious session of today's program. It is none other than the presidential oration. We are unique in the sense that we have both our national president and our Kerala chapter president are giving their respective orations. Dr. Johnny does not require any formal introduction, but however, being a senior member of the CSI, I would like to say a few things about him. Dr. Johnny, if you just ask me, I will say that the first impression of Dr. Johnny is of a very soft-spoken, ever-smiling, and also a nice personality, a highly, I should say a personality which we everybody will adore to. But at the same time, he is a resilient personality who can just withstand and face any sort of situations with extreme calmness. As a president of Csi Kerala Chapter, his contributions are well accepted and appreciated by all the members of CSI. Out of this, I just want to say one thing, that is the fitness program which he has initiated, which was well accepted and taken by all the members of the CSI, and it has done wonders in the energy as well as the fitness capacity of all the members and the families. I also want to say that Dr. Johnny is a person who is a motivator and also an inspiration to all the younger colleagues, and he always makes sure that they get the best training, and he is also instigate them in the field of research. As it is customary to say few things about the biodata of the Dr. Johnny, I'll just say a few things which has been presented to me. He is at present working as the head of the Department of Caritas Heart Institute, Kottayam. He has been working uninterrupted there for the past 25 years since 1995. He does both interventional and non-interventional work. He belongs to the 1997 MBBS batch, and he did his MD and DM from Medical College, Kottayam. He was also the past president of the Indian Academy of Echocardiography Kerala Chapter. He was also a principal investigator of the 2 coveted registries conducted by Csi Kerala. His special interest is in research, fitness of sorts, and as well as in literature. His better half is Mrs. Rani, who is a homemaker, and he is blessed with 2 children, and Mr. Annu Jose, who is a pediatrician, and Appu, he is a computer engineer. Now may I ask and request Dr. Johnny to give the oration.
Dr. Sajeev is joining on.
Okay, Dr. Sajeev,
He's, the third chairperson is Dr. Sajeev, who is joining online for this session from Calicut.
Yeah, very good morning to all and respected seniors and dear friends. As you know, Dr. Jody Joseph is a very active member of the CSI, and especially for the last 2 years when he was vice president and subsequently the president of the CSI. He was instrumental in promoting the exercise training programs, as has already been mentioned, and it is also my pride and our privilege to say that he was our 1977 part-time batch and he's my classmate. And over to you, Dr. Jody, for your speech.
Thank you, the most gentleman cardiologist, Kochi sir, the most renowned scientist, Kumar sir, and Dr. Sajeev, my classmate, MBBS classmate, and very close friend, and respected teachers and my dear friends. I have coined the heading as bench to bedside stories, because after 2 hectic days of conferencing, I am sure you are tired. Let us hear some stories. As Harari said, man is an animal who loves stories, creates stories, believes in other stories, and make others to believe your story. So let me start with my story. Again, this bench to bedside. ആർട്ടിസ്റ്റിക് ആണെന്നാണ് ചൈനീസ് സാർ പറഞ്ഞത്. ഒരു മലയുടെ താഴ്വരയിലെ ഒരു കാട്ടാറിൻ കരയിലുള്ള ഈ ഗ്രാമത്തിൽ ജനിച്ച് ഞാൻ ഈ ഗവൺമെൻറ് സ്കൂളിൽ പഠിച്ച് മഹാരാജ് കോളേജിലും സെൻറ് തോമസിലും അല്ലെങ്കിൽ മെഡിക്കൽ കോളേജും വഴി പട്ടത്തുള്ള SUT ഹോസ്പിറ്റലിൽ ആദ്യം എത്തിച്ചേരുമ്പോൾ അല്ലെങ്കിൽ പിന്നീട് കാരിത്താസിൽ എത്തുമ്പോൾ ആ സ്റ്റോറിയുടെ കാര്യങ്ങൾ അതിൻ്റെ അധികം ഇല്ല. അത് നിങ്ങളെപ്പോൾ തന്നെ എല്ലാവരുടെയും പോലെ തന്നെയാണ്. ജോ പറഞ്ഞത് ഞാൻ മലയാളത്തിലാക്കാൻ ശ്രമിക്കാം, എനിക്ക് ഇംഗ്ലീഷാണ് കൂടുതൽ വശമെങ്കിൽ മലയാളത്തിൽ പറയാൻ ശ്രമിക്കാം. So the transforming the bench to bedside is really what I am highlight is transforming our own research for our own day-to-day practice. That is a simplistic form of translation research, because you know, from academics into the communities takes about 17.4 years for a concept from the basic research to come to the society for the benefit of the society. That is the standard. But COVID was, at time of COVID, we have seen it is much shortened. And this I would say the type 2 of bench to bedside. പക്ഷേ നമ്മുടെ ലൈഫ്സ്റ്റൈലിനെ മാറ്റണം, അല്ലെങ്കിൽ മാറ്റും അവകളി നമ്മളെ താൻ എന്നുള്ളത് നമുക്ക് എല്ലാവർക്കും അറിയാവുന്നതാണ്. എന്നെ തന്നെ നോക്കുക, ഇൻ ബാസ്കറ്റ്ബോൾ ടീം ഹി വാസ് ലീൻ and after about 10-25 years my mother ridiculing me on my tummy. And this is not the recent phenomenon. We can see the manager and coach of our team, Vijayan sir, our surgery professor, who was a state basketball player, after 15 years in the bench from the academics, he has changed. And again the person sitting in front, Sardi Mohan, died in South Africa at the prime age of 95. Despite his great physique, he was a smoker. So with these few words, I dedicate this figure, as Chinese sir has said, that is by Auguste Rodin, the ഉയർന്ന ചിന്തയും ഉറച്ച ശരീരവും എന്നുള്ള കൺസെപ്റ്റ് നിങ്ങളുടെ നെക്സ്റ്റ് ജനറേഷന് വേണ്ടി ഞാൻ വെക്കുകയാണ്. ഇതൊക്കെ പറയാൻ എളുപ്പമാണ്, കാരണം അഗസ്റ്റേ റോഡിൽ തന്നെ അവസാനം ഡയബറ്റിക് ആയിരുന്നു, നല്ല വയറുണ്ടായിരുന്നു. സോ ഐ വിൽ കൺസിഡർ the motivation and fast track translation as transformation of cardiology as a coin. I would like to answer a term I would like to coin. And all throughout my career, I had been a silent research partner to many of studies which I enjoyed, including Dabigatran, Apixaban, Doxaban international studies and some quality improvement program. And one thing I learned was the importance of data quality when I was criticized by the CROs and all. Second is the gap study which was never completed. I knew the right question asked the communication between the basics research and the clinician is a study. Monte Carlo meeting so right question for research is very important. And Nammude president, the vibrant president, connected all of us into the research, state level, national level and international level. As the ACC president has said, the research it is the journey that is important, the process that is important than the final, your publication or results. You enjoy that journey, you are through. And ഞാനിത് പറയാൻ പോകുന്നത് വിജയത്തിൻ്റെ കഥകളല്ല, കൂടുതലും പരാജയത്തിൻ്റെ കഥകളാണ്. അതിൻ്റെ അകത്ത് അറിഞ്ഞതിൽ പാതി പറയാതെ പോയി, പറഞ്ഞതിൽ പാതി പതിരായും പോയി എന്നുള്ള ഒരു ശോക മൂടുണ്ടെങ്കിലും യു ക്യാൻ ലിസൺ ടു ദാറ്റ്. ആദ്യത്തെ ഞാൻ കാരിത്താസ് ജോയിൻ ചെയ്യുമ്പോഴേ ഒരു കമ്മ്യൂണിറ്റി അവിടെ കണ്ടു. 100 പേരോട് ഒരേ സ്ഥലത്ത് തന്നെ താമസിക്കുന്നു. സോ ഐ ഫൗണ്ട് ദ ഓപ്പർച്യൂണിറ്റി ഫോർ എ നാച്ചുറൽ സ്റ്റഡി. അന്നൊക്കെ ഈ പറഞ്ഞ ഡയറ്റും ഭയങ്കരമായിട്ട് കത്തി നിൽക്കുന്ന സമയമാണ്, റിവേഴ്സ് ചെയ്യുക എന്നൊക്കെ പറഞ്ഞ്. സോ അവരുടെ നൊയമ്പ് വീഴുന്നതിന് മുമ്പ്, അത് ക്രിസ്മസ് നൊയമ്പിന് മുമ്പ് ശേഷവും ലൈപ്പിഡ്സ് എടുത്ത് കാര്യമായി ചേഞ്ച് ചെയ്താൽ തന്നെ അവർ സംഭവവും അവരുടെ 30 തേങ്ങ കാൻറ്റീനിലേത് 7 തേങ്ങയ്ക്ക് കുറയ്ക്കാനും കോക്കനട്ട് ഓയിൽ 70% ശ്രമിക്കാനും അവർ സമ്മതിച്ചു. പക്ഷേ ഒരു മാസമായപ്പോഴത്തേക്കും മദർ സുപ്പീരിയർ പറഞ്ഞു, സാറേ ഇതിഞ്ഞി മുന്നോട്ട് പോയാൽ ഞങ്ങൾക്ക് നുണ പറയേണ്ടി വരും, സാറിന് നുണ പറയേണ്ടി വരും. കാരണം ഒത്തിരി പേരും വീട്ടിലേക്ക് ഇടയ്ക്കിടയ്ക്ക് പോകുന്നുണ്ട്, പൊതികൾ വരുന്നുണ്ട്. സോ ഐ ന്യൂ ഹൗ ഡിഫിക്കൽട്ട് ഈസ് എ നാച്ചുറൽ social diet or exercise trial to be completed. And second is I had a മനോരമയിലെ 600 എംപ്ലോയീസ് ഒരിക്കൽ ചെക്കപ്പിന് വന്നു, ഫുൾ ചെക്കപ്പ് നടന്നു, കൗൺസിലിംഗ് നടത്തു. ദെൻ അതിൻ്റെ അകത്ത് കുറച്ച് 4 വർഷം കഴിഞ്ഞപ്പോൾ അതേ ആൾക്കാർ 450 പേര് വീണ്ടും റിപ്പീറ്റ് ചെക്കപ്പിന് വന്നു. ഒരു 325 പേര് 3-ാം വർഷം വന്നു. I found that the serum cholesterol level was rising up. I told them that we have an opportunity like a Framingham study at least 300 ആൾക്കാരുടെ ഒരു 15 വർഷത്തേക്ക് ഇത് ചെയ്യാം. സംഗതിയൊക്കെ തിയറിയിലൊക്കെ നടന്നു. പക്ഷേ അത് കഴിഞ്ഞ ഇൻസ്റ്റിറ്റ്യൂഷൻസ് തമ്മിലുള്ള ആ ഒരു ട്രാൻസാക്ഷൻ്റെ പാർട്ടായിട്ട് മറ്റ് ഹോസ്പിറ്റൽസിലോട് എല്ലാ ആൾക്കാരെ വിട്ടു തുടങ്ങി. അതോടെ അതും മുന്നോട്ട് പോകാൻ പറ്റിയില്ല. പക്ഷേ വൺ തിങ് ഐ നോട്ടഡ് വാസ് the lab values. In the lab value, I thought it's a lab error, but the SGPT level was initially rising. I did not know about the fatty liver concept at that time. I probably think that was a pointer. So again, I would like to something practically important, because you all know how important it is to have a central line for emergency blind pacing or fluid administration or a drug administration. Supraclavicular subclavian approach aimed at hitting the junction of the jugular vein and the subclavian vein above the clavicle is a simple way, shorter distance, straighter path, fewer pleural or arterial puncture. And the great thing is that you can continue your CPR while somebody is attempting. I have done it many times. And the direction is simple. Just bisect the angle between the sternal head of the sternocleidomastoid and the clavicle. Adine 1 centimeter lateral എന്നൊക്കെ പറയുന്നുണ്ട്. But I will show in the next slide that just depress the angle between your index finger. To the tip of the index finger, you poke your local needle. ആ ലോക്കലിൽ തന്നെ നിങ്ങൾക്ക് ഫ്ലഷ് കിട്ടും. കാരണം സോ സൂപ്പർഫിഷ്യൽ ആൻഡ് ഒത്തിരി ഏരിയ ഉണ്ട്. അങ്ങോട്ടോ താഴോട്ടോ മുകളിലോട്ടോ തെങ്ങോട്ട് മാറിയാലും നമ്മൾ എവിടെയെങ്കിലും ഒന്നെങ്കിൽ സബ്ക്ലേവിൻ അല്ലെങ്കിൽ കോൺഫറൻസ് അല്ലെങ്കിൽ IJV എത്തും. ആൻഡ് ഇഫ് യു ലുക്ക് അറ്റ് ദ ലിറ്ററേച്ചർ യു ഫൈൻഡ് ദാറ്റ് ഇനീഷ്യലി ദർ വർ ലോട്ട് ഓഫ് സ്റ്റഡീസ്. അതിൽ ജെയിംസിൻ്റെ സ്റ്റഡി ആ 3000ൻ്റെ നമ്പർ നോക്കുക. ബിഗ് ഗുഡ് സ്റ്റഡി, ഗുഡ് സക്സസ് റേറ്റ് ആൻഡ് ലോ കോംപ്ലിക്കേഷൻ. ആൻഡ് അഗൈൻ എ കമ്പാരിറ്റീവ് സ്റ്റഡി ബൈ comparative study by Sterner, supra versus infra, 84% higher success rate, lower complication. And I am sure in every institution, at least a short story of either of anesthetist or intensivist, നമ്മൾ ഒരു പേഷ്യൻറ്റിനെ മിസ് ചെയ്തതിൻ്റെ പാർട്ടായിട്ട് either a pneumothorax or a non-compressible thing. Either coming back to my experience, it is not a data, compared data. I have presented 16 of blind pacing in 1998 in this forum itself. But overall, my experience may be more than 300 plus, 95 success rate, no pneumothorax, less than 2% anterior puncture, even after no complication, even after those days of thrombolysis. And nowadays, you have if you have the luxury of a linear probe, you can just identify the IJB software. They can compress down, go down and identify the brachiocephalic subclavian junction, and you can direct other. And I am only just learning because even recently, despite a wire in the infraclavicular subclavian and peripheral injection, I struggled hard to get a permanent pacing puncture. So I think the youngsters can reinvent this procedure. Then coming to an ethics of a drug challenge, 1999 times a lady came with the bradycardia, hypertension, VPCs, could have been died. And the same week another lady came, brought in an ambulance, brady, same scenario improved. Both patients were there. George sir അറിയാം, with a great history taker. Sir find out ഇത് രണ്ടുപേരും വെട്ടുമാരെന്ന് പറഞ്ഞൊരു ഗുളിക കഴിക്കുന്നു. Then next time we had another lady from the somewhat the same locality. സാർ അങ്ങോട്ട് ചോദിച്ചു, വെട്ടുമാരൻ കഴിച്ചു ഇതേ? She said, കഴിച്ചു, പക്ഷേ I have been taking it on and off. It is not there. She argued. She was a teacher. And the Ayurvedic physician also was confident. And she said, yes, he's ready to take it again. Anyway, patient improved, took back to ICU, mounted halter, വെട്ടുമാരൻ എടുത്തു, senior തന്നെ. And we researched and found out that it was Ashokan, which was, if it is not well prepared in the process, such as alkaloid aconite, with digitized side effect. So we presented that in Thrissur CSI that year, got experience of same cases from Alleppey and Thrissur nearby. So the batch of the drug was it was dangerous, but we got criticized for not having an ethics committee approval. They were right. I just argued, but they were right. We then constituted with the retired Madhu sir as the DME, as the chairperson, we constituted an ethics committee, which was good for us for a long time. So, പിന്നെ റിസർച്ചിൽ അല്പം ഒരു ഹ്യൂമർ വരുത്തുന്നൊരു കാര്യമാണ്. ഞങ്ങളെയൊക്കെ ഈ ചെക്കപ്പ് പ്രോഗ്രാംസ് വിളിക്കുമ്പോൾ അത് ഡിസ്വേഡ് ചെയ്യാനായിട്ട് ഞങ്ങൾ പറയുമായിരുന്നു, നിങ്ങൾ അവിടെ ലോക്കൽ റിസർച്ച് നടത്തുക, ഒരു സർവേ നടത്തിയിട്ടേ ഞങ്ങൾ വരുവുള്ളൂ എന്ന്. അങ്ങനെ കുറേയൊക്കെ ഒഴിഞ്ഞു പോകും. പക്ഷേ ദിസ് വാസ് എ വെൽ കണ്ടക്റ്റഡ് പ്രോഗ്രാം ബൈ കോട്ടയം ഹാർട്ട് ക്ലബ്, സെൻറ് തോമസ് കോളേജ് പാല, സ്റ്റാറ്റിസ്റ്റിക്കൽ ഡിപ്പാർട്ട്മെൻറ്റ് ആൻഡ് അലുമിനി, ആൻഡ് ഒരു ലാർജ് ക്വസ്റ്റനെയർ ഓർ fully done in 2 wards in Muthodi Panchayat around 2003. We had some important points like one that I almost never check BP rising compared to the high diabetic control. The most important thing is that the interesting thing is that BMA in the Kedikala Menaked just answer the question, near question ഉണ്ടായിരുന്നു. യേശു ക്രിസ്തുവിൻ്റെ പോലെയാണോ നിങ്ങളുടെ വയറ്, മോഹൻലാലിൻ്റെ പോലെയോ, അന്നത്തെ മോഹൻലാലിൻ്റെ പോലെയാണോ, പറവൂർ ഭരതൻ്റെ പോലെയാണോ എന്ന്. സോ ഐ കണ്ടെയ്ൻ എ ലോട്ട് ഓഫ് ഇൻട്രസ്റ്റ്. ആൻഡ് ഈ 25 years കഴിഞ്ഞ് സിഡ്നിയിൽ നിന്ന് എനിക്കൊരു കോൾ വന്നു, സാറേ ഞാൻ സ്റ്റാറ്റിസ്റ്റിക്സ് ഡിപ്പാർട്ട്മെൻറ്റ് ഉണ്ടായിരുന്ന ഒരു സ്റ്റുഡൻ്റാണ്, ഞാനിപ്പോൾ ഇവിടുത്തെ മെൽബൺ യൂണിവേഴ്സിറ്റിയുടെ ഒരു വലിയ ചീഫ് കോർഡിനേറ്ററാണ്, സാറിൻ്റെ ആ ക്വസ്റ്റനെയർ ഇപ്പോഴും ഓർക്കുന്നു എന്ന് പറഞ്ഞു. സോ ഐ തിങ്ക് വി ഷുഡ് എൻജോയ് റിസർച്ച് ആസ് ഇറ്റ് ഗോസ്, ആൻഡ് ആസ് വി ഹാവ് ഡൺ ഇൻ കോട്ടയം ഹാർട്ട് ക്ലബ് രജിസ്ട്രി. Around the time ACS QQ was being done in Kottayam, we had ഞങ്ങൾ CMEയുടെ കൂട്ടത്തിൽ, ക്വാർട്ടർലി CMEയുടെ കൂട്ടത്തിൽ നേഴ്സിന് ട്രെയിനിങ് പ്രോഗ്രാം കൊടുത്തിട്ട് അതിൻ്റെ കൂട്ടത്തിൽ അവരെ ഡാറ്റ എൻട്രി ഓപ്പറേറ്ററായിട്ട് യൂസ് ചെയ്തു. ഒരു ഹോസ്റ്റൽ ഒരു കേസിന് 5 രൂപ മാത്രം. സോ ജനത റിസർച്ച് വി കണ്ടക്ടഡ് എ ലോട്ട് ഓഫ് numbers and presented in the first CFSI meeting of preventive meeting, and I think that was a fillip to the drive of our Kerala CSI to go for group research, including the ACS QC. And just coming to one of the things we identified, that is an artifact in the lung fields with our own echo probes. We were dissuading it as the artifacts, but we found that it is more common in the patients with acute LVF and with the diuretic is messed away. And then we searched and found out that this is something not new that we have detected. Maybe 10 years ago, HHC and then Picano, etc., people from the sonology and emergency medicine has described it. But we found that nothing in our literature, in our cardiology literature, we thought it is useful and we went ahead. We surveyed, we had an initial survey in the ICU admission. It was more in the LVF patients and healthy patients it was very rare. And then we had a comparative study, acute pulmonary edema, before giving diuretic, because diuretic is melted away. So, മിക്കവാറും കാഷ്വാലിറ്റി എന്നൊരു ഷോട്ട് കിട്ടിയിട്ടായിരിക്കും വരുന്നത്. സോ ബിഫോർ ഡയറ്റിക് അവർക്ക് മൾട്ടിപ്പിൾ USCs ഉണ്ടോ എന്ന് നോക്കി. So, it was innumerable, was 100% sensitive, then airway disease 100% negative. Maybe a sporadic a few there presented in the Richur conference at maybe 2009. Many were impressed, many eyebrows naturally were raised. Then we thought it is very important to train the entire team, otherwise you won't miss it, because so evanescent, regardless of concerns, juniors, techs, nurse, it's very so easy, so simple, no technique needed. So 100% sensitive for BDNs in LVF, whether systolic or diastolic in the acute symptomatic phase, and techs were taking up a few pseudo BDNs which are not strong and not reaching the end of this thing. Once they are trained, they were avoided, and we continued our observation in very many scenarios, different probes, different machines, different Cath Labs, theaters, everywhere, public checkups. So we thought, even though it is not there in the book, it is time to translate into day-to-day practice from bench to bedside, and we did it. So in those days, the procedure described in the books, the sonologists were about half an hour for each patient. Who has the time? We simplified it to just 1 minute echo pulmogram. We only took 4 quadrants, because ഈ 4 quadrants ഉണ്ടെങ്കിൽ സംഭവം നമ്മളെ സംബന്ധിച്ച് അത് മതി. ആൻഡ് റീഡിസൈൻഡ് അവർ കേസ് നോട്ട് ടു ഇൻകോർപ്പറേറ്റ് ദിസ് ക്വാഡ്രൻറ്റ് ആസ് ഒരു ക്വാഡ്രാങ്കറിൻ്റെ അകത്ത് പ്ലസ് മൈനസ് എന്നും, അല്ലെങ്കിൽ ഇത് സീരിയസ് ആയിട്ട് മെയിൻ കേസ് നോട്ട് ഇത് എക്കോടെ താഴെ അതിനും കൂടി ഒരു കോളം കൊടുത്തു. And made it mandatory that every patient, whether normal, whether it's a standard study or echo study or even emergency thing, this has to be taken, and there is a small notation format also designed, and this system continues since 2010, unabated, no loss of enthusiasm, and the team experience I think is unmatched maybe anywhere in the world. ഞങ്ങളുടെ സ്വകാര്യ അഹങ്കാരം. പക്ഷേ we designed Disney evaluation protocol, especially for our juniors. Just do the LV function imaging and the USC imaging. If LV function is reduced and USC positive, cardiogenic pulmonary edema. If negative, either a respiratory cause, especially COPD. If the LV function is good, USC positive, you have 2 or 3 options on which, if there is nothing to suggest an inflammatory disease like an ARDS, give a shot of diuretics, or you can do an elevated E by E prime, which is cumbersome at the emergency, or BNB time delayed. If it is melts away, it is a cardiogenic pulmonary edema or fluid over the renal dysfunction, or water drinking, or hypoalbuminemia, and if occasionally the ARDS ALD non-reversible ആയിരിക്കും. ALD never reverses and it progresses. So it is very simple, and we had a experience from a lot of, because it is a part, practically just like strength വെക്കുന്നത് തന്നെ, it is part of every our examination, and we have handhelds, 3 or 4 handhelds we have, and everyone knows about it. Even you can see, നമ്മുടെ ട്രോളി ഇരിക്കുമ്പോഴോ നമ്മുടെ വീൽചെയറിൽ ഇരിക്കുമ്പോഴോ വഴി വെച്ച് വേണമെങ്കിൽ നമുക്ക് നോക്കാം. ദിസ് ഈസ് ഇൻ എ സിറ്റിംഗ് പോസ്ചർ. ഈ പേഷ്യൻ്റ് COPD എന്ന് പറഞ്ഞ് വീട്ടിൽ പോകാനായിട്ട് പൾമോളജിയിൽ നിന്ന് വിട്ടതാണ്. സോ പ്ലൻറ്റി ഓഫ് USCs we admitted, give a diuretic, and it is part of the heart failure clinic. This evaluation is in our center, and occasionally in the radiology books ഒക്കെ നോക്കിയാൽ you find that a higher number of percentage of നോൺ പത്തോളിക്ക് BDNs ഇൻഹേൽ. പക്ഷേ ഒരു ഇൻ്റർകോസ് സ്പേസ് എൻ്റെയർ ആയിട്ട് 3 ഉള്ളൂ. ഇത് എക്സിബിഷൻ്റെ സമയത്ത് ഒറ്റ പ്രോ സ്പേസ് തന്നെ 15-30 അതിൽ കൂടുതലും കാണും. സോ നോ കൺസേൺ അബൌട്ട് ഇറ്റ്. മാത്രമല്ല നമ്മുടെ സ്മോളർ ഫുട് പ്രിൻറ്റ് ടിഷ്യൂ ഹാർമോണിക് ഉപയോഗിക്കുമ്പോൾ നമുക്ക് ലോവർ പെനിട്രേഷൻ, ഹയർ പെനിട്രേഷൻ ഇത് വളരെ കുറവുമാണ്. സോ ഇറ്റ്സ് ദ ബെസ്റ്റ് തിങ് ഫോർ അസ്. ആൻഡ് ഞാൻ മെൻഷൻ ചെയ്തു ലാർജ് ഏരിയാസ് വെയർ ദീസ് ആർ റെയർ തിങ്സ് ബട്ട് ഈസി വി ക്യാൻ ഐഡൻറ്റിഫൈ, എസ്പെഷ്യലി NSAID intake and water intake overload. So in COVID scenario there could be a few inflammatory things, and ആൻഡ് നമ്മൾ എക്സ്പെക്ട് ചെയ്യുന്നു എച്ച് ബി ഡിസ്ഫങ്ഷൻ കൊണ്ട് നെഗറ്റീവ് ആണെങ്കിൽ മോസ്റ്റ് ലൈക്ക് ദ ഡോമിൻ കോസ് മേ ബി സംതിങ് എൽസ് ആൻഡ് മേ ബി ടെക്നിക്കൽ ക്രൗഡിങ് ഓർ ഓൾ ദ യൂഎസ് ക്വയറസ് ട്യൂർ വി കാൾ വൈറ്റ് ലങ്സ് ഓർ B2 ലൈൻസ്. സോ ഈ എക്സ്പീരിയൻസ് ഷെയറിങ് ഞാൻ ട്രൈ ടു പ്രൊപ്പഗേറ്റ് നിയർ ബൈ ഹോസ്പിറ്റൽസ് വന്ന് കണ്ടുള്ളവരൊക്കെ ഇതിനോട് കൂടി. അന്ന് ഞങ്ങൾ 2013 ഞങ്ങൾ CSIക്ക് ഒരു പ്രൊജക്റ്റ് കൊടുത്തു വിത്ത് രാജു, ജാബിർ, മാത്യു, അബ്രഹാം, നിയർ ബൈ പീപ്പിൾ. ബട്ട് somehow the research committee could not understand the significance, or I don't know about the details, but അവർ അത് വേണ്ട, ഇതൊരു റേഡിയോളജിക്കാരുടെ ആണെന്നിട്ട് പറഞ്ഞാണെന്ന് തോന്നുന്നു, മാറ്റിയെന്ന് തോന്നുന്നു. മേ ബി ഫണ്ട്സിൻ്റെ കുറവായിരിക്കും. എനിവേ ഇറ്റ് ഡിഡ് നോട്ട് ഹാപ്പൻ ആൻഡ് ഐ അറ്റൻഡഡ് എ ഫ്യൂ പ്രസൻറ്റേഷൻസ് ഇൻ ദ CSI. ചെയ്തപ്പോഴൊക്കെ CDF ചെയ്തു, ചിലപ്പം ടൈം ചിലപ്പം നമ്മുടെ ചെയർപേഴ്സൺസ് ഒരു കൃത്യരായി. ഇങ്ങനെയൊക്കെ അതൊന്ന് പറയാൻ പറ്റിയില്ല, അറിഞ്ഞതിപ്പോൾ അത് പറയാതെ പോയി എങ്കിൽ ഞാനത് നിർത്തിയതോടെ. ഞാൻ JSCC എഡിറ്റർ എന്ന ജഗത് നരുവിള എറണാകുളത്തൊന്നും പറഞ്ഞു. അപ്പം പുള്ളി പറഞ്ഞു സംതിങ് ഈസ് ദെയർ ബട്ട് ഐ ഡോണ്ട് തിങ്ക് വിതൗട്ട് എനി പ്രോപ്പർ കൺസെൻറ്റ് വി ഡോണ്ട് ആക്സെപ്റ്റ് എനി മേജർ പേപ്പേഴ്സ് ഓൺ റിസർച്ച്. നിങ്ങളുടെ അടുത്ത് കഴിയുക. അറിയുന്ന പോലീസുകാരൻ്റെ ഇടിയേക്കായതും അറിയാത്ത പോലീസുകാരുടെ ഇടി കുറവാണെന്നെങ്കിലും ഞാൻ പിന്നെ അറ്റംപ്റ്റ് ചെയ്തില്ല. ഇതെൻ്റെ രക്തമാണ്, ഇതെൻ്റെ മാംസമാണ്, എടുത്തുകൊള്ളുക. സോ പക്ഷേ 7 വർഷത്തിന് ശേഷം മോഹൻ സാറും ഹരികൃഷ്ണനും 2 ചാപ്റ്റേഴ്സ് എനിക്ക് തന്നു. ഐ തിങ്ക് ഡേറ്റ ഈസ് ദെയർ ആൻഡ് ഇപ്പോഴ് ധാരാളം പേപ്പേഴ്സ് വരുന്നുണ്ട് ഇൻ കാർഡിയോളജി ജേർണൽസ്, എസ്പെഷ്യലി ഫ്രം ദ പിക്കാനോ ഹു ഈസ് എ കാർഡിയോളജിസ്റ്റ് ആൻഡ് നോട്ട് ഫ്രം ദി ചൈന. And our days of data and publication is yet to come. I am sure it will come. And with these few words, I am coming to the last slides of this my presentation, fitness and me and you. And ഈ കർവൊക്കെ നിങ്ങൾക്കറിയാം, ട്രാൻസ്ഫോർമേഷണൽ കാർഡിയോളജി. നമ്മളെല്ലാം 1 day ഓഫ് എന്തൂസിയാസ് ആണ് ഇൻ റിച്വലിസ്റ്റിക് ഇൻ വേൾഡ് ഹാർട്ട് ഡേ. പക്ഷെ അത് ട്രാൻസ്ലേറ്റ് ചെയ്യാറില്ല, ഇതുപോലെയൊക്കെ ആയി പോകും. ഫോർ മീ ഇറ്റ് വാസ് എ ലാക്ക് ഓഫ് ടൈം കമ്മിറ്റ്മെൻറ്റ് ആൻഡ് ലാക്ക് ഓഫ് ഡയറ്ററി ഡിസിപ്ലിൻ ആൻഡ് പ്രോപ്പർ ലാക്ക് ഓഫ് സ്ട്രെങ്ത് ട്രെയിനിങ് വിച്ച് ഇസ് വെൽ ഇൻ ടു അവർ സ്റ്റാൻഡേർഡ് ഗൈഡൻസ്. മെനി ഓഫ് ദം മേ നോട്ട് ഗിവ് സിഗ്നിഫിക്കൻസ് ടു ദാറ്റ്. സോ എനിക്കൊന്ന് സമയക്കുറവ് എൻ്റെ മകൻ പറഞ്ഞു തന്ന ഒരു ചെറിയ വർക്കൗട്ട് ഞാൻ ചെയ്തു. അത് സ്ട്രെങ്ത് ആൻഡ് ഹൈ ഇൻറ്റൻസിറ്റി ആയിരുന്നു. ഐ ഫൗണ്ട് ദാറ്റ് ദർ ഇസ് ലോട്ട് ഓഫ് ലിറ്ററേച്ചർ റിഗാർഡിങ് HIIT ഓൺ ദ ബെനിഫിറ്റ് ആൻഡ് വാസ് കൺവിൻസ്ഡ്. ഇത് 2013 ഞാൻ ചെയ്യുന്നതാണ്. Then when I had a good benefit, I transferred into my family, my friends, my colleagues and even the society. ഞാൻ സ്റ്റുഡൻസിനും പേഷ്യൻസിനും ഫാമിലിക്കും പറഞ്ഞു കൊടുത്തു. I tried to propagate it through the Lions Club, 100 Lions Clubs for MOU വെച്ചു. ഒരു 8-10 മീറ്റിങ്സ് കഴിഞ്ഞു. അപ്പോൾ ഒരു ദിവസം ഒരു ഡോക്ടർ, സീനിയർ ഡോക്ടർ എഴുന്നേറ്റ് പറഞ്ഞു, ഹു ഈസ് ലയൺ മെമ്പർ, ലയണിനെ പോലെ ഗർജിച്ച് പറഞ്ഞു, ഈ ഡോക്ടർ പറഞ്ഞതെന്ന് കേട്ടാൽ നിങ്ങളുടെ മെയിൻ കുഴലി പൊട്ടിപ്പോവും, ഹാർട്ട് പൊട്ടിപ്പോവും, അറസ്റ്റ് വരും. ഞാൻ ഇതിനെപ്പറ്റി ഒരു പുസ്തകം എഴുതിയിട്ടുണ്ടെന്ന് ഒരൊറ്റ അടി. അതോടെ അതിൻ്റെ കഥയും കഴിഞ്ഞു. ഇപ്പം ഈയിടെ ആരോ നമ്മുടെ ഇങ്ങനെ പറഞ്ഞ പോലെ തന്നെ വിനീത് കുമാറിൻ്റെ കേസ് സംഭവിച്ച പോലെ. ബട്ട് ഐ ബിലീവ് കൺസിസ്റ്റൻസി ഉണ്ടെങ്കിൽ ദിസ് കണ്ണൻ ഈസ് മൈ എക്കോ ടെക്നീഷ്യൻ ഫോർ 10 years and she is there for 15 years. They do only 7-minute workout only. They are reasonably fit and fit. So ഈ ഒരു സംശയം ഉണ്ടായിരുന്നു വെദർ സ്ട്രെങ്ത് ട്രെയിനിങ് ആഫ്റ്റർ ദ ഏജ് ഓഫ് 50 or 60 സേഫ് ആണെന്ന്. ഐ റെഡ് അബൌട്ട് ഇറ്റ്. ഐ ലുക്ക് ദി ഓൺലൈൻ വീഡിയോസ് ആൻഡ് പ്രസൻറ്റേഷൻസ്. ദിസ് ജൊനാഥൻ സള്ളിവൻ, exercise emergency physician, written a very beautiful book. He has marvelously improved his own training programs. And I started to have strength training with an empty bar as advised by them. Only 4 major compound exercises, that is squat, deadlift, shoulder press and bench press. അത് ക്രമേണ കൂട്ടി പ്രോഗ്രസീവ് ലേണിംഗ്. ഐ തിങ്ക് ഐ ഹാവ് ടോക്ക് ടു യു അബൌട്ട് ദ മിത ഓഫ് ക്രോട്ടൺ in the Olympic years of the BC. But anyway, the same method and alternate day rest, only small amount of kettlebell training, and it improved me like anything. I enjoyed it, and still I am enjoying it with my grandchild. And as Ashish and Deepak recently has shown us the benefits of aerobic training. No doubt about it, but we should have a comprehension of both. And as Ashish has spoken in those meetings, that the road to the mountain of weakness is more than one. നിങ്ങളുടെ താല്പര്യവും ഇൻട്രസ്റ്റും സൗകര്യവും അനുസരിച്ച് you mix it. Both are good. That is what I say. And this is I try to impress upon my hospital authorities and my senior colleagues. E patient, I don't think that you will imagine. He is the patient. Second heart transplant patient who had 1.5 years after his heart transplant, and we can train the elderly people safely. I think Tiny is doing it. So that is why the background we have started on our family fitness program, the youngsters who has given me so much of courage and support, and the seniors guided me, especially Manjara sir, and experts that was coming, and the contact with the younger generation is so stimulating to me at this age. And just to mention that this aerobic strength Bhajan's the person who told about the term aerobic, the Ashley Cooper, at 90 still has resorted to more of a strength training at this elderly age, and keep swimming up. Otherwise, കാലത്തിൻ്റെ ഒഴുക്ക് നിങ്ങളെ താഴോട്ട് കൊണ്ടുപോയിക്കൊണ്ടിരിക്കും. പ്രായമുള്ളവർക്ക് അത് കൂടുതലാണ് ഒഴുക്ക്. So keep fighting. So ഉറച്ച ശരീരവും ഉയർന്ന ചിന്തയും നിങ്ങൾക്ക് എല്ലാവർക്കും ഉണ്ടാകട്ടെ. I wish you a journey upwards in fitness and everything in life, whether straight or even after dip. And I wish you all of you to come to to Nadagani Greenberg for a family get together, which was delayed and missing, and we can discuss everything. Thank you all. On 27th of November. Thank you all.
Thank you, sir.
Thank you. That was fascinating set of anecdotes and a very inspirational set of messages. But we've been using lung ultrasound quite extensively in our ICU post-operatively. I'll vouch for it. It's terribly underutilized, and it's needless how many wasteful X-rays we are doing, subjecting people to radiation and using a vastly insensitive tool as compared to lung ultrasound. And I think CSI should take this up, multi-center study, where we could just look at the incremental utility, train people, which is very easy, using your protocols, and I think we need to do this. This is something that we really have to move forward with. Somehow we've been neglecting it.
Especially only in the day of, just to mention that we have done a good number of screening also. Newborns, it is in the first few hours and that will be there. Then after the second or third day, it is coming there. Either there is a problem, and it is very good for a pediatric.
It picks up things far earlier than X-ray. So if there is consolidation happening, you will know at least several hours before the X-ray shows this consolidation.
I think the time will come in the mobile, once some can monitor at home, and you can call the nurse, and the diuretic dose will be adjusted in the future.
I think so. I think that's a very cheap, expensive, reproducible tool. So we have to embrace that. That's the message I have got from you. I'm glad that you actually spoke so extensively about it. The only thing is we should have somehow found a way to publish. Don't go to JACC. Narula is a close friend of mine. He will not publish. So the thing is that we have to find a way to collectively challenge this hegemony that West has imposed on data from India. And we've started it. We've established something with the number of studies that have come, multi-center studies that have come from Kerala. But my experience has been intensely painful. The Hridayam study that I published in just now in Global Heart, JACC wanted to publish it after ACC. It was a featured presentation in ACC. And when we sent them the paper, they rejected it. And they gave no real reasons for it. So there is something. We cannot actually fight that system. We have to find an alternative way, and we have to be so powerful that they can't ignore us. It's happened with China.
Science ennum angane ayirunnu. Don't worry, I have no regrets.
Anyway, I think we have to.
Thank you, sir.
Both of us.
I request the chairpersons to present a memento to Dr. Johnny Joseph as a token of love and appreciation. Let's have a loud applause for him. Thank you, Chairpersons. Thank you, sir. We'll move on to next session, session lay extraordinaire. I would like to invite the Chairpersons, Dr. Anis Tajuddin, Dr. Cherian Koshi, Dr. Rajesh T, and Dr. Saji Kurutugulam. The first presentation is on LVAD, Welcome to God's Own Country, by Speaker Anand Kumar V. As it's all a live presentation, I request all the speakers to stick to the time to 8 minutes.
After that very energizing talk by Dr. Johnny, I feel a lot of adrenaline in my veins, and I feel like exercising heavily from today onwards. So after that we have a series of high voltage talks coming up. Over to you, Anand.
Thank you. Touchpad.
Hold it, sir.
Thank you, and welcome to this session. I thank Dr. Sulfikar and Dr. Joe for this topic, and this procedure LVAD was done by our surgeon, Dr. Sujit, ably supported by some proctors from Abbott and their clinical team. So I think it is very knowledge that LVAD is an electromechanical device to assist circulation, and we have right ventricular, left ventricular, or the biventricular, and initially started for cardiogenic shock, but now it is no longer used for cardiogenic shock. We have ECMO and other things, but it's used as a bridge to transplant decision, or now as a destination therapy. Previously we had para and extracorporeal devices, but nowadays all the LVADs are intracorporeal. Initially, many people thought that the pulsatile flow device was better because it mimics the physiological flow, but now we know that the pulsatile flow is associated with device failures. So nowadays, almost all the devices are continuous flow devices. And from a historical perspective, first it was done by Dr. Debaki in 1966. For a lady who had a post-cardiotectomy shock following AVR for 10 days. And this was a paracorporeal device, and then Dr. Denton Cooley did as a successful bridge to transplant, and then the total artificial heart was done by Dr. William DeVries in 84, but it never took off because the patient died after 3 months, and the first long-term LVAD was done in 1988, and the game changer was the rematch trial. In 2001, it was published in NEJM. That in patients who are waiting for transplant, there is a significant reduction in mortality. The mortality reduction was very huge, 52% compared to 25% at the end of 1 year if you use a first generation device, which was a pulsatile device, and which in fact had a much higher complication. Even with that, there is a 52% survival with 25%, because all these patients were having an average survival 6 months. And then in 2009, the new continuous flow devices came, the HeartMate 2, and that had a much more better device success rate and device longevity and reduction of stroke and LVAD failure. So in 2013, we have the approval for LVAD not only for bridge to transplant, but also as a destination therapy. It is class 2A, and even the latest European guideline, you can see it is a class 2A recommendation for both for bridge to transplant as well as destination therapy. In India, we know we have nearly 1 million people, 1 million heart failure incidents a year. If you can see, the end stage heart failure is something like 60 to 95,000, and this is the heart transplant curve in India in 2020, we had something like 200 transplant all over the year, around about 10 centers, and with an average 5-year survival around 60%. And this is a paper last year by Dr. K.R. Balakrishnan. So there's a vast majority we know doesn't get transplant because they are very, very sick and should be on a LVAD, but is not done so because of many reasons. Sorry. Can somebody? So now for advanced heart failure, now we use this classification, Intermax classification, that is for advanced heart failure, NYHA 3B and 4. We have on the stage from 1 to 7. In 1 is the critical cardiogenic shock, and then we have lesser and lesser integrity. And this also gives how early we should act, either as a for transplant or for a mechanical circulatory device. For example, Intermax 1, we should act within hours. Patient should get a mechanical support like an ECMO or a LVAD, and class 2 within days, and class 3 within weeks. So even the ESC guidelines, if you see, in, the Intermax 1, 2, 3 and 4 should go for a very early mechanical circulatory device, and also Intermax 4 and above, more than 4 who are at high risk. So how LVAD helps the patient? Improves the blood pressure, improves end organ perfusion, reduces the LVEDP, so reduces the workload of the heart, reduces myocardial consumption. Also it reduces the LA pressure, so it actually prevents the right heart failure. So heart transplantation we know has some contraindication, even though this is the best choice for end stage heart failure. One problem with heart transplantation, it is contraindicated in patients with pulmonary vascular disease. So this is a clear indication for LVAD also. In LVAD is not a pulmonary vascular disease is not a contraindication. In fact, there is a large studies which shows that patients with high PVR, the PVR drops to normal levels after LVAD because of it unloads the left atrium, and also the survival, if you see, patients with high PVRI or with normal PVRI, survival is somewhat normal. At the end of 3 years, you can see nearly 75% survival for LVAD also. Pre-existing right heart failure also not a contraindication, but just like the high PVRI, they may have a slightly higher pre-operative, post-operative mortality. So the available the device in India are the HeartMate 2, the second generation device, and the HeartMate 3, which is much more costlier, and also the Jarvik device. This was the first generation device which used in the rematch trial. It's a pulsated flow. HeartMate 1 is a large device, bulky device, huge battery consumption, intra-abdominal pocket. So now we have the intrathoracic continuous flow, which is much more portable, and there is a lead line, and there is a battery. And now we have the HeartMate 3, which is an intrapericardial, extremely small intrapericardial, little more expensive. So standard anticoagulation is aspirin plus vitamin K antagonist to keep INR around 2.5. Some promising data with Novax is there. LVAD also unfortunately associated with significant complications. Bleeding is probably, there are multiple reasons, including the use of anticoagulants, but one of the reason is the use of the low pulsatility. Also there is a ischemic stroke as a complication, and then we have infections as a complication. Our patient is a 61-year-old lady, idiopathic dilated cardiomyopathy with ejection fraction around 10%, who had a decompensated after an LRTA, and he was transferred to our center, put on ECMO, and invasive ventilation started, and he was on dialysis, ventilation. So then we thought, because the EF was so poor, about 9% with a good RV function, cardiac catheterization was reasonably satisfactory, the PVRI was good, so we thought we will do the procedure. Our surgeon, Dr. Sujit, did it. You can see the apical incision and put the pump, you can see the device, and that is connected to the aorta. We did it exactly 1 month ago, and then he was weaned off from ECMO, very slow recovery, weaned off from ventilation, but weaned off now getting weaned off from the continuous veno-venous dialysis, now on twice weekly dialysis. So this is the X-ray. You can see the apical chamber, inflow chamber, the device, and the outflow chamber. Outflow chamber is not radiolucent. You can see the external wire which is connected You can see this is the echo after the device. You can see the heart may look actively contracting, but it is actually the suction by the device which gives this. And you can see in this, you can see the aortic valve is not opening because the entire flow is through the device. And every day we should do the gradients. The gradients, both inflow as well as outflow, it should be less than 2 meters. A high gradient actually is an indication of thrombosis, and we should intervene. And this is how the device is. The device has a controller unit which can be charged by a portable wire as well as batteries. So you also have a shower bag. You can shower with the device, and the batteries last for about 12 hours. And the lack of pulsatility, so most of the patients will not be able to feel the pulse because it's a continuous flow. You have to check the BP using a Doppler machine with a sphygmomanometer or with a pulse oximeter and sphygmomanometer. Weekly INR is monitored. Now we have the HeartMate 3, which is a centrifugal device which is magnetically levitated, and there is an option for artificial pulsatility by increasing and decreasing the pump speed. So we have every 2 seconds. So we have a 30 beat per minute pulse can be felt, and this has a much less thromboembolism, bleeding risk, and longer battery life. So we have now the large Momentum 3 trial, nearly 400 patients data. The overall survival is almost 85% versus 70%, you can see, and event-free survival is 75% versus 60%. Now we have the 2019 data shows the HeartMate 3 survival is equivalent to transplant, 83% versus 82%. In fact, 2021, 3 months ago, we have a paper from Hanover which says there is a 100% 5-year survival. This is the first time, 2021, we have a 100% 5-year survival from a study. So future we have devices which are fully internal with remote monitoring, which is already there. We also have the latest pulsatile device, and also but 3 months ago we have the first commercial total artificial heart which is approved for commercial marketing in Europe. So ladies and gentlemen, respected chairperson, there is a mammoth gap in India between potential heart transplant recipients and actual surgeries, and many heart failure patients are ineligible, like pulmonary vascular disease, and LVAD as a destination therapy or bridge is suitable to most patients. Long-term survival for HeartMate 2 is now 90% at 2 years, 60% at 5 years. For HeartMate 3 it is even higher, and it's suited for high PVR as well as for patients with right heart failure, but of course comes at a significant cost and some lifestyle adjustment because of the batteries and some unique complications. Thank you.
Thank you, sir. So let's move on to the next presentation, cryoablation for AF, the balloon then coming from the cold, by Dr. Arun Gopi.
This happened to be the first case of LVAD implantation in the state. Let us give a big hand to Dr. Anand, Dr. Sujit, and the entire Lakeshore team.
Can I have it on the slideshow more? Yeah, okay. A warm good afternoon to all. At the outset, my salutations to Sulfikar sir. He was in fact the person who inspired me to take up cardiology, and my gratitude to all the organizers for giving me this opportunity to discuss a novel therapeutic option in electrophysiology, that is cryoablation for AF. This would be the flow of my talk. The reason why I'm discussing this is because of the recent case we did. The stories of a 68-year-old hypertensive who was troubled by recurrent episodes of palpitations, multiple episodes of hospitalization with AF, a LA size of 39, history of TIA for which she was put on NOACs, titrated to the maximal dose of amiodarone and beta blockers. Despite amio plus beta blocker maximal tolerated dose, she continued to have recurrent paroxysms of AF and was recently hospitalized with us with heart failure pursued again by AF. So she clearly needed something beyond drugs. It's not an uncommon scenario for most of the practicing cardiologists because AF is easily the most common sustained clinical arrhythmia you see in practice. With rising prevalence with age, numbers expected to double from 25 to 2035, leading cause of stroke and heart failure, a 5-fold increased risk of stroke, a 3-fold increased risk of heart failure. AFFIRM clearly showed us that rhythm control was not superior to rate control, But there was a key takeaway from a firm trial. The presence of sinus rhythm was associated with a 50% lower risk of death. But unfortunately, the technique they used to achieve sinus rhythm was wrong. They used antiarrhythmic drugs, and when you use antiarrhythmic drug, because of its pro-arrhythmic potential, that itself conferred a 50% increased risk of death. So that is why if you look at guidelines across the globe, be it the American HRS Society or the European guidelines, they all give a class 1 indication, level of evidence A, for catheter ablation for patients with symptomatic paroxysmal AF who are refractory or intolerant to at least one class 1 or class 3 antiarrhythmic drug. So our patient had a class 1 indication. She had recurrent paroxysms of AF despite maximal tolerant dose of amio and beta blocker. Gratitude to the seminal observations by Hazagre and colleagues who found pulmonary vein ectopy to be the trigger behind AF initiation, and that is why wide antral circumferential ablation of the pulmonary veins for electrically disconnecting the pulmonary veins has been the cornerstone of management of paroxysmal atrial fibrillation. We used to do this with radiofrequency ablation for years together. Now we have cryoablation, and stay tuned, possibly in future we are going to have newer technologies like laser and electroporation as well. So both are essentially minimally invasive methods which uses just transvenous access. One freezes the electrical connections with a 23 or 28 mm balloon. Other does a point-by-point ablation using radiofrequency application. So this is typically how a radiofrequency setup would look at. You have mapping catheters in and the ablation catheter in. We do a point-by-point application of the radiofrequency current and destroys the electrical connection by resistive heating and conductive heating. On the other hand, with cryoablation, we just take a transeptal axis, take a balloon, find the ostium of the pulmonary vein, inflate of the balloon there, and freeze and electrically disconnect the pulmonary veins from the left atrium. So essentially, how does a cryo application differ from radiofrequency ablation? One of the key differences is cryo applications are reversible. So if you are freezing at a wrong spot and you find it early enough, quickly rewarming the tissue can reverse the damage that has been created, which was not possible with radiofrequency application. So reversibility is a major feature in favor of cryo lesions. Another thing is with the freezing, the ice holds the catheter or balloon there and it gives excellent contact and stability of the balloon, which was not there with radiofrequency application. Just see the pictures between a radiofrequency lesion and a cryo lesion. Cryo lesion clearly preserves the endothelial integrity. It reduces the risk of thrombus formation. Clearly, the lesions are homogeneous and well demarcated. Now coming to the evidence, you see the graphs comparing catheter ablation antiarrhythmic drugs. The graphs are so diverse. Catheter ablation is clearly safe and more effective than antiarrhythmic drugs. A 31% reduced risk of stroke, a 50% lower reduction of mortality. And if you apply it early on in the natural history of AF, this is how the natural history changes. Early application of catheter ablation can make a paradigm shift in the natural history of AF ablation with a good long-term outcome. So early referral for catheter ablation is of paramount importance in patients with atrial fibrillation. Now, how to achieve it? You want to do a point-by-point radiofrequency ablation or a cryo balloon was the matter of debate, and that was set to rest with the Fire and Ice trial published in New England Journal about 4 years back, which is the largest multi-center head-to-head AF trial that we have till now. The message was clear. Cryo application was clearly equivalent to the conventional radiofrequency application based on efficacy, similar efficacy. The graphs are almost similar, but lesser complications. Lesser groin side complications, lesser atrial flutters, and the worst complication with AF ablation is pericardial effusion or tamponade, much lesser with cryo application, but a slightly increased risk of phrenic nerve injury with cryo ablation. In addition to that, cryo balloon also demonstrated a 34% fewer cardiovascular hospitalization, a 33% fewer requirement for repeat ablation compared to radiofrequency ablation. So Fire and Ice told us that cryo ablation was equally efficacious compared to radiofrequency application, much lesser complications, lesser procedure times. The LA dwell times was lesser and lesser requirement for repeat ablation. Now this was the initial study. Now the technology has advanced. Now we compared the point of care radiofrequency ablation. That's a contact force radiofrequency ablation versus the traditional cryo ablation and the latest 2-minute short cryo ablation. And we found that all the three technologies were equally effective and the maximum AF burden reduction was achieved the latest 2-minute freeze of the cryo balloon. Now moving on from the trials to real world evidence. So a single procedure with cryoablation gives a 80% freedom from atrial flutter, fibrillation and atrial tachycardia, which is quite good with AF. And with the second Medtronic Arctic Front Advanced balloon, these results are maintained even at the end of 2 years. One of the major differences is cryoablation is not much operator dependent. A low volume operator can also produce equivalent results as with a high volume operator. with lesser procedure times and lesser complications. All the technology that I'm saying now is from Medtronic. There's a system from Boston also which is in the pipeline but not available with us. So with all these advantages, you can find that there's a significant worldwide adoption of this technology with 3 lakh procedures being done in 60 countries globally. But still now, unfortunately, till about 1 month back, the technology never came to our country. We were fortunate to apply this technology when it came to our country last month for this index patient that I discussed earlier. So this requires a femoral venous access. So we take a transeptal access. This is an intracardiac echo probe. You can see the echocardiographic look at the septum. We take a intracardiac echo guided transeptal access. Once the transeptal access is taken, we take a 12 French flex cath sheath into the left atrium. And once we get into the left atrium, we cannulate each of the pulmonary veins, take a pulmonary venous shoot, define where the ostium of the pulmonary vein is, cannulate the pulmonary vein with an achieve mapping catheter. Over the catheter, we just have to thread the balloon, inflate the balloon, see whether there is good occlusion, and then start freezing. So once you start freezing, so you look at the electrograms. This achieve mapping catheter gives you the electrogram. The sharp high frequency potential which accompanies the atrial signal is the pulmonary vein potential, and as you start freezing, the potential starts dissociating, or the pulmonary vein starts getting electrically dissociated from the left atrium. So once you do this in the superior pulmonary vein, you can do it in each of the pulmonary veins, a cryofreeze of each of the pulmonary veins, and once you ablate of all the pulmonary veins with the cryofreeze, the procedure is done. It just requires transvenous access, so the patient can be discharged on the second day itself. And with this technology, this patient is doing quite fine. She has come to follow up and has not had any episodes after that. And with the first cryoablation, we welcome this technology to our state. And clearly, with all these advantages, cryoablation is going to be the future for AF ablation in our country as well. Thank you.
Thank you, sir. So moving on to the next presentation, stent delivery techniques, how to get a perfect track record, by Dr. Pratap Kumar N.
Wonderful work by Dr. Arun. And this also happened to be the first case of cryoablation in AF. Let us give one more big hand to Dr. Arun, please.
Stent delivery techniques. I'll be showing 4 cases where there is a difficulty in preparing the lesion to deliver the stent. This is the first case where the ISR CTO. We had actually taken a wire. You can see that we used a filter FC with a fine cross. 1.5 into Tasuna balloon tried, failed, not crossed. Anchor wire tried, not crossed. Anchor wire with the balloon, not crossed. Then we tried a Nick Nano balloon. Balloon actually gone down and inflated. After that, we took a 2.75 into 12 balloon pre-dilatation, tried to take the stent down, not possible. So again, we have taken a anchor balloon in the side branch, taken a 38 stent and finished. This is a second case. You can have an angulated vessel in the LAD with a diagonal. It is a right radial route, 6 French GBU, filter FC, 2 into 12, Maverick balloon, 2.5 into 12. Everything is crossed at 2.25 and prepare the lesion, because in the mid part we saw a calcium that is 2.5 into 6 Wolverine balloon. After that, we tried 2.75 into 40, not trackable. 2.75 into 20, not trackable. No stent crosses. Tension already created dissection in the LAD. So what is to be done is we put 2 stents in the proximal. We did a 3 into 12 and 2.5 into 12. That actually taken the curve. After the curve, we are in trouble. The distal end of the stent is not opened up. No balloon crosses, and there is a dissection. What to do? So shifted the patient to the ICU in the level. In this level, waited for 2 more days. We plan to do a rota or IVL, but using the mother and child catheter. Pre-dilatation is a must. Take the child catheter. We have taken a 2.5 into 12. Actually, it is very important. Whenever you take a mother and child catheter, you have to take a balloon down first. With the balloon, we took a telescope that is actually easily trackable balloon track. You can see the balloon coming down, and we have, with the help of the balloon, we took the telescope down. So with the telescope, we actually did an IVUS to understand there is a lot of dissections, a severe underexpansion, there is a calcium nodule, heavy calcium around. So we took a 2.5 into 12 IVL, 80 pulses, all the 80 pulses used. Then we took another run. We saw the proximal stent edge actualize, increased stent area after the IVL. Then we took a telescope taken deep into the previous stent, 2.5 to 24 L stent. You can see that stent is coming down. The telescope is sitting there, and you can take the stent down where nothing was going, and then we got a final result. This is a third case. This is actually a lady attempted antegrade intervention. So we decided to retrograde. You can see the microcatheter sitting in the septal branch. I took the wire easily, Suhatri crossed. Once I crossed, the fine cross is not taking the acute ankle. That was the toughest point. So what I did is actually, I took a Corsair Pro XS wire switch to cyan black for this support. With that, again, the microcatheter is not moving up. So I decided to take an antegrade wire. So antegrade wire with a fine cross antegrade, which was attempted earlier. But the fine cross antegrade with the filter FC, cyan black is tracked, but not crossed. So we took a Gaia third. The Gaia third wire crossed, but it is not going distal down. When it is not going distal down, what I did is actually, I tried an antegrade wire is not moving forward, no balloon crosses the lesion, 1.25, Ryuri. So tried a retrograde Gaia second wire. Now, keeping this antegrade wire as the marker, you can see that actually the Gaia 2 wire crossed retrograde. In the second frame, you can see the Gaia second wire crossed. Once the crossed, what I took is actually antegrade wire crossed, wire entered the septal collateral. So I deliberately kept the antegrade wire into the septal collateral. Then I tried a guide cylinder down. With the guide cylinder with 1.25, then a Nick nano balloon, and nothing crosses the lesion. What I did is actually, I tried a tonus. Tonus catheter is used in a severe calcified lesion, that is also not crossing. So taking a fine cross up to the midway, I tried a rotor wire down. With the rotor wire, I just took a blind rotor wire down. I took a 1.5 rotor for 180,000 RPM, which itself is a very high one. Tried for nearly 40 seconds, no use. 200,000 RPM, tried, not crossing. Then I took a 220,000 RPM. Then you can see the second frame, I crossed. Once I crossed, then I took a 2.5 into 12 millimeter balloon, then a 3 into 48 stent, and with this is actually the final result. This last case is a moderate LV dysfunction. The procedure done in 2013, a PCI to LAD, PCI to circumflex in 2015, and then a POVA done again to the circumflex. Then a PCI to LMCA bifurcation by DK nanocrush in 2020 in July. A POBA with a depth to LMCA bifurcation in 2020 in November. Then the patient went go for a cabbage in 20 December. Now the PCI to, now there's a patient came back with a severe angina. There are 7 procedures already done. The access, the left femoral is actually having a dissection or almost no flow. This is an angiogram taken from the left radial. This is an angiogram. No other vessel is there, only one vessel with a lot of stents. And the graft actually, you can see the graft. The junction is having lesion, ostial part is also having disease. The LMCA to LAD stent is patent, mid-LAD stent has mild ISR, circumflex is totally occluded, RCA co-dominant, totally occluded, Lima to LAD is occluded, SVG to OM, mild ostial stenosis with a graft junction as a tight stenosis, impression TVD, so the SVG to OM, 95% occlusion. The challenge is actually refractory angina in a patient, multiple intervention already, both femoral axis can't use, right radial pulse is not felt, left radial pulse is feeble, and access both brachial arteries. So what I did is actually, I took a right brachial route and a left radial route to understand the angiogram. We took a 7 French GBU with a filter FC wire not crossing. Then I tried a Miracle 6. You can see the Miracle 6 wire cross, but it is outside the stent margin. So it is gone beyond. We took the largest, toughest wire is Congress by 20. I took a wire and with the balloon not crossed. Then what I did is actually stop the procedure, try retrograde attempt to circumflex, both left radial spasm. So the catheter movement from left radial is almost impossible. A single catheter retrograde I tried. In a retrograde intervention, you use a microcatheter. So what we did is actually a 6 French AL catheter from the axis. You can see I passed the wire down. Once I pass the wire down, this is a single axis I'm trying. I passed the wire. The next wire is actually with a fine cross. Then I took a Miracle 6 wire. You can see the Miracle 6 wire is going up. Once the Miracle 6 wire, with a blind, balloon dilated, I reached up to the ostium. After reaching the ostium, I took a 1.6 balloon, 1.5 Ikasushi balloon, followed by a Tasuna balloon of 2 into 10. Then I took a 2.5 into 9 Sprinter balloon. Then we took a flow like this, and then I removed the catheter and came back again with the same 7 French GBU. Now it is very simple. Field FC wire passed. Then we did a tap technique. This is a tap technique. Then we did a balloon dilatation and a 4 into 8 balloon in the LMCA pot, and this is the final result. So in techniques to track a stand, body wire, anchor balloon with techniques 1. Second is a guideline or a guidezilla or telescope as a mother and child catheter, rotablation in some cases, and lastly, retrograde techniques. Thank you very much.
Thank you, sir. So let's move on to the last presentation, Post-COVID MISC, an Intelligent Cardiologist Guide by Dr. Mahesh K.
Thank you very much, Zulfikar sir and CSI, for this opportunity. So these are COVID times. So I think it's important to be talking about something which I think is often going under the radar. It's not been spoken about much. It's not been in the media much. But I would like to emphasize that this is a really, really serious problem that we've been encountering called MISC, or multisystem inflammatory syndrome in children, which is temporally associated with COVID-19. So let me start this with a story. This is 22nd of January. I received a baby around midnight from another city, and the baby had come in with history of some drowsiness, lethargy, preceded by 2 days of fever and multiple episodes of vomiting. The mother was a trained nurse who was not working anymore, but she had noticed that this baby was being very lethargic and drowsy, and whenever the child would sleep, the baby's pulse rate was going down because COVID time, so she was checking the pulse oximetry saturations, and she noted that the child was bradycardic. And she told this to the doctors too, and an ECG done there showed that the child was in severe bradycardia with a complete heart block. So when the child was received in the casualty, the child was drowsy, bradycardic with a complete heart block with a heart rate of 30, hypotensive, tachypneic on oxygen, and we intubated the child in the casualty. The child was at that time antigen negative, but there was history of COVID-19 in family members about a month back. We immediately rushed the child into the Cath Lab, and I put in a pacer. And this procedure was done under full PPE because of the context of COVID in the family members. So it was a struggle. Child arrested multiple times. On the table we managed to put in a pacer, and then by then the child's TrueNat test came positive. So the child was also COVID positive. So we had to shift this child into the COVID ward, which really considerably made the logistics much more complicated. And by then the labs came back. The child had leukocytosis, the cardiac markers were elevated, and the inflammatory markers that are used for COVID like ferritin, D-dimer, LDH, etc. were elevated. So was this something related temporarily to the COVID that the family had? The child actually had no history of COVID, but the family members had. Meanwhile, the child was clinically worsening with worsening acidosis, worsening cardiac function despite the pacing, and we, on a knee-jerk reflex, we started off an IVIG and high-dose methylprednisolone. By then, our multidisciplinary team got into play with rheumatology and intensive care, etc., etc. We added pressors. We tried to salvage this child, but by then the child was having intermittent loss of capture, worsening cardiac function and acidosis, heart went on dilating, and we kept escalating the supports in the ventilators. Eventually we decided to put him on the ECMO, but this child did not give us the opportunity and actually died a few hours after admission. So this is how dramatically MISC can actually present, and it can so often go under the radar. And it's a typical chameleon. It can manifest in so many different ways that you can completely miss it, even as an experienced clinician. So when COVID-19 began, we still do believe that it is benign in children. It doesn't cause much mortality, morbidity. So it's considered to be okay. So now we are opening schools. We are quite casual about children and COVID. But last year in April 2020, NIH had sounded an alarm about a mysterious new illness, which was sometimes looking like Kawasaki, with multi-organ affliction. And this was having some serious morbidity, mortality, and was temporarily associated with COVID-19. That's all that they could say. By then, multiple reports started coming from Europe, US, and across the world, and multiple publications started coming on it, and cardiac manifestations were a very important feature of the whole presentation, with cardiac dysfunction, coronary enlargement, shock, etc., etc. So multiple papers were coming. Towards the end of last year, we had 2 papers come out, one from Chennai and one from Mumbai, from India, which also more or less corroborated the data coming in from outside. So what is MISC? This is a delayed hyperimmune hyperinflammatory syndrome that can occur after COVID in children, even if the child has been completely asymptomatic. The pathobiology could be one of 3. It could be autoantibodies happening due to viral mimicry of the host antigen cells, or it could be the viral antigens which are getting expressed on the host cells, triggering an inflammation, and it could be the cytokine surge, and it could be a combination of all of these things. So it could present something like a Kawasaki disease, or it could be fever and inflammatory markers without KD features, or it could present as shock and cardiac involvement. So there are multiple case definitions from CDC, NIH, etc., etc. So the general guideline is in an individual, a child less than 21 years presenting with fever, lab evidence of inflammation and multi-organ dysfunction with no other plausible diagnosis, and a temporal association or a lab association with COVID-19, that would comprise a diagnosis of MISC. So the heart is affected like in a regular myocarditis, immune damage to the myocardium. There could be damage to the coronaries leading to coronary ectasia. There could be damage to the conduction system. And the management principles, you have to understand that it could be a mimic. There we have had children who presented like appendicitis, the children who presented with abdominal pain, vomiting, neurological signs. It's a great mimic. So it's important to consider MISC in all children presenting unusually in these COVID times. So as cardiologists, we look at cardiac functions. Cardiac dysfunction is a very important feature. Cardiac biomarkers are typically I can show the myocarditis features. And you can also have pericardial effusions, pleural effusions, regional wall motion abnormalities, valvulitis, altered myocardial echo texture, etc. Coronary abnormalities have been noted in between 6 to 93% of patients affected. ECG changes are quite diffuse and non-specific largely, and there have been very few cases of actually documented bradycardia or sustained arrhythmias. This is a publication that we came out and published in BMJ Pediatrics recently between 2 centers, Amrita and Baby Memorial in Calicut, where we described our own spectrum in a cohort of 41 patients after the first wave of COVID-19. And the cardiac management basically are around the time critical administration of IVIG and corticosteroids, resuscitation from shock. Often you need vasopressors to maintain the systemic perfusion, ventilatory support, and sometimes even ECMO. And you also need to be wary of life-threatening arrhythmias and prevent coronary thrombosis with anticoagulations. Exactly 4 months after that first case that I presented, we had another child, again came in at midnight. Child came with external pacing paddles placed on her. Child was severely bradycardic. And this again, there was history of COVID in the father a month back. The child never had anything. But when this child came, the child had multi-organ dysfunction and severe bradycardia. Once again, we placed an emergency pacer, instituted all the supportive measures, and immediately, without wasting any time intellectualizing, we started IVIG and high-dose methylprednisolone therapy. Slowly, the child started to improve. Initially, we had our heart in our mouth because there were periods of intermittent loss of capture, but subsequently, the child started to improve. Slowly, our rhythm started to come back, but the child still continued to be in complete heart block. So this was the timeline, and about 4 weeks after, the child had actually been discharged, but was continued to be on in complete heart block, and eventually required a permanent pacemaker implantation, and the child continues to be on follow-up with us. So this is a serious disease, and we need to take cognizance of this. I'll close this with a final case. A 24-day-old newborn presented to us, referred as query LV outflow obstruction because of profound LV dysfunction. Child was in shock, severely lethargic, poorly perfused, profoundly dysfunctional ventricles. We admitted him as a DCM, we managed him as a DCM, but he was not improving. And then suddenly we discovered that there was history of COVID in the mother in the antenatal period. During the 31st week of gestation, the mother had COVID. And this child's inflammatory markers were very high, and the baby and the mother were both COVID antibody positive, and all the labs were coherent with a diagnosis of MISC. We started IVIG, steroids, and managed this child purely on that. Within 48 hours, the child started to improve, ventricular function started to recover, and this child made a full recovery, and we could discharge the child home, and this got published in the Lancet in March. post-operative MIS is also something we are beginning to see. We are seeing that increasing mortality, morbidity in children undergoing heart surgery with very unusual features. Child who's about to be discharged suddenly becomes sick, vasoplegic, etc., and shock, going into shock. So this is again a situation that we are facing right now, and to understand this better, we have studied the levels of inflammatory markers and their trends in the post-operative period. This is an ongoing work so that we can actually interpret what level of ferritin is actually high, what level of LDH is actually high, when do we label it MISC, etc. So to conclude, we must keep our eyes open for MISC. We must consider it in children behaving unusually following a temporal association with COVID-19 in various kind of environments. Cardiac involvement is very prominent. It can manifest in various ways, and it may determine the actual survival of this child. And we as cardiologists play a very, very important in a multidisciplinary team to manage MISC. Thank you.
Thank you. Thank you, sir. Now let's move on to discussion of the above 4 presentations. I also request the online chairpersons Anis, Tajuddin and Cherian Koshi to join the discussion.
Anis, Cherian and Rajesh are there.
And also Rajesh T.
Let us start the discussion with LWAD. Just I will hand over before asking one simple question to Dr. Anand. Dr. Anand, if you have a case where the patient is actually a candidate for LWAD and a candidate for transplant, and an organ is available, what will you choose? Or how do you choose?
Definitely, if you see the 2021 guidelines, the transplant is in eligible patient is a class 1 indication. LVAD as a bridge therapy as well as destination therapy is a class 2A indication. So if a patient is definitely worked out and Cath study is done, the PVRA is less than 5, then I think definitely transplant should be the option. So this is reserved for patients where heart is not available, the patient is in temporary support and we cannot wait longer, and or if the patient has a pulmonary vascular disease.
Now, thinking by logic, one of the studies which you have shown shows very good 5-year survival rate of close to 100%, which is not the case with
That is a very recent study, 2021, published only about 4 months back. But if you see the 2018 and 19 data, we have the survival of HeartMate 3, the latest device which is equivalent to transplant in the long term, that is in the medium term, that is 5 years. But of course, there is the cost of the device is about 3 times more than transplant, number 1. Number 2, there is some lifestyle limitation because the patient has to change the batteries, replace the batteries every 12 to 18 hours. And of course, even though we need not have immunosuppression, there is still some specific adverse events like infections, device failures, all contribute to some 20-25% in the long term. Thank you.
Dr. Rajesh?
Yeah, congratulations, Dr. Anand, on the first LY. I think thanks to your team, the patient is alive today and kicking. One question I want to ask you is, these infections are a very threatening complication because with the LY, although thrombosis can be prevented with a very good systemic anticoagulation. What's your protocol for preventing infection? How long does the patient need to be on prophylactic antibiotics?
95% of the infections come in the first 6 months. So 6 months is the most important time. Of course, the initial time we give something similar to pacemaker, that is ticoplanin, and to cover the gram-positive coccus, skin flora. And after that, there is no prophylactic antibiotic given. It is only you always ask them to give a chlorhexidine dressing over the skin area. And if there is infection, now the protocol is you use very good debridement and antibiotic according to the culture and long-term antibiotics.
Thank you.
Dr. Anish? Anish, you are muted.
Yeah.
Can you unmute me?
Yeah. The RV dysfunction is a very important thing. What was surprisingly seen in LVAD is RV dysfunction is not a contraindication, because once you put the LVAD, it reduces the LA pressure and the lung pressure, the PVRA significantly falls. Even the most of the comparative studies, the Columbia group study, 500 patient data, patients who had a high PVRA, that is more than 5 units, as well as less PVRA, in the immediate first 2 weeks itself, the PVRA falls to normal levels, and that is maintained over a period of 2 years. So, high PVRA and even right heart failure is now considered not a contraindication. That is why now there is not much usage of BiVAT. There's LVAT usually takes care of the right heart failure also.
Anish?
You're muted, sir. You're muted. Anish, sir, you're muted.
Yeah, now you're audible, Anish.
Yeah, thanks. So, because of lack of time, I will concentrate on Dr. Arun's presentation. I must congratulate him for the first case of cryo. Actually, as Arun mentioned, I mean, to get the benefit of cryoablation early on, we should probably be selecting patients very early in his life course for atrial fibrillation, so that you have better results in terms of prevention of recurrence and all the benefits of reduced heart failure. And as far as the efficacy of radiofrequency ablation versus cryo, as I mentioned, both are almost similar, except maybe more data will come from the new generation of cryo than we may get more data on that. I just wanted to ask you, about the ease of doing the procedure. I think it's one of the best use of technology to reduce the stress on the operator for atrial fibrillation ablation. And also, because RF ablation gives you more flexibility in terms of the type of lesions you can give. Which all cases would you prefer, RF ablation over cryo ablation, or as an initial choice of ablation? And as a, case selection, how does it do a case selection for cryo ablation at this point of time, when post-effectiveness is also a matter of concern?
Yeah. So I'll take one by one. Okay. So yeah, it's a well thought of question. So I'll go one by one. Operator it's one of the easiest procedure when you compare AF RF ablation, because it is, as shown in trials, it's not operator dependent. A low volume operator can also provide equivalent results as a high volume operator, because once you have the transeptal axis, it's just getting into the pulmonary veins and freezing. Radiofrequency ablation, you have to go point by point, and so you leave gaps, and that is why you leave alone risk of recurrent arrhythmias. Choosing between cryo and RF, my personal choice is paroxysmal AF in a young person, not so dilated left atrium. I would always go for cryo first, especially on the other hand, elder person whom you don't want a complication, especially pericardial effusion is the most feared complication. Atrioesophageal fistula is the worst complication you can have with RF ablation. All these complications are almost nil with cryo. So if you want a safe procedure in a smaller left atrium, in a younger heart, as a first procedure for paroxysmal AF, we would always go for cryo. Now, when do you choose radiofrequency ablation? When you have concomitant arrhythmias, when you're dealing with long persistent AF, when you have a concomitant flutter to be done, when you have an atrial tachycardia which is initiating an atrial fibrillation, when you want to give lesions beyond the pulmonary veins, when you have more things to do beyond going around the pulmonary veins, then RF would be the choice. Still, a lot of operators who do both choose RF over cryo for complex cases, and for simple start-off ablations as a first procedure, cryo would be chosen. The next question was from sir about the LA size. As the LA goes larger, your success rates might go down, but again with paroxysmal AF, cryo gives a universal result.
So now this, for the treatment of paroxysmal AF in a young patient, now it has become, from refractory cases, it has now become the frontline treatment.
Yes, sir.
In young patient, class 1.
Yeah, as indicated, the difference between antiarrhythmic drug therapy and radiofrequency ablation or catheter ablation, the graphs are quite wide apart. And if you give as Dr. Anish also said, if you do an early ablation, you can really retard the progression of the disease. Yes. On the other hand, if you give long-term antiarrhythmic drug therapy, the toxicity of the drug therapy also comes in, and the atrium remodels to a process where finally ablation would also not be helpful. So early initiation of ablation is useful, and that is why most of the guidelines give a class 1 indication for paroxysmal AF early on in the natural history. So that once you ablate of the paroxysmal AF, you can prevent the progression towards long-standing persistent or persistent AF.
And you measure it after 3 months period, after a blanking period of 3 months.
Yes.
The
initial
response
3
to
months is
treatment.
given as a blank period where you can have some amount of arrhythmias, but after that you generally have a symptom-free period, close to about 80%, 70 to 80% success rate.
Recurrence of AF, do you choose RFA or cryo?
Whenever there is a recurrence, always RF, because majority of the times recurrence happens because of the macro-oriented arrhythmias due to the gaps in the lesions, and so all those cases we always prefer RF.
Yeah, okay, thank you, Arun. I think Dr. Cherian, we'll go to the third case. Yeah.
Yeah, my question is to Dr. Mahesh. How will you follow these recovered MIC cases with the echo or MRI?
So this is an evolving field. We don't have all the answers, but definitely we will need a long-term follow-up on them. We are planning MRIs on all of them at 6 to 9 months on the follow-up. At least 3 or 4 of these patients have persisting LV dysfunction, some regional wall motion abnormalities, LV apical dilatation, persisting coronary ectasia, etc. So these are things that we will need to follow up over the coming months and years.
One simple question. Post-COVID MIC, how a patient who is asymptomatic and they call you for an ECG and echo cardiac evaluation, you do it, it is normal. How frequently do you repeat it? Daily?
When a patient is admitted?
Admitted with the MISC?
With the MISC, we need to...
Initial evaluation is normal.
Initial evaluation is normal.
Normal. There is no cardiac involvement.
Okay.
Yeah.
If the child is admitted with a multi-organ dysfunction, we must stay on the watch out for cardiac involvement evolving. So we would repeat an ECG and an echo daily during the initial intensive period of management.
Yeah, patient can worsen all of a sudden.
Definitely, yes. So
and it's a very bad mimicker for many other things.
Yes.
How do you differentiate from a generalized sepsis? Sometimes it can mimic this whole thing.
Yes, sepsis is always to be considered as DD, and we would try to rule it out by the labs as standard. We would send a blood culture, we would look for a background of infection. And in the current context, if you have a very clear-cut temporal history with association with COVID, you must give it very serious credence. If at all you want to treat, you can always cover with an antibiotic while you go ahead and treat it with IVIG. Steroids you may hold back. If you have a concomitant suspicion of both sepsis and MISC, you can hold on to the steroids, but you can go ahead and treat with IVIG and give a broad spectrum antibiotic coverage while pending the reports.
Early initiation of ECMO in these patients, especially
ECMO,
before they...
Nowadays, now we have a very strong multidisciplinary team managing MISC at our hospital. So we have a rheumatologist, pediatric intensivist, pediatrician, and the pediatric cardiologist working together. So we have a common group. Any patient coming in or the message coming in about a patient coming in, we go into an alert mode, including keeping ECMO ready. We had a patient come in yesterday. The moment we got the information that the child is coming in with severe LV dysfunction, the CVTS team was informed to keep ECMO standby. We managed to salvage the child just with IVIG infusion. Many of them, the moment the whole dose of IVIG goes in, the ventricular function starts to improve. It's one of those most gratifying things that you can see. Profound LV dysfunction beginning to improve. That's something that you rarely see. So that is one of the hallmarks of MISC, that if you initiate the time critical management, the results are very gratifying. We've had to give ECMO in at least 3 patients at our center, and all of them have been salvaged.
Sad to see that you lost a child. And what do you think we could have done retrospectively? Anything else we could have changed?
So we've lost 2 children. Now in the last 6 months, we've seen about 60 odd at our hospital, and we are aware of more than 800 in the state. So the 2 children that we lost, this first child that we came in, one of the things that confounded our management was the child also turned out to be COVID positive. So which meant that the child went into a COVID ward, which was not really optimal for the pediatric management, going in with the PP, all that was big trouble. And getting IVIG actually into the patient was a big barrier. So we tried to overcome that, learning several lessons from that IVIG should be available in the ICU, so that the moment we order it without a wastage of time, over the next 15-20 minutes, we should be able to initiate the time critical therapy. I think that is very, very important.
Any questions from the audience? Yeah, please.
Here.
Last one question.
MISC, if the patient is discharged, at the time of discharge, the echo is normal. And do we have to repeat echo, and how frequently?
We should definitely repeat the echo even if the patient's echo is normal, because we don't know downstream what's going to happen, how many of them are going to have some myocardial fibrosis, scarring, evolving coronary issues. So we have a protocol of post-discharge, 1 week later, we called the patient back in for a cardiac evaluation. Then 4 weeks later, then 3 monthly we are following them up.
At that time, you look at the coronaries?
We look at the coronaries, we look at the LV function.
I think we come to...
Thank you.
Yes, sir.
Considering your time.
Sir, Kadar sir.
So the cocktail would be when you have an active COVID infection. So the antibodies are actually helping you fight the COVID. But here the problem is caused by the antibodies itself. So MISC is not active COVID, it is a hyperimmune, hyperinflammatory response to COVID. So you have the antibodies which are causing all the damage. Like the antenatal case, mother had COVID, baby never had COVID. But the mother's antibodies pass transplacentally into the baby and trigger an immune response in the child. That is what leads to the multi-organ damage. So the cocktail would not
Thank you, sir. Thank you so much. Thank you, presenters. Thank you, chairpersons. So we are moving to the last session of the scientific program, the huddle, structured and steered panel discussion on prevention and treatment of VTE. Queries, answers and conclusions. I invite George Koshi A. And I invite the travelers Ashraf SM, Dr. Jaber A, Dr. Nadarajan KU, and Dr. Praveen SV to the dais.
All travelers have joined.
Dr. George Koshi A will join us online. Thank you.
Dr. Nadarajan, I think you are in the hall, I believe.
No, I'm in the dais actually. Myself, Dr. Jabir and Dr. Praveen. Now you can see us, right?
Everyone has joined.
Okay.
So, can we start?
Yeah.
Ashraf is not here, sir. Ashraf might be...
Yeah, Ashraf is with us here, I can see.
Since
okay.
Sir is not coming, so I thought I also know.
Okay. So, let us start we are already late, let us start. We know that, pulmonary embolism, the most important aspect of the management is a proper risk stratification. And the pulmonary embolism with hemodynamic instability is associated with high mortality. So let us start with thrombolytic treatment of pulmonary embolism. And let me ask Dr. Nadarajan, what will be the best thrombolytic regimen in a pulmonary embolism with hemodynamic instability? Because we have data with streptokinase, urokinase, people give tenecteplase. From your experience, what do you think is the best?
Thank you, sir. See, traditionally we have been, as you correctly said, we have been giving either streptokinase or urokinase in the usual 2.5 lakhs followed by 100,000 units for the next 12 to 24 hours. But of late, there is overwhelming evidence in favor of RTPA, particularly alteplase. So we have about, at least in the last 2-3 years, we have about 10 cases where we have given alteplase. The dose, as you know, is 100 milligrams over 2 hours, and we have excellent results. And the current guidelines and data recommend the use of alteplase in preference to streptokinase or urokinase.
Okay. Suppose alteplase is not available, do you think, how should you give streptokinase? It is much cheaper.
250,000 units bolus over 30 minutes, followed by 100,000 units in the next per hour for the next 12 to 24 hours. Or urokinase.
An accelerated regimen may be equivalent or even better.
There is evidence to show equivalence in the response to accelerated dose in comparison to the protracted course also. And if the patient is very sick, probably it makes a case for accelerated regimen in preference to the conventional prolonged duration.
And I think we have some experience in which we have given it, in an accelerated manner, streptokinase. And overall, I think that is easier and probably slightly better. One more question to Dr. Nadarajan. See, many times you may not be able to do the CTPA, which is very important for the diagnosis, maybe due to logistic problem, lack of availability, or renal issues, or a patient cannot be shifted and all that. Are you justified in thrombolizing a patient with pulmonary embolism, with hemodynamic instability, without confirmation by a CTPA?
That's a very pertinent question that you're asking. A lot of times, as you said, there are practical difficulties. So the guidelines very clearly recommend if there is hemodynamic instability as evident by resuscitated cardiac arrest needing CPR, or obstructed situation like low blood pressure, protracted hypotension needing long-term pressor supports, and if the echocardiography clearly shows right ventricular dysfunction, and when there is difficulty in getting a CTPA organized, you are justified in thrombolizing the patient. To the contrary, in a patient who is hemodynamically unstable, if there is no RV dilatation or RV dysfunction, you have to search for alternate causes, and then thrombolysis is not justified. RV dilatation, hemodynamic compromise, you are justified in thrombolizing the patient without having to necessarily confirm by doing a CTPA angiogram.
I think that is very important to understand. Now, failed thrombolysis and people with severe degree of shock or contraindication to thrombolytic treatment, the mechanical devices are very important. So let me know from Dr. Ashraf, what are the mechanical interventions which you can do in pulmonary embolism? I know that you have some experience in your sector.
Thank you, sir. Basically, the mechanical intervention, both failed and for accelerated thrombolysis at the local site. We have been doing last 9 years with more than 68 patients and already published the research article. Basically, our aim is to massive or submassive, Dr. Nadras mentioned, to restore the flow through the pulmonary artery to improve the LV filling pressures. Basically, 3 aims like mechanical clot maceration, and second, you can aspirate. Mechanical aspiration, combination with the local delivery of thrombolytic with reduced dosage. So, how to macerate? You can rotate with the pigtail catheter within the thrombus or using automatic mechanical device. It is available in the market, like suction apparatus. And how to aspirate? You can use regular 7 French or 10 French catheter. You can introduce either through jugular or the femoral route. But before that, you have to exclude any iliofemoral thrombus. If there IB thrombus, you can go through the jugular like that. And even Mullin sheath also okay. Then how to thrombolyze? Like for example, already mentioned here. Like previously, we have used streptococcus during 2009 to 11 during time. That later we got reticulized those two were available instead of 80 milligram half dosage, or even alteplase like lesser 15 milligram instead of 100, or tenecteplase less than, if it is normal 30 to 40 instead of you can use 20. Like that, you can reduce the dosage and reduce the bleeding complications. So basically, you are making some sort of flow through that and macerate it, and effectiveness of acceleration of the thrombolysis process and reduce the complications. And we have got wonderful, almost like more than 99, only one death on top, that is cancer patient. Otherwise, extremely useful, very simple, like what we are doing for the primary angioplasty.
See, just as we say a patient with cardiogenic shock in an MI, thrombolytic therapy seldom helps. You have to do a mechanical thing, you have to do a primary angioplasty. Is it true with pulmonary embolism also?
Yes,
Patient coming with severe shock, there's no point in giving thrombolytic treatment, straight away go for a mechanical management. Do you agree to that?
Agree, sir. Basically, the thrombolytic, it takes time. Mechanical means usually thrombus occurs in the bifurcation area. Definitely patient comes with shock or main pulmonary artery. The original thrombus is also important. For example, COVID area, intrinsic thrombus can occur in the bifurcation of main pulmonary artery, or iliofemoral area you have a large thrombus and occluding that, because iliofemoral area will be thrombus will be 9 to 10 mm. So our bifurcation will be 9 to 10, so occlude that area like saddle embolism. So you just want to take that, or else if you have ECMO, you have to switch out ECMO. Otherwise, there is definitely a role for mechanical.
Okay, thank you. Thank you, Dr. Ashraf. Dr. Jayaprakash, let me tell you a clinical situation, and you tell me how we can manage that. An RTA patient with head injury and high risk of intracranial bleed develops pulmonary embolism with hemodynamic instability. What will be your approach? You cannot give thrombolytic treatment. What are the options?
There are two issues here. One is the patient has a pulmonary embolism, high risk. He is in hemodynamic compromise. Here seems to be in a situation where thrombolytic therapy is contraindicated. So this patient should go for a mechanical aspiration or a surgical embolectomy. So that depends upon what are the resources of the hospital where he is admitted. So if the surgeon is agreeable for or the surgeon, cardiothoracic surgeon feels that he can go for a surgical embolectomy, that is one option. That may be a better option. Second, because if we do a mechanical pulverization also, we may require good amount of anticoagulation, isn't it, Ashraf? Because we are manipulating. That is important. So I will opt for a surgical embolectomy if possible, otherwise mechanical. Then second thing is, we need anticoagulation following this, that we have to discuss with the neurosurgeon and then decide on an anticoagulation protocol, maybe a little subtherapeutic or suboptimal anticoagulation, a lower dose of anticoagulation, but he must be on anticoagulation.
Anyway, a difficult situation. Any comment on mechanical interventions in DVT? Huge thrombus burden. Anyone having any experience, Dr. Jayaprakash?
Yes, sir. We have experience in our center. Probably this was a couple of cases which was done by our interventional radiologist in our team. He does mechanical aspiration or pulverization and aspiration. There are some new hardwares and materials available for aspiration from the peripheral venous system.
It's not a very standard recommendation, but many people believe that there is a huge thrombus burden. Even if you give your low molecular heparin and all that, it may not clear it immediately, and there could be significant risk of embolization.
And there is some recommendation or consensus on the use of a localized local thrombolytic therapy, so that it reduces the chance of a post-thrombotic syndrome. A post-thrombotic syndrome chances may be less.
Just to add a point, sir, that actually two sides you have to be very careful, like popliteal vein and second is iliofemoral. In a superficial vein, no issue because profundal vein and the poplite there is a collateral. And these two are, like Dr. Jadhav said, post-thrombotic syndromes more than 80% recurrent venous thrombosis. So little bit aggression is needed, iliofemoral and poplite.
Okay, thank you. Now I think we will go to another aspect. See, some of the patients with pulmonary embolism really come in the low risk category. Maybe you can manage them as an outpatient. And who are the patients suitable for outpatient management? How will you decide, Dr. Praveen? Because all patients, may not require admission. Can you tell what are the guidelines and how will you?
Yeah. So there are 2 points to that. One, what is the guidelines and recommendations say, and what we practically follow in our practice. Of course, there is a large body of data from recommendations and all saying that somebody who has a low risk PE, that is a P without any hemodynamic instability, you do a CTPA, RV is not enlarged, or the markers of RA strain are negative, or an isolated DVT, the first episode. These patients, basically you apply the scores which are available in the net, like the PESI score and all. The score is low, these patients can be safely left for home-based care. That's what the recommendations, and even countries like UK and all that follow. Basically, the important thing here is, with the arrival of NOAC, basically if the patient is presenting with a first episode of venous thromboembolism, where there is only an isolated DVT, the patient is otherwise stable, there are no other comorbidities, then you can fastly load these NOACs to have a faster efficacy of action, just like unfractionated heparin or low molecular heparin. So there are these sort of patients, basically you can start these patients initially itself with these drugs. It's not a pure OPD treatment, they say. The patient is actually initially managed in the ER or an intermediate care unit for the first couple of hours, and then they are mobilized for an early discharge and a early follow-up on an OPD basis. That's what the recommendations say.
But they should be very meticulously followed up.
Correct. These patients should be meticulously followed up. Of course, and the bleeding risk.
But it is possible.
It is possible.
It is possible. I think it is very important. You have the high risk, intermediate risk, and the low risk. Intermediate risk, again, there is a gradation. And we know thrombolytic treatment, basically, people who come with hemodynamic instability, people who have cardiac arrest, people who are in hypertension, elevated markers, especially the troponin and ventricular dysfunction. Those are the high risk. And to the low risk, or the lowest risk people can be managed as outpatient. Now we will go to another aspect. Now we know NOACs are currently preferred over vitamin K antagonists. If you look at the guideline, they tell that NOAC should be preferred over warfarin in most of the patients in the management of pulmonary embolism. Dr. Natarajan, is there any situation where the vitamin K antagonist should still be used as the first option?
Like atrial fibrillation, where there is a definite role for vitamin K antagonist in valvular atrial fibrillation with a mechanical prosthetic valve, there is some evidence that in patients with venous thromboembolism also vitamin K should be considered in preference to NOAC. We have to understand a term called thrombophilia, where there is an increased thrombogenic potential in a particular patient, and this manifests as recurrent thrombosis, particularly unprovoked thrombosis. So unprovoked recurrent thrombosis in the venous system, it becomes an indication to search for prothrombotic conditions, otherwise called thrombophilia. And a few conditions to name are the APLA syndrome, the antiphospholipid antibody syndrome, for instance. These are situations wherein, because the vitamin K antagonists act on multiple levels in the coagulation cascade, the vitamin K antagonists are actually preferred in such conditions. So to name such conditions will be APLA, and the deficiency of the anticoagulant proteins like C and S. These are probably some of the few indications where vitamin K antagonists will be used in preference to the novel anticoagulant drugs.
Others will be the standard contraindication, like people with CKD.
That's correct. That's correct.
Another point will be patient while on NOAC is developing recurrence of pulmonary embolism.
Correct.
Then maybe you can change over to VKA and you can monitor the INR.
That's correct.
Then pregnancy lactation is always a problem, you know. NOAC are contraindicated vitamin K antagonists depending upon the trimester. You can use it or not. I think that is the situation.
Is it that cancer patients probably, can I add a point?
Dr. Ashraf, which will be your antithrombotic as the initial option? Now you know you have multiple choices. You have the UFH, you have low molecular weight heparin, you have fondaparinux, you have NOAC. So what is your option?
So traditionally we have been using unfractionated low molecular weight heparin for long years. Now the fondaparinux will be a little bit result, but NOAC has come recently. So if you take why the acute phase is very important, because thrombogenic potential in the process is very rapid and very important. And if we can divide that, like acute phase initial 5 to 10 days and long term initial 3 months and extended period beyond 3 months. So in acute phase, if you are not treating properly, you can have a lot of recurrence. So that is very important. You need a molecule with a very good effect, no issues, no complications. So you can have high intensity initial treatment 5 to 21 days. If you have two approach, you can make a 2-drug strategy. Like initially low molecular weight heparin, switch over to NOAC. Previously certain selected cases like already speaker told about warfarin selected cases. Or even you can use 1-drug strategy like rivaroxaban 50 milligram BD for initial 3 weeks and followed by 10 milligram BD, or apixaban 10 milligram BD followed by that you can, beyond that you can, after 3 weeks you can maintain treatment. So my approach, you can either choose two, either non-clone heparin followed by NOAC, or 1-drug strategy initially with rivaroxaban and apixaban. If you want to take dabigatran, you have to use at least 5 to 10 days of heparinization is needed. After heparin and low molecular weight heparin, viability, long time and patient preference and heat and other issues is better with low molecular weight heparin and compared to unfractionated.
Anyway, UFH is not currently very much
and benefit.
And the monitoring is also a bit difficult. Now we will come to another very important aspect. Dr. Jaber, VTE in malignancy, what are the options? Which thrombotic agent?
VT in malignancy, one is malignancy is closely associated with VT, and if a person develops VT, we should keep him under strict follow-up and keeping in mind that a malignancy is an underlying possibility if there are no other identifiable causes are there, and they should be followed up meticulously, so that sometimes the malignancy may become evident only after 6 months or 1 year. There is data regarding that, and it's a high chance of VT recurrence in malignancy. The entire data, if we look at the entire data, most of the drug used mostly was low molecular weight heparin, and the data which compared heparin or low molecular weight heparin long term use versus VKA was inferior to low molecular weight heparin. So it is low molecular weight heparin for 3 to 6 months. Now we have data with NOACs. We have the Hokusai VT trial with edoxaban, but edoxaban is not available for us. We have data with rivaroxaban, and we have data right now. We have data with apixaban in the Caravaggio trial and the ADAM trial. So we can use after the initial 3 to 6 months. of malignancy, a long-term treatment. So whether we can use it initial part depends upon what type of malignancy it is. In a gastrointestinal malignancy, all these studies have shown that NOACs are associated with the high incidence of bleeding. So in a gastrointestinal malignancy, better to avoid NOACs. And second, there are certain anti-malignant drugs which has got an interaction with the NOACs, especially the vinblastine group of drugs, the vinca alkaloids, and second is the anthracycline derivatives. They are strong PGP inducers, so they reduces the blood level of NOACs, so it should not be used along with these drugs. So if these things are not there, if it is a non-gastrointestinal malignancy, there are no drugs that can produce significant interaction with the NOACs, then apixaban, rivaroxaban, or edoxaban, since we don't have edoxaban with us, so apixaban or rivaroxaban can be used instead of low molecular weight heparin, especially in the if we are going for a long phase, that is after the 3 to 6 months. Initially, still preferred is a low molecular weight heparin for the first 3 to 6 months. Then the long-term management depends upon whether the malignancy is cured or still it is active.
Thank you, Dr. Jabu. That's a very complete answer. So you have to find out whether it's a GI malignancy or not, and how effective the malignancy has been under control. Now, COVID-19, very important. COVID-19 and venous thromboembolism. Any difference in the management strategy, Dr. Praveen? I think you are working in a center where a lot of COVID patients are managed. I'm sure you would have come across many situations.
Yeah. So,
is it similar to the standard guideline or any difference?
Yeah, we know the guidelines have come a full circle, right from a high dose anticoagulation in the initial part of the epidemic to now the guidelines are saying a usual intensity of anticoagulation only. So practically, even though that is the guidelines what they say, practically what we follow in our center is any patient who is hospitalized with COVID-19 in the critical care setting, these patients are usually given on the usual dose of, that's a prophylactic dose of anticoagulation. We prefer low molecular heparin or fondaparinux. That's what we follow. Suppose these patients are hospitalized, is oxygen dependent, and if that patients are like some amount of dyspnea is there, we still keep the patient in intermediate care unit. That patients also we follow the usual prophylactic dose of heparin or fondaparinux. Then these patients, if they don't clinically have any episode of venous thromboembolism, these patients at discharge, we usually give them 2.5 milligrams BID of apixaban or low dose of rivaroxaban, around 10 to 15 milligram. And these patients, what we usually do is at follow-up, around 2 weeks of follow-up, if there is no further episodes, we usually, in our practice, clinical practice, we stop these patients from their routine NOAC therapy. That is what we follow in our practice. Now, regarding our experience with management of pulmonary embolism episodes, right from the initial episode, we had cases of pulmonary embolism. I still remember a young guy in his 20s who was airlifted from Gulf with a massive pulmonary embolism with COVID-19. He was on ventilator, supportive care. We thrombolized him. He's still on follow-up. He recovered. He made a good recovery. Still on follow-up, but as a protocol, just did a CT pulmonary angio 6 months after this. We found that there was a residual good thrombus burden in the pulmonary arteries even after anticoagulation. So we shifted that patient on vitamin K antagonists, and he's still on follow-up with normal PA pressures. That's what we follow in our routine clinical practice. Vis-a-vis the recommendations are concerned, the recommendations have come a full circle. Now the recommendation is that the patients are preferably given the prophylactic dose of low dose of anticoagulation, be it clexane or fondaparinux, and then the indication for follow-up with oral anticoagulation at discharge. Even though the US FDA and all give recommendations, the recommendation is that usually unless the patient has a clinical episode, these patients at discharge are evaluated, and if there is no risk of ongoing thrombosis, these patients are usually not given an outpatient treatment. That is what the American Society of Hematology and all those recommendations now follow.
Okay, Dr. Praveen, one more point. See, should we look at the D dimer to decide on the duration of the prophylaxis? Because even if you do not tell, the patients go on repeating the D dimer and tell even my value, even now my value is 900, 1200, can I stop the tablet? Should I continue? You go by that or just give it for 4 to 6 weeks?
No. Now the recommendation is that you should not go by D dimer alone. You should incorporate the D dimer also into our clinical criteria. If the patient has high risk, like other features, high risk of venous thromboembolism. Along with that, you add the D-dimer also, and the D-dimer is more than twice or thrice the upper limit. Then only we anticoagulate these patients. That is what we found.
D-dimer alone probably is not very important.
Yes, correct.
Okay. Now I think we will go to some aspect of the VTE prophylaxis. Dr. Natarajan, which drug would you prefer for DVT prophylaxis? Now we have data telling that Novax are very good or even better than the low molecular weight heparin and enoxaparin. But even now, most of the people are more comfortable with enoxaparin. What is your option?
When this question of DVT prophylaxis is posed to anybody, we as a group of practicing cardiologists, we immediately think of patients who undergo surgery. For example, some general surgery, needing prolonged immobilization, orthopedic surgery, so on and so forth. It's very important to understand that DVT prophylaxis are also important equally in patients who are admitted to the medical ICU or the coronary care ICU. Let's say, for example, a patient with heart failure is getting admitted. That also be an indication for DVT. Unfractionated heparin or enoxaparin, for example, 40 units of enoxaparin once daily or fondaparinux 2.5 milligrams subcutaneously once daily have been the drugs. With the advent of NOACs, particularly in the context of surgeries like orthopedic surgery, NOACs are equal, like for example rivaroxaban or apixaban or even dabigatran, which is initiated 12 hours post-operatively, and it should be continued for about 10 to 14 days post-operatively. Some guidelines even say that the patient needs prolonged immobilization. It depends on the need for prolonged immobilization post-discharge. But I want to use the opportunity to say that we underutilize anticoagulation for DVT prophylaxis in medically treated patients. Lot of times patients with heart failure don't get anticoagulation for this particular reason, which is very important to understand.
That is very important. I think many times it is ignored. We always think of only knee joint replacement and hip joint replacement.
Absolutely.
Now, coming to another important point, Dr. Ashraf, that is regarding the duration of anticoagulant therapy in pulmonary embolism. It has to be given for prolonged, maybe even for life. But there are situations where it can be shortened also, especially when it is prolonged and all. But to decide the duration, will you depend upon deep dimer or the Doppler of the lower limb veins or a repeat CTPA? Because many times patients come and ask, should I repeat it so that I can stop the treatment?
So that total duration, the first question, like the total duration of oral it should be determined by you have to examine the individualized patient risk and risk of bleeding bilateral therapy. Individualized patient risk means already discussed, for example, Aplas syndrome, as Dr. Nambiar said, is electron. And like cancer patient, Dr. Jayaprakash has already mentioned, because the cancer is a particular ability because the risk is very, preference is very high, like 20% within 1 year. So as long as patient is receiving chemotherapy, even low dose, you have to continue with the anticoagulation. And come the unprovoked and provoked. If it is provoked, we can even 3 months is enough for distal bleeding. When pulmonary embolism be to 6 months. But you have to always on duration on OPD base, you have to send for thrombophilia. And with the thrombophilia, apply two factors like the factors highlighted, V L and other prothrombin gene mutation, need a very long-term anticoagulation. And you have to see that a lot of risk factors like VT recurrence, that's a scoring factor like PNR score, mean continue, all these are the scores we have to go with that. And the bleeding risk, like in which another patient is creatinine spiced or there is an anemia, even if hemoglobin level is a risk factor. So then whether warfarin was you extend the period, there is not a study of Roxaban or Apixaban or Endaxaban. You have a study reputable warfarin for long years and dabigatran also in that scenario. Now, if the patient is not tolerating at all and very low risk, but you have to continue with that. So in that case, there is an antiplatelet part also in there. Now, regarding second part, like whether D-dimer, but also already Dr. mentioned there is no guideline at all. And some patients are taking the D-dimer, the sampling, and also some people even send factor 8 levels. Now come to venous duplex part, venogram. This is very, very important in a iliofemoral. If there is residual obstruction, the recurrence is high. And iliofemoral again, because the thrombus occurs near the wall, not that wall. When wall is getting damaged and there is a post-thrombotic syndrome, that causes edema and stasis, again predisposed thrombosis. So repeat ultrasound, Doppler scan is some value, even if it is not, recommended by ACP. And the third question, like the CT angiogram pulmonary, this is usually we are in dilemma after 6 months. Our own relative, whether we have. So I used to follow, individualized, suppose patient is having pulmonary embolism, and we already given thrombolysis and pulmonary pressure not normally. In and around micro more than 40 to 50. You can send the CT angiogram, you can see whether that or constriction, you can see whether it's CT. If it is normal, don't think that is normal. Even subsequent thrombus we can't detect on CT angiogram. So there is no guideline, it's individualized clinical practice.
Dr. Jayaprakash, coming to another important aspect, chronic thromboembolic pulmonary hypertension is increasingly recognized. So a patient coming with pulmonary embolism already could be having some degree of thromboembolic PH already. It may be something like an acute or chronic. That is one aspect. Second aspect, out of the people who present with pulmonary embolism, how often you encounter them going into chronic thromboembolic PH? Can you enlighten us?
Sir, if you look, if you ask me about the patients I'm seeing, the number of CTPH patients may be very less. If you look at the world literature also, it's less than 1% of all the pulmonary embolism. But then there is a definite recommendation that all pulmonary embolism patients after treatment, they should be on follow-up, and at 3 months we have to reevaluate the patient. And during reevaluation, what we look at the symptom of the patient, we look at the echocardiography and see whether the pulmonary hypertension is persisting. If the pulmonary hypertension is persisting, then we may have to go for a CT pulmonary angiogram or a ventilation perfusion scan to see whether there is typical segmental perfusion abnormalities. As he said, when there is an acute on chronic pulmonary embolism, we have to differentiate it from a chronic thromboembolic PH. So chronic thromboembolic PH, by a convention, the standard therapeutic, the diagnostic procedure is a ventilation perfusion scan, a planar ventilation perfusion scan. That perfusion scan showing a segmental defect, perfusion defect, symptoms, pulmonary hypertension, then it is likely to be a chronic thromboembolic PH. And chronic thromboembolic PH, the management differs. Here the patient should be definitely work up for a surgery. If it is a proximal PA, segmental PA, then if discuss with this, just like the heart team, we have a team for the CTPH management. This team discuss with the surgeon, and the surgeon feels that the thrombus is accessible, he should go for a pulmonary thromboendarterectomy. Those thrombi which are inaccessible to the surgeon, balloon pulmonary angioplasty is an option. After all these things, it's a lifelong anticoagulation. And for this matter, actually we don't have a data regarding the use of NOAC in this particular situation. Still, data is with only vitamin K antagonists, but many people, by consensus, they are using NOACs. And the drug therapy, there are two drugs with data. One is riociguat and other is macitentan. These are the two drugs with data.
Okay, so shall
anyway, these people do require follow-up, and it's very important that you do a repeat echo after 3 months or 4 months too, and very carefully look at the TR depth. Sometimes the TR depth may be very, very trivial, but it can pick up significant pH, and ultimately they can do the CTPA and all those things. I think one or two more questions and we will conclude. Dr. Praveen, after 6 months, there's a recommendation that you can reduce the dose of NOAC. Do you agree to that? Rivaroxaban 20 can be made 10.
Yes, I was searching through the literature for this particular aspect. There is now data and recommendations to say that you can continue with a reduced dose of NOAC after 3 to 6 months of initial normal recommended dose, except for specific dosing recommendations for each drug. If you find that there is a first episode of venous thromboembolism, it is like you are not able to find out a cause. It is an unprovoked case of venous thromboembolism, but you deem that the bleeding risk is high and you still need to continue drugs, then two drugs studies are there to show two drugs. That is, one is apixaban at a dose of 2.5 milligram BID and rivaroxaban at a dose of around 10 milligrams OD beyond 3 to 6 months period for continuation and efficacy with a lower risk of bleeding. Except, of course,
But
if
we
the
don't
patient is
have-
obese and all that.
We
Yeah.
don't have much data with dabigatran.
Yeah, we don't have much data with dabigatran. We have data
I think
with.
that is the situation. Okay, now one or two more questions and then we will stop. And now, Dr. Natarajan, any data of pulmonary embolism in the pediatric age group, especially in the use of NOAC?
I was going through the literature to search answer for this particular question. Pulmonary embolism in the pediatric age group is not uncommon. Whereas venous thromboembolism, particularly in sick children who need central venous catheters, etc., the risk is definitely there. So your question was with reference to the data on NOVAC in children, right?
Okay.
That is
Suppose
the
you want to use a prolonged anticoagulation in a child, need not be this even otherwise. Do you think there's a data on
There
NOAC,
is.
or it has to be a vitamin K antagonist?
See, the results of the Einstein Junior trial was published in the Lancet in the end of 2019. That very clearly says that they have compared weight-adjusted doses of rivaroxaban in comparison to vitamin K antagonists, and they found that it is equivalent. With lesser chance of recurrence as well as bleeding, equivalent to warfarin. So you can give weight-adjusted doses of rivaroxaban in preference to
limited
weekend.
data, very limited.
Limited data, that's correct.
And the other aspect is VT in pregnancy. Dr. Ashraf, what will be the safest option?
I can say 3 points, like if DVT and pulmonary embolism is diagnosed, you can hospitalize. You can use unfraction heparin or low molecular weight heparin. Unfraction is category C and category low molecular weight. And both not crosses the placenta. If you patient already mechanical walls and having this problem, you can continue to warfarin provided your warfarin is dose is less than 5 milligram. The terplogen is almost equal to general population. And thrombolysis is reserved for light-threatening thromboembolism with a high risk of fetal distress and maternal hemorrhage. And the choice of thrombectomy only if the DVT involved the idiofemoral or IVC and patient near curve, then only you can use the thrombectomy. Otherwise, as everybody knows, that switch over to all these things are normal only. And one factor is the procoagulant factors are all elevated in pregnancy except factor 11. So it is little bit aggressive in anticoagulation. Now, only choice is which are the already patient had one episode of some thrombosis in the past, and there is no thrombophilia, there is no need of routine anticoagulation for pregnancy. If the patient having thrombophilia risk factor, with a one episode, previous episode, you can give prophylaxis. Otherwise, no need of prophylaxis in a patient. Previous history can cause monotony.
In pregnancy, we have some issues, because we cannot take a CTPA ordinarily because of the risk of radiation. The NOACs, we have no data. I think you have answered that question very nicely. Before we conclude, Dr. Jayaprakash, something about IVC filter. The initial enthusiasm has come down. What is the current status?
Yes, sir, the enthusiasm on IVC filter is dying down, but there are 2 strong indications. Still, there are 2 standard indications. One, if the patient has an absolute contraindication, a patient with proximal DVT, absolute contraindication to anticoagulation therapy. Second, a patient on therapeutic anticoagulation developing recurrence of PE or VT, then there is a role for the IVC filter. Otherwise, there is no role. Basically, in primary prophylaxis, there is no much role for IVC filter.
Okay, thank you. I think we can conclude the session.
And the last, one more question. Any role for antiplatelet? Otherwise, it will not be complete in venous thromboembolism. I think Dr. Praveen can tell that, and we will stop with that.
Yeah, I was also searching the literature for that. There is actually evidence for low dose aspirin. There have been trials in patients of hip replacement elective ortho surgeries. After discharge, they were maintained on low dose aspirin. It was found to be efficacious for venous thromboembolism prevention. Or if there is some role.
Inferior to an antithrombotic.
Yeah, and also beyond 3 to 6 months of initial anticoagulation, some patients where you deem there is a risk for recurrent events, low dose aspirin has been studied with positive results in clinical practice, even though with NOACs, aspirin may no longer have that role actually.
Okay, I think with that we conclude.
Sir,
I think we have not exceeded the time.
Sir, I just add, because all these questions, sir, is prepared. This is fantastic and very practical, and also very, We gained a lot.
Okay.
lot.
Okay.
Thank you, sir.
So we believe that we have not exceeded the time, and all five of us,
Thank you. Thank you, Dr. George
we would like to
Koshi.
thank Dr. Sulfikar
Thank you,
and the team.
travelers. Thank you for
All the
participating in
travelers.
this discussion.
Thank
you all.
Sulfi. Thank you.
We have come to an end of the all formal sessions of CSIK. We had a wonderful 2-day session of the annual conference conducted by Csi Kerala Chapter. On behalf of CSI, I thank all the delegates and faculties for actively participating in the conference and making this a successful event. Thank you all. And I personally thank organizing committee for giving me this opportunity to be a part of CSI. Thank you. Thank you, sir. Thank you all. Thank you, sir.
Thank you. Thank you all for attending this session so completely and staying till the very end. I think Neelima, you require a round of applause for the excellent job she has done over the last 2 days. Great job. Thank you. Now is the time for the annual general body meeting. I request the office bearers to take on the starting of the general body.
I request all the CSI members to be in the hall for attending the general body meeting. Thank you.